parts of the country. So let us begin this, and we'll be having inauguration session later. Just before the coffee break.
Thank you, Dr. Sanitya. I again welcome everybody out here on this Sunday morning, and I thank each and every one for taking out time and attending this particular morning session. So let's start. I think here Dr. Fayaz Menon will be the opening batsman, and before we go on to that, this ensemble is basically a very good combination of the IAS team as well as the NMOA team, and I'm thankful to each and every one who belongs to each of these particular organizations. And I believe that in future more and more things like this will keep on taking place, and the association will grow a bit more stronger every year. Thank you. And may I invite the opening batsman out here, Dr. Fayaz Menon, and he'll be speaking on evolution from open bankcard to arthroscopic bankcard. So to chair this particular session, I request the head of the department of MGM Medical College, Dr. Rahul Kadam, to be on the dais. I request Dr. Kiran Mari, the Vice President of the NMOA, to chair the session as well. Thank you, sir. We don't have a couple of dignitaries from NMOA, Dr. Nitin Matre, who is the President, as well as Dr. Sachin Kale, who is the past President. So we miss these two guys here. And one of the person, Dr. Ashok Ghodke, probably is on the way. So if he joins, that's good enough. So let's wait. Dr. Alvin Vieira, who is the Secretary of the IAS, I believe if he's around, we'll just invite him as well. So let's start with the session. We are running a bit late. Thank you. Dr. Fayaz.
Open bankcard to arthroscopic bankcard is not just the bankcard, but it's all about shoulder stability. So when we talk about shoulder stability, it's not just one particular surgery, but the whole concept that has evolved over the last whole century or maybe about 120-125 years. So the modern history dates back regarding the shoulder instability from 1890 when Roca and Hartman described the first shoulder instability concept and the role of ligaments. 1892 some more shoulder work was done by Bean and his team in terms of shoulder arthroplasty. In 1906 a Perthes machine was described. 1911 some work was done by Corbin, and then
Takaji came up with a Euroscope being put into a few joints like knee in 1918, and then came our hero, that was Bankart, who described Bankart lesion in 1923. Arthroscopy actually predated Takaji. So this surgeon by the name Nordentoft in 1912 actually talked about visualizing the joint.
However, he did not do anything until the 1980s when Takaji started using Euroscope for the arthroscopic purpose. It was very initial time, and Berman in 1931 took Schneider, Burkhardt, as we all know, developed arthroscopy over time, and today, and of course, many metrics across the globe, like Johnny and classification of instability here classified it based on directionality. Matson talked about ambient terms which were either or require surgical. Burkhardt and Fuller worked on bone loss, myelinoid, the concept of myelinoid gland, and Pascal Boyle, of course, ISIS score was developed inside what surgery is done, and Albert came up with this EIT score as score to assess the risk of developing surgery. Now, again, going back to 1906, this is the man on Burgess, George Clemens on Burgess, who described first for physician the allusion of much before what Packard described. Packard described it and operated Packard since 1950. Connolly actually described reverse McLaurin procedure or the transfer of first filters into the exact defect. This is the first procedure what now has been rechristened as Remplissage, what we call. So, but the way we do has changed drastically. Rowe, Warren, Asiro, Kattani also had great results with their surgeries. Now, in arthroscopic repairs, the first came was this Johnson staple, basically instrument maker, and we used the same staple for Packard. I don't know how many of you all use this staple for Packard. I have
teachers, Dr. J. A. Pachure in Bombay Hospital, we've seen this staple being used for Bankart repair. That was open Bankart repair basically. And the same staple was used for fixation of ACL and for the fixation of rotator cuff. By that time, these suture anchors had not come. Then Richard Caspary came up with some procedures to recreate AIGHL via glenoid tunnel and all that stuff. Then he again developed these transglenoid stabilization, and over time for that stabilization he was the one to bring these suture punch instruments, etc. And he showed that there are 96% good results when 6 or more sutures are used, because it involved the capsular shift. Then Mitek came up with suture anchors, and Job used this generation 1 suture anchored for capsulolabral complex repair through the subscapulary split, which was then later on adopted by Savvy and others. Till this time it was difficult because the suture was used was Ethibond, which was earlier said that it is non-breakable, but it actually broke. Till this time what happened was that this knot pusher had not come till Burkhardt came up with this 6th finger, what knot pusher that we use. So it has evolved over time as to how we use. However, still till this time the suture material of fiber wire did not come. Schneider developed Rio screw of titanium which you could put in, and in case there is this suture is broken or something, you can remove it back and all that stuff. It also had its limited success rate. Later on, Schneider himself developed these suture hooks to take the bite through the labral tissue. Then came these absorbable ones, which were this polyglycolic acid and PGLA.
these were basically again the active sutures, rapid absorption over 3 months, was not visible on X-rays and all that stuff, but the sutures still made very good. Then SureTech, that was
PGA staples came. They were fantastic ones, easy to use and easy to put in, but as easy to break as well. So this came and this went away, not much used, but whatever, it still gave some good results because of the inflammation caused due to dissolving of this PGA material. Then there were over time multiple PLA, PGA, composite screws and all these things were used. First it was we need to understand what is bioabsorbable and biocomposite. Bioabsorbables were the one which got absorbed. It only had PLA, PGLA, which got absorbed over time and kept the cyst or fibrous tissue over there. And there was this risk of these post-stem fracture because they were the stress risers. And then these hydroxyapatite was added to it so that there is formation of bone at those times. Then these all suture anchors came. Conmed brought it for the first time, and over time this was taken up by the other players in the industry. Ethibond could take only the weight of or the pressure of 13.2 kgs. Full credit goes to Arthrex for developing fiber wire, because once fiber wire came, then the whole shoulder reconstruction and all those procedures became easy, because now there was some suture material that could actually hold the pressures which were caused because of the tightening of the anchors, and this was real game changer. We also have fiber tapes now which are thicker and which do not cut your fingers, because we all arthroscopy surgeons know that when you take these knots, it at times cuts through your fingers also. Then Rethal invented the first knotless anchor for lazy surgeons like me who did not want to take these knots, and it had been also copied across the industry. Over time, arthroscopy surgeries developed better with better anchor sutures, better portal location. It changed from just bankart repair to a proper shoulder reconstruction surgery, where you took all the aspects of the shoulder instability and tried to address everything. Wilf resurrected the old cannulus procedure as Remplisa, which we do today, which was originally described about a century ago. Now, talking about the bone transfers, again it dates back to 1907 when Eden used this tibial bone graft, Hibonite used ICBG, Noeske first did these coracoid transfer with the sutures. This was very unstable, so Latajet used a single screw for that, and then Bristow helped it. Bristow actually did not do the surgery by himself, but he described and he talked about it. Poinder, of course, Provencher, of course, used this fresh osteochondral graft for the bipolar lesions. Open Latajet first. Trillat did this incomplete coracoid vein. He used the coracoid inferior part of the subscapularis muscle, but Latajet tried it and it used to again keep on breaking, so he used the single screw. Pate was his associate. He said that this doesn't work, we'll use 2 screws instead. He went to the garage, autoclaved 2 screws and then fixed them, and then he said that yes. What today we call Latajet procedure is actually described by Walsh. So this Latajet, what today we do is, this is that those 2 screws in the coracoid and use through subscap split and the CA ligament to reconstruct the anterior inferior glenoid. And this has been the most seen video till date about 2.5 million views on YouMedi. Arthroscopic Latajet developed by Lafosse. Over time he developed much faster, much easier, and standardized the procedure, and now it is being done across the globe. Of course, it's not easy because it uses transglenoid planes, and then Pascal Boileau used button techniques after identification and protection of the axillary and musculocutaneous nerves. The work of Sugaya, Taverna, Wong, Tokish, of course, multiple different techniques, but all of them worked well. Provencher used this fresh osteochondral graft for the glenoids, and it achieved this bench and surgical research. This led to KD award in 2025 recently. This has been a game-changing research. Now these innovative concepts started trickling in. Earlier, Rowe thought that 96.5% are stable by just doing a bankart repair, but Burkhardt and De Beer came with this concept of engaging Hill-Sachs lesions, and then over time Burkhardt, along with I.G. Itoy and Giovanni Di Giacomo, came up with the concept of glenoid track, and that has changed the way we see this particular surgery. So over the last 125 years, this has been a journey just from a simple repair to a complete concept of shoulder stabilization, which we do not know still more what is to come. So it's a journey without destination, but every time we are becoming smarter and smarter. better and better over time. So the key remains picking up the right surgery in a given patient, and that is the art which we need to become an artist to learn this. I conclude my talk with this, with thanks to IAS One and Navi Mumbai Orthopedic Association. Thank you very much.
Thank you so much, Dr. Fayaz then. Yeah. So let me invite the second speaker, who is the Hulk of the Navi Mumbai, and he's been wearing this hat of Pirates of the Caribbean. Dr. Aditya Gunjotikar, please come here.
Good morning, everyone. I'd like to thank Indian Arthroscopy Society, Navi Mumbai Orthopedic Association, Sandeep sir and Nilesh sir for giving me an opportunity to present my talk. I'm here to talk about the glenoid labrum, the anatomy. I'm here to take you back to first year MBBS now. Take your time, sir. इथे नहीं है on the laptop. Okay. So here we go. So the glenoid is an inverted comma-shaped bone. It is concave in cross-section, covered by a hyaline cartilage which is thinner in the center and thicker in the periphery. It articulates with only 25 to 30% of the humeral head in all joints of motion. So it measures 35 millimeters in the vertical dimensions and 25 millimeters in the transverse dimensions. So the glenoid labrum becomes very important. It is basically a fibrocartilaginous ring which covers the rim of the glenoid. It is triangular in cross section and it varies a lot in thickness and height. It can be at times a very prominent free structure, free with a very prominent structure with a free inner margin, and at times it may be completely absent. It is made up of dense fibrous tissue with very few elastic fibers. So there is a lot of variation in the size of the glenoid by itself. The labrum is, the superior labrum is usually the tallest and the thickest, whereas the inferior labrum is usually the one which is a little more rounded and has a more free inner margin. Hi Rahul. Can I get my slides, please? Yeah, thank you. The inferior labrum had a lateral extension which sort of increased the overhang, thereby accommodating and centralizing the humeral head onto the glenoid. The glenoid labrum is described in clock phase directions, described as a clock phase from 0 to 12 o'clock, and it can be described in directions. Originally it was only 4 directions, that is a superior, inferior, anterior, posterior. But now it also includes supero-inferior, antero-inferior, posterior-superior, posterior-inferior. So glenoid is basically glenoid labrum is basically a place where there are interconnections between the glenoid bone itself, the periosteum, the capsule, the cartilage, and the synovium of the glenoid. Synovium of the shoulder, sorry. So there is a lot of varying morphology of the glenoid. It is not uniform. A glenoid itself, various studies have shown the glenoid measures from somewhere between 2 millimeters in a few up to 14 millimeters in others. And also there is an variation among itself for the glenoid as well. The superior labrum is usually, the inferior labrum, is usually the one which is more anatomically consistent. It is rounded in shape and has a lateral extension. The superior labrum is usually more triangular and larger in cross section, probably because of the attachment of the long head of the biceps. And the posterior labrum is inconsistent. At times it may be flat, at times rounded, at times hook shaped, so variable. So there was an article by Hill which basically described the layers of the labrum. There's a superficial layer which is a mesh-like layer which helps in lubrication and reducing friction. There's a middle layer which is made up of loose tissues which sort of supports the deeper layer. And the deeper layer is the main one which has the main collagenous fibers, circumferential oriented, and they function to some extent like the meniscus in the knee joint. Converts the tensile forces into the compressive forces. The labrum attaches to the bone by the similar way a tendon attaches, with those 4 zones. Among these zones, the uncalcified fibrocartilage is the one which is the most important, which resists translation. And this uncalcified fibrocartilage is seen more in the inferior labrum as compared to the superior labrum, thus indicating that the inferior labrum is important related to stability. We all know that. Okay. Now there's a paper in 1994 which described the origin of the biceps from the long head of the biceps from the supraglenoid tubercle. Now basically what they said is that 40 to 60% of the biceps originates from the labrum and not the tubercle. So, and they describe the types of labral attachments onto the types of biceps attachment onto the labrum. The first one is the entirely posterior attachment. The second one is a posterior attachment mainly with extension up to the center. This was the most common one. Third one is the central attachment equal anteriorly and posteriorly. The second most common, and the least common was the anterior biceps attachment. So this was a paper in which they had they compiled 691 arthroscopies, and among those 691 they found 50 patients with biceps labral variants. Now these variants may be a bifid biceps, a split biceps, a discoid biceps, and they realized that patients who have biceps labral variations, biceps attachment variations have more labral pathologies. And they attributed this to the fact that maybe the biceps is a mobile structure that undergoes a lot of load, and that load gets transmitted to the superior labrum. The anterior labrum almost continues as an inferior glenohumeral ligament, the anterior band. And the inferior glenohumeral ligament is attached onto the humeral head around the articular surface near the anatomical neck. It has a superior and inferior band and an intervening axillary pouch. Now these superior and inferior anterior and posterior bands, they originate from the labrum. The anterior band originates from the 2 o'clock to 4 o'clock position, and the posterior band from 7 to 9 o'clock position. Together they form an axillary pouch which tightens during rotations and abduction, maintaining shoulder stability. Now there are multiple labral variants, especially of the superior labrum. There can be a sublabral recess, which is basically a gap between the long biceps attachment and the glenoid bone. Usually you can see it as a small cleft. It is important to differentiate this from a slap lesion. In a slap lesion, you will see a glenoid bone present, whereas in a superior labral recess, sublabral recess, there will be cartilage, as you can see in the photo here. This is not to be repaired. If this is repaired, this may lead to tightening of the shoulder and post-op pain. Then there is a sublabral foramen, where the superior labrum is basically absent from the anterosuperior glenoid. They're usually from 1 o'clock to 3 o'clock position. This has virtually no clinical significance and again does not require a repair. And the third one is a Buford complex, which is basically 3 things. You have got a thick MGHL, absent superior labrum, and the MGHL is directly attached to the biceps insertion. Again, this does not have clinical significance, may increase the pathology, but nothing else needs to be done about it. Now, how does the labrum help? Labrum basically increases shoulder stability by 2 mechanisms. The first one is concavity compression. What the labrum does is it increases the depth of the glenoid socket by almost 50%, thereby increasing concavity. As you can see in the photo to the left, as the spear deepens into the underlying surface, the amount of force required to displace it is on the higher side. Okay, so that is how the labrum helps in providing concavity. There was a study which showed that labrum contributes to 10% of concavity compression, and sectioning the labrum reduces shoulder joint stability by 20%. Second one is the glenoid suction cup. As I mentioned earlier, the cartilage of the glenoid is thinner in the center as compared to the periphery. So the peripheral glenoid is a bit more flexible. The cartilage and the labrum and the capsule, which continues with the glenoid cartilage, basically provides a suction cup which helps to center the humeral head and resist translation. It contributes to around 20 newtons of force, and there are studies which have shown that sectioning the labrum reduces this suction cup. So what is a Bankart repair? We basically do a capsulolabral shift as well as a labral repair to get a so-called bumper at the anterior glenoid. So getting that size of bumper is important to getting the labral height, that is the size of the bumper, is important in post-op stability. As the illustration in the center shows an anatomical repair, Bankart repair and a suboptimal repair. Now the photo arthroscopy picture that you see on the left is a good high raised bumper, whereas the one on the right is not so good of a bumper. So the one on the left is more likely to be stable post-operatively. And this is further backed up by these two studies. This was a Korean study with 50 Bankart repairs. They did a CT arthrogram at around 3 to 6 months post-op and 12 to 18 months post-op. And they measured the labral height as well as the capsular volume. And they had 10 patients who had redislocations or apprehension. And they found that patients who had a decreased labral height and capsular volume at 3 months, early post-operative period, are the ones who failed. All the patients showed a decreased labral height and increased capsular volume at around 18 months, but that was not really associated with instability. So they concluded that initial maintenance of the capsular volume, which directly affects our rehab protocol, is the one which is important for maintaining stability. And this was another paper, another Korean study, where they involved 46 Bankart repairs, and they did a CT arthrogram at 6 months. They measured the size of the labral width, and also the position of the inferior anchor. Patients which had a good labral height and good bumper, especially in the 5 o'clock position, had good outcomes. And patients who had a poor labral height in the lesser positions had a poorer outcome. They had 2 redislocations and 2 patients with apprehension, both of whom had poor labral heights in the 5 o'clock position. So they concluded that maintaining a good labral height is important for maintaining stability. Another thing that they noticed was there were higher the number of dislocations, lesser was the labral height, and poorer were the post-operative outcome scores, even if the patients did not have symptomatic instability. Okay, and that's the end of my talk. Thank you, everyone.
So let me invite the next speaker who is going to solve the matrix here, and his topic is on elbow approach for the shoulder instability. Dr. Rahul Dowri, please.
So, a very good morning. At the outset, I would like to thank IAS and NMOA for giving me this opportunity. Last month it was in Kanpur, and today in our home turf. So it is really a good initiative, reaching out to everyone, and I congratulate IAS for this excellent initiative. So, uncomfortable. So we'll start with the topic. Topic for today is algorithmic approach to shoulder instability. So, as we know, sir has taken us through the history of shoulder instability, and we have been through the anatomy, basic anatomy. But then we have there is a literally soup which is there around shoulder. We have a lot of lesions, we have ever evolving concepts which are coming up, and we have a lot of procedures which have now been added. So shoulder instability is not just a simple Bankards or a remplissage, but we have new concepts, new procedures which are added, and my talk will attempt to help us have a protocol or algorithm by which we can treat all these conditions. So one of the most primary aspect to approach the patient is the patient factors itself. Can we have the slides, please? So, age of the patient, level of activity of the patients, and the nature of sports participation is probably one of the most important concepts, important areas which we have to consider. Also, one of the most important aspect we should consider is the number of dislocations. Now, initially it was considered first dislocation. We should always conserve the patient. I think they really like you. So, first dislocation was supposed to be conserved, but now the recent literature is showing higher rates of dislocation in patients who are conserved. So, they are now suggesting that patients with a significant labral injury and or a Hill Sachs should be operated. So, this is. Now we come to, then we have the anatomic factors. Anatomic factors includes the lesions which are present in and around the shoulder. Most important is the Bankards lesions. These are the essential lesions of shoulder instability. Then you have the capsular laxity and capsular injuries, Hill Sachs lesions, glenoid dysplasia, and bone loss. So these are the factors which you assess, and once you have assessed, then you can take a call of so as to what procedure needs to be done. Of course, physical examination is the most important. You take a detailed history, as I said, the number of dislocations. The first dislocation is very important. The duration since first dislocation, the immobilization and the duration of immobilization after the first dislocation is very important. Also, the patient expectations. So, patient who is in suppose a contact sports player or who is active athlete, you might have to do probably include a plus procedures while treating him, while compared to someone who has a sedentary work and is not into active sports. Then you take special tests. There are load and shift tests, apprehension and relocation tests, shoulder laxity and sulcus tests to assess the amount of instability and generalized ligamentous laxity in the patient. So after this, we come to the radiological test. I will just go through this X-rays. So we have multiple views. Hill Sachs is mainly seen on Grashley and internal rotation views. Body Bankards is best seen on the anteroposterior views. You have the axillary view for the joint congruence and see the relation of the humeral head with the glenoid. And then we have for Hill Sachs, we have the striker notch views and the West Point views. So X-rays primary will be much better. They will give you more information if the dislocations are recurrent and chronic. More important than X-rays are MRIs and CTs. So whenever I advise, it is always MRI with limited CT cuts if necessary of bilateral shoulder. So this is basically to assess the bone loss. You cannot assess bone loss without the CT. Then you have a myriad of soft tissue lesions. It can be Bankards with slap probably. Then you have cuff lesions in elderly. So this MRI becomes the mainstay of investigations. Now that we are armed with all the information, then we decide what to do next. Now it depends on what type of lesions are we facing. Now Bankards is not just one Bankard. You can have any of this. So it can be a simple Bankard, it can be an osseous Bankard, it can be a reverse Bankard, a Perthes lesion, Alpha lesion where you may not be able to see the labrum directly when you are weaving through the posterior portal. You might have to shift to the anterior-superior portal to weave the labrum, or you might have to use a 70-degree slope, and then you have the other glenoid-labral avulsion defects. So again, when we talk about glenoid bone loss, a CT is mandatory. You have multiple methods to calculate the glenoid bone loss. Long-face CT cut, axillary cut shows you the best glenoid surface. you calculate the percentage of glenoid bone loss. Now there is a concept which is evolving that is the critical bone loss. Now when we started, the critical bone loss was supposed to be more than 25%. When everyone say okay, more than 25% go for Latarjet, it has slowly came down to around 20-25%. The recent literature says that glenoid bone loss as less as 13.5% also critical bone loss, and you might have to add a Brony procedure or some plus procedures to tackle that glenoid bone loss. One of the most important concepts is the on-track and off-track glenoid lesion. So I won't go into the details. I think there are talks which will discuss this in details. But in general, on-track glenoid hill sacks, the entire hill sacks remains on the glenoid track throughout the range of motion, while in the off-track, the glenoid track is medialized and goes off the glenoid track. So this is a basic concept. So when we plan for surgery, we have to look for all this. We have a lot of open and as well as arthroscopy procedures. Arthroscopy procedures can be Bankards. We can be Bankards in addition to remplissage. Nowadays we have dynamic anterior stabilization that is coming up for anterior instability. Then we have bone block procedures, bone cerclage procedures, and obviously arthro-Latarjet. In open procedures, we have open Bankards, then we have the putiplat and other soft tissue procedures, and we have Latarjet procedures. So this is in short a flow chart which we can go. So after considering everything, usual glenoid bone loss less than 10%, and patient is usually a sedentary or you can consider a non-dominant hand, we can go for isolated arthroscopic Bankards repair. Around 10 to 20% bone loss, I will again, as the literature is evolving around, I won't go for 20, around 10 to 15. But with other lesions, suppose the other is off-track or engaging hill sacks, probably we'll go for arthroscopic Bankards plus other arthroscopic plus procedures. They can be either double row stabilization or a remplissage procedures. Again, if the patient is an athlete, he is into contact sports or overhead activities, you might consider these procedures even when the bone loss is on the lesser side or if the lesions might be smaller. And more than 20% bone loss, obviously you have to go for a bony procedure. Again, this is not hard and fast. It depends on what the patient has, what the patient demands are, and accordingly you might have to go 15 to 20%. Nowadays we have the bone block procedures which are coming up and are really good. I've had few experiences with this and the patients are really doing well. So maybe with the evolving nature of our procedures and our understanding of the anterior instability, we might do such procedures even for a lesser bone loss and other stability. So to conclude, plan the procedure with respect to the needs of the patient and their expectations. Don't hesitate to get all radiological investigations as per your liking. So many a times you don't have complete details if the lesions are on track, off track. So either you calculate or ask the radiologist to give you all the details, including glenoid bone loss and the hill sacks lesions. Patients with critical bone loss, soft tissue procedures may be inadequate. You have to have a Brony procedure. And routine use of plus procedures, excessive use might actually lead to excessive stiffness or restricted rotation. So try and avoid in unindicated cases. Any doubts or any questions?
Sorry.
Thank you.
Thank you, Dr. Rahul. Let me invite Dr. Jahangir Pestanji for the next lecture, Arms and Ammunitions in the Bankard. His photo has been actually shown in Dr. Rahul's lecture, so I believe. Carry on.
Good morning, everyone. Thank you to Dr. Nilesh sir, Sandeep sir, IAS and NMOA for this wonderful opportunity. Can we start? So I will be talking about arms and ammunition in Bankard surgery. So this is how we feel when we go for surgery. Our arms and our ammunitions. So what all do we need? Let's gear up. Let's talk about the arms. Everything you need for planning and preparation. So what do we need? We need Bissinger rods, we need cannula inserters, cannula, probe, knot pusher, suture cutter, suture retriever, liberators, rasps, and suture passers. So what does Rambo do? Rambo first prepares to approach the target. To approach the target, he needs Vissinger rods, cannula inserters, and cannulas. These are Vissinger rods. These are also known as, they are also used to make entries as well as to shift the portals. They should be blunt so that they don't damage the soft tissues inside. A cannula inserter goes on top of the Vissinger rod, and these are different cannulas of different measurements and diameters. So now Rambo has to engage the target and liberate his hostages. So what does he need? He needs a probe. So these are probes. These probes are measured, so we know the depth at which we are working. These are soft tissue graspers. They are serrated. They can be used to give traction to the soft tissue to see the reduction. Rasps are available in both upwards and downward rasps. These are used to create a good bleeding bony edge at the glenoid. These are liberators, tissue liberators. These are used to liberate the fallen down labrum, the torn labrum from the glenoid. And this is a curette. So this is an arthroscopic curette. Also can be used to remove cartilage before inserting the suture anchors. These are suture retrievers. This is a suture retriever used to shuttle sutures and to retrieve sutures. Now Rambo has to execute the attack. For that, he needs bird beaks, lassos, and direct suture passes. So suture passes can be indirect and direct, or retrograde and antigrade. This is the best example of a retrograde suture passer. These are lassos. They can be straight, 45-degree left curve and 45-degree right curve, most commonly used for Bankart surgery. This is a bird beak. Again, bird beak will be straight, upward, left and right. Bird beaks can be used both as a suture passer as well as a suture retriever. And this is an antigrade suture passer or a direct suture passer. They are available in both ways. That is the disposable types, such as this is a Smith & Nephew example of first pass mini, and then permanent metallic type. So this is a small video which demonstrates how it works. A needle is inserted, disposable needle, and a loop has to be created. The loop is inserted. A good big bite is taken into the tissue. Here they are showing the cuff tissue through which the bite is being taken. And then the suture is pulled out. Now Rambo has to finish the mission. So how does he finish it? He needs a knot pusher, the sixth finger, as Dr. Memon very rightly said, and suture cutter. So this is a knot pusher. The knot pusher, the tip has to be ideally be very blunt so that it does not damage the sutures, it does not damage the threads. And a suture cutter, it can be both an open or a closed suture cutter. Now we've spoken about the shastras, the arms. Now we'll talk about the ammo. So I don't really need to talk much because sir has spoken a lot in detail about suture anchors already in the first talk. So suture anchors for Bankart's repair can be classified either based on material. So they can be metallic, PEEK, bioabsorbable, and all suture. Metallic were preferred earlier. Now they are in elderly where we need a good pull-out strength. Problems were with osteolysis. Then there are PEEK, bioabsorbable sutures which have come in earlier. Bioabsorbable sutures, again the risk was that it could form a cyst and it would pull out and the strength would not be that great, but the newer ones are actually very nice. And then there are all suture anchors which are now in trend. Then they can be double loaded, single loaded depending on what you need in the finances of the patient. And the star right now is knotless, again as I said, for lazy surgeons and newer surgeons like us who are not very good with knot time. So knotless works wonders for us. Certain pictures of different types of suture anchors. These are the suture anchors which are usually used in Bankart's repair. And just like it, that's the end of our Rambo movie. Rambo walking away, all wet and tired. Thank you.
So let me invite Dr. Abhishek Nerurkar, who will be talking on hillside tackling squad. So he is one-man squad for this particular hillside issue, right? Please.
So I thank Indian Arthroscopy Society and the organizers for the opportunity to speak about Hill-Sachs. So Hill-Sachs is a very important part of the anterior-inferior stability, and I'm going to talk about why is it important, what are the decision-making factors, and how you can actually implement and tackle the Hill-Sachs. So all three things in the meantime. So what is anterior-inferior instability? Usually, a lot of times in the initial days of the practice or when the concepts were not evolved, most of the concentration was done on the anterior part, on fixing the bankards, and the posterior part was often avoided or neglected, and because of the lack of knowledge rather, and that lead to a lot of failures in the initial days of arthroscopic bankards. So if you see here, you have a bankard, and you have a posterior component of the anterior-inferior instability, which is the Hill-Sachs defect. So what you need to understand that essentially it is a bipolar defect, and if you try to tackle it only the one component of the bipolar defect, then the failures are going to be more. So when surgeons started understanding the complications and trying to find solutions for the problems, there were two thought processes that evolved. One who started doing letargy for all the patients to prevent failures, and the other group of surgeons who started developing an algorithm regarding how do I tackle the Hill-Sachs or the recurrent instability problem. And if you go through the initial papers, Burkhardt was the one who spoke about the engaging lesions and the non-engaging lesions in the initial days of this practice, and bipolar lesion was the most important thing. And as I said, if you address only one component, then you will have more failures. As we all progressed, we understood that you cannot get, so you can't talk about engaging and non-engaging, because once you have a dislocation, the Hill-Sachs has already engaged. And then the next concepts that evolved were about the on-track and off-track lesions. Nowadays, if you want to justify a Hill-Sachs surgery, then you have to actually speak about whether the glenoid was on-track or off-track, and then you justify your surgery. So we can always discuss this in detail, because it's a long thing to discuss about Hill-Sachs and interval and the glenoid track. What you need to know is that if your glenoid track is more than your Hill-Sachs interval, then it's an on-track lesion, and this is less likely to fail with Bankard's repair. And if your Hill-Sachs interval is more, then it is more likely to fail, and you need to tackle the posterior part or the Hill-Sachs defect along with repair of your Bankard's lesion. So you can do it pre-operatively with your measurement in the CT scan. You can do intraoperatively. There are various ways of doing this and finding out whether you are likely to redislocate this the shoulder after doing the repair. So let me show you an animation, very important animation, in which you see what is happening. You have a Hill-Sachs defect there, and it is actually on track, so it is not engaging. The same amount of defect, if you create more medially, the same defect now becomes engaging or it becomes off track, and that is why calculating this interval becomes very important. This we have already discussed about
when to do what. So another thing is important thing that you need to understand is critical bone loss. When we are talking about critical bone loss, you cannot, there are again multiple papers for that, but you cannot say a single value. The critical bone loss will depend upon what kind of patient you are treating. So if you are treating a housewife, you may have a more critical bone loss. So if you are considering 20%, but if you have a young person who is very active, then the critical bone loss will reduce and you will have to consider 15%. So there is different thought processes about it, but the critical bone loss will reduce. So your threshold is going to be reduced if you want to do secondary lesions, secondary stabilizations, or a bony procedure. So what is a remplissage? It's basically a French word, and it actually means filling the defect. So you are basically trying to convert your off-track lesion to an on-track lesion. It is done by doing capsular tenodesis. So your infraspinatus is the tendon and the capsule, the posterior capsule that is used to fill the defect. And basically what you do is when you convert the off-track to an on-track, you prevent the engagement of this particular bony defect. And that is the thought process behind doing this remplissage procedure. So if you see in today's day and date, there are two different ways by which we are doing this. One is a standard technique in which it's a standard anchor that you put and then you take the knots and push the infraspinatus and the capsule into the defect. There's also a double pulley technique in which you basically make a suture bridge and try to compress the tissue in between these two posts onto the bone, which gives you a better fixation when you are having bigger Hill-Sachs defects. So I am going to show short videos about both the techniques so that you understand what is exactly done. Okay, so let's see the standard technique. So this is the Hill-Sachs defect. You have to clear the defect and expose the bone. Make sure that you don't expose too much of the bone because your anchor purchase will reduce. So just make it fresh so that you can get healing of the tendons or the repair onto your bone. So you can use one anchor, you can use two anchors, you can use single loaded, double loaded. All these configurations are going to be dependent upon what is the depth of the Hill-Sachs, what is the size, the length, and then you can decide what is the best for that particular patient, and you can have all those permutation and combinations. But what is done is that once you put an anchor, you have to, okay, so the pilot hole is done and now the anchor is going in. This is the second anchor. Then you can take your bird beak, you can have your different kinds of suture passing devices which will penetrate the capsule and the infraspinatus tendon. And one limb of this particular thread is passed through the tendon. So this will essentially make a suture bridge. So this can be repeated. So you can do like a mattress kind of a stitches. You can take all 4 bites or you can take 2 bites. Again, all these technical configurations. So once you take your bites and once you finish your bankards, when you pull in, this is how it will look. So all the tissue comes and sits into the defect and converts it to an off-track kind of a defect. So next is the double pulley technique. And so again, you can see this is the Hill-Sachs defect. I'll wait on this. I'll show you what actually is on the outside first. This is, sorry. So outside, what you do is you tie 2 ends of the different threads into the loops and then you pull the loop. So when you do this, the suture passes through one anchor, then over the tissue and then into the second anchor and then it comes out. So once you do that, put 2 anchors here, again on the left side arthroscopic view. So the second anchor is gone in. Here you may not take the bites because your basically your portal acts as a suture tissue bridge, the difference between the 2 portals. And then you start pulling the thread, the tissue is going to be compressed into the defect. This is how it looks from outside. You can see the knots, but nowadays you have skipped doing it. I think most of the surgeons have skipped doing this. And this is how the construct looks after it is completed. So what is more important here is that the clinical radiological assessment is very important. You try to figure out, try to understand the concepts of instability, try to understand what is a bipolar bone loss, keep reading about in the on track, off track kind of lesions, try to understand what is the critical bone loss in your patient, and follow the steps of instability management properly. And in initial days of practice, you should have low threshold for remplissage procedure. Whenever you have a doubt, do it rather than not doing it, because you may save in a recurrent instability and save in a surgery for the patient in the future. Thank you.
One question.
Yeah.
If there is a defect, you would want to put the anchors right at the depth of the defect, or on the articular cartilage side. Like, what is your take given the situation?
So what happens is, again, you have to, if you understand the concept, if you are going into lateral, then you are exposing too much of a bone medially, which may actually be engaged later on. So if the defect is small, you can fill it in the center of the defect. Sometimes the defect is linear, then you need to put one anchor on the top, one anchor at the bottom. Okay, but if you have a wider defect, then probably what you can do is you come more on the medial side. Considering that you have to be very careful, because the screw can then slide off inside your joint. So you be very careful, give it a proper ankle, cover more medially to basically have less chances of re-engagement.
So smaller defects in the depth and larger defects towards the articular cartilage, right? Is that the other factor?
Yeah. So what is your take or other faculties take?
I would
Sanjay.
basically, if you come very close to the cartilage, then you will limit a lot of external rotation. So if you are doing a remplissage, so by remplissage, the infraspinatus will not allow the head to go ahead. So somewhere in between the defect, even if you place an anchor slightly away from the cartilage, it won't allow because 1 centimeter defect you have converted to 5 mm. But if you put your anchors very close to the cartilage, your external rotation will be highly restricted, and that does not come back. So patient might not be happy with the limit of extension. So for a normal sedentary patient, it's okay. But if you are doing it in an athlete, you should try to be as away from the cartilage as possible, because this infraspinatus doesn't stretch out that easily. So that has to be continued. So larger defects, or even for a smaller defect, try to stay as away from the cartilage as possible. It won't allow the head to engage, because that is a concept of that.
I believe it's too short. Although it's at the center of the defect, rather than go away from the cartilage, although it may not serve the purpose also.
So basically, I think we can conclude that you don't have to come too medially, because that is risky, obviously. But whenever you are taking a decision where you're going to place the anchors, if you place it too laterally, you're going to have a problem. So don't do that. Either medial in the center or more medial than the center. That is one thing. And the second thing is, I have seen, there have been quite a lot of differences in terms of the stretching out of the infraspinatus. At least I have seen that a lot of times, all the patient, when you give them proper rehab and do the stretches, they do pretty well. I'm not seeing too much of an external rotation restriction after the remplissage.
Basically, the profile of the patient also matters.
Yes.
So as you rightly said, if it's an athlete, then we need to maybe just remplissage do not do at all. Might have to go in and do some bony procedures. So it all depends upon the profile of the patient as to whether it's just a homemaker or some throwing athlete or something.
Also, we need to differentiate. There is a normal bare area about the defect. If you think that normal bare area is a hillside, then we are not doing the procedure at all. So that differentiation has to be there, which is the hillside and which is the normal bare area which is there below the infraspinatus. It has to be below the normal bare area, but as away from the cartilage as possible. As Dr. said, between center of the defect is ideal.
And Sanjay, I think very important point, because that is why all the people who are learning arthroscopy in initial days should not focus on the MRI, should do a diagnostic round in each and every patient, thinking about trying to understand the anatomy. Because if you keep on doing the same in 50 patients, you'll understand that, okay, this is a bare spot which is there I have seen in my other patients, and then you'll not try to fix there. So doing diagnostic arthroscopy properly in initial days is very important. Don't try to just look at the images of the MRI and try to start your primary surgery immediately.
So I had a few take on this. One is, in my cases, I do dental research in all cases, and we came out with the results which will show that there's no significant external rotation deficit in any of these patients, and the recurrence rate in our patients is very, very, very less. That means it is like 2 in 200. So that is a very good recurrence. That is a good rate we had. The external rotation deficit or the tightness of this patient was only 10 degrees. I do in 10 to 15% patients. So that means to say that, so even if you do a remplissage in all cases, it doesn't matter because you are giving vertebrate stability. Then there is no fixed rule as to how many anchors, where the anchor should be. The idea is that there should be enough of soft tissue sitting onto the dressage bed. That is the idea. If the defect size is, for example, like 1.5 centimeters, maybe one anchor is enough. Otherwise, it's like 2.5 centimeters something, then you can put 2 anchors and span it. The idea of spanning is like you should have enough space between the anchors. And the idea, if you go really close to the cartilage, the chance of penetration to the opposite side is always there because you are coming to the edge of the, if it's like a ball, you're coming to the edge of the ball and more chance of penetration to the opposite side. So I had one particular case which I remember, like because I was really aggressive, I wanted to actually put it towards the edge in one of the cases. So it went in, and then I visualized on the opposite side. Luckily, it was an all-suture anchor. So it went to the opposite side near the subscap. So that is the problem when you put it towards the cartilage. This is my take.
So Ayyappan, because it's a very good point. Because when you are putting too medially, which should not be ideally, okay, too medial. But if you are putting it, you have to angulate it because it's a sphere, and if you are going tangentially, then you are going to have this problem. So the portal might change, or you have to angulate, or you have to purposely tilt the hand so that it doesn't go, it goes into the tissue. But it's difficult.
Yeah.
Most of
the capture of the capsule is more important than the tendon. If you try to come toward the tendon side, as what Sanjay was saying, that definitely there will be a rotation deficit. Otherwise, it doesn't.
Thank you. Any more questions?
Thank you, Dr. Abhishek there. So let me invite Dr. Ayyappan Nair. We'll be talking on the perfect glenoid anchor placement.
Good morning to all respected teachers, senior colleagues, friends, and respected chair. The first time I'm giving a talk in any kind of hat like this, so I really appreciate the effort of Nilesh. It takes really a lot of time, effort, and imagination to come up with this kind of ideas and to execute it. Really, hats off. So, I would, before I start my talk, I would really like to thank all of you because recently there was the Shoulder Society of India's elections, and all of you who are members of SESI have voted for me, and I really thank you for that. And a special thanks to Sandeep Biraris, who put a lot of effort. So we are good friends for a long time, and I feel that in the end of the day, what really matters is like how many good friends you have. So that makes a difference. Thank you so much. So I'll be speaking on the bank card and the proper anchor placement in the bank card. I'm from Manipal Hospitals, Bangalore, and we also run a research center in shoulder surgery in Bangalore. So coming to the bank card, so we should rather know what are the causes of failure of a bank card to correct so that we do a bank card properly. So now, normally what happens is, the most important paper which we have is from Pascal Bodu, who found out about what are the possible causes of failure of bank card. So in this, there are a few takeaways in this paper which were very, very interesting. One was the most important thing, which is the last one in the slide, is basically it tells us that how many number of anchors, less than 3 number of anchors failed, there are more failure chances. Then the second is this anchor, where should the anchor be kept? So if you look at this particular picture, if you keep the anchor to the side, if this anchor is to the side, if the anchor is to the side of the glenoid like this, then the soft tissue comes only till this much. You might not get enough of plication. So anchor should be on top, and the idea is to pull the soft tissue and the labrum back onto the surface. The idea is, one is a bumper. Actually, the bumper does not have any role. What bumper visually gives to us is that there is quite a bit of plication. So more bumper means more plication has happened. So definitely positioning here is very important. Then the other thing is, how much of plication is to be done? You need to do definitely adequate plication, and in some cases, for example, you have significant ligament laxity, you might require more plication. You might require a double row fixation. All that is important for fixation. And how we mobilize is also very important. And the IGHL is the key to the anterior stability. That means the most important anchor here is the 5 o'clock anchor or the 4:30 anchor, because that is anchor which actually pulls up all the tissues. So I will go through the videos and run through the video and tell how I do it and what I feel is important. Normally my visualization always from the trans cup code. The trans cup code, I normally put it, if this is the biceps, so my entry is somewhere here. You can see that. And it is always in the muscle bed, muscle belly of the supraspine. It is dialed into a tendon. So this gives me a proper access to the posterior as well as the anterior. It gives me an entire visualization in the front of the shoulder. We published this where we looked at the healing of the stance cup code, and it was very safe and healed well. So then, coming to the tissue plication. So for example, you might have a very bad abscillation where you can't see any tissue at all. You can see the tissue here, and the tissues could be quite bad. So it is adequate release going all the way along the glenoid surface, and visualization from an anterior-superior port is very, very important. So you have to release it, we have to release it all the way till around 6:30 position. This is very important, 6:30 position, because the IGHL attaches up to around 5:30 to 6 o'clock position. So we need, if you are planning a capsular shift, where you are planning to shift the capsule from there to here, we need to release it all the way, because tissue can be scarred up till there. So we need to do that. And another very important thing is, how we elevate it, how we mobilize this capsule is very important, because you need to really put the elevator and go under the capsule and elevate it from the subscap. So that lift is very important. We should do it till the subscap is properly visualized. And one more important thing is, if you don't separate the capsule from the subscap by lifting it like that, when you go do a catch or pass a lasso, there is even a chance of accident or injury. So you can see that. So this is a mobilization which normally I do. The tricks for visualization is, my visualization is always from an anterior-superior port. You can adjust the light source 12 o'clock or 6 o'clock, keep on adjusting till you go there. And then the most important thing is, if you want to visualize this area, so you can always even try to dislocate the shoulder. If you want to visualize the 6 o'clock or the 6:30, sometimes it's not visualized possible from the front. So what you do is, you dislocate the shoulder, then you can see the 6:30 position elevated. And when you want to visualize the anterior, then you relocate the shoulder. These are two things which you can do. So this is my video on the bank card. So I thought I will run the video along and then tell my logic of bank card anchor placement. So I always elevate it all the way here till this much. See, our normal labrum is here. So we need to elevate it till here, and sometimes it is difficult to find the soft tissues here. So what you do is, if you can go to the 6:30 or a 6 o'clock position, and then from the normal labrum, if you can elevate it, then you should be able to find that labrum. So here again, the first anchor is at 6 o'clock. It is always a knotless anchor which I put there. So now, or I could always use an all switcher anchor. I'll tell you why the all switcher anchor is important in today's scenario. And then, so that is a knotless at 6 o'clock. Next is at 5 o'clock. I'm using tape anchors. The importance of this knotless or the all switcher anchor is that the angle of insertion should be maximum 90 degrees. I'll show you a paper on that, why this 90 degrees is important. So you can always go for certain companies which have angle guides for insertion. So one, you can see this 6 o'clock. It is easy to insert a 6 o'clock from posterior. I go from posterior. And then again, you can see this is on the glenoid surface. I'm using tape anchors in 5 o'clock position especially. Tape again, importance of tape is that it helps in tissue plication more tissue plication, cut through chances are less. Pull out chances of, if you have double loaded has lesser pull out chances than a single loaded. A tape has lesser chances than a wire anchor. So this is the construct. So I'll just hold this once. So I'll just go through this again. So what I was trying to tell you is that elevation is the key to success in the bank art. You have to release till 6:30, 7 o'clock position. Only then you can get the entire shift here. We have to start the elevation from 6:30 down, then go again like this. Lift the capsule from the subscap is very important. Only then you get the adequate plication and the IGHL comes on. And the 6 o'clock anchor, once you put 6 o'clock, the plication is at 7. The most important anchor in the success of a bank art is the 5 o'clock anchor. Here, always we try to do a maximum plication by going deeper inside and taking a bite, and IGHL should be really tightened in this position. This anchor alone is enough to fix the entire shoulder, this 5 o'clock anchor. Then, I prefer to use all switcher anchor because metal solid anchors, you can have, suppose it cuts out, it comes out. So you have hardware irritation. Hardware irritation is 0. Then, if you don't want a pull out in the all switcher anchor, put it on the glenoid face, put it maximum 90 degrees, always use a guided anchor or a guided sleeve which give you a direct penetration. Then, the tape anchors have better pull-in, lesser cutout chances, more tissue plication. Then, minimum 3 anchors is required. I can come all the way up. So this is my bank art. This is the knotless again. So just want to show you, this has been put from posterior. It gives you excellent positioning here in the posterior. And the plication you can see coming in like that. So it gives you an excellent plication. So if you have a anchor pull out, how do you manage? It is easy to manage an all switcher anchor pull out. For example, this pulled out for me. So what I did was, I've already passed the sutures. You can see the anchor is pulled out like that. So what I did was, I used the already passed, it is already passed with the IGHL and the capsular complex. You can always put a push lock and put back in. Then when you compare, this is my last very important slide, to compare the all switcher with the solid anchors. So this is why the vertical insertion is more important. The dead man theory does not apply to the all switcher anchor. When you put it at 45 degrees, you can see there's an oval hole. Here there's a circular hole. That means more bone defect. Here, the all switcher anchor holds on to the cortex. The cortex is the key there. So if you have a wider cortical hole, more chance of pull out. Smaller cortical hole, lesser chance of pull out. So when you're using all switcher anchor, put it straight. So this is basically shows that the defect size is much lesser when you use all switcher and in straight. So that's why again, dead man theory does not apply here. And one more important thing is, if you try to do 45 degrees, there is the windshield wiper. It keeps on moving and it eventually becomes loose over a period of time. And you can have cyst formation. And this is again a very important slide. You can see all switcher anchor has the minimum cortical diameter. Minimum. And you can see the volume of bone which is affected is very less compared to all the other anchors. So in summary, I prefer all switcher anchors. Tapes more than wires. And insertion should be possibly at maximum 90 degrees. Keep it on the glenoid face are the takeaways in bank art and anchors. Thank you so much.
Thank you, sir. Any questions? Okay, so let's move on to the next talk. Dr. Aditya Pavaskar, good friend, is going to talk on glenoid and labrum, although there is a bit of overlap, but I believe we'll have new things to learn as well.
So I'd like to start off by thanking the organizers, good friend Dr. Nilesh, IAS and NMOA. Well, Ayyappan has just made my task easier. There's a lot that he did cover, but like one of my teachers says that the more times you see and do something, the stronger it gets imprinted in the mind. Well, I don't know how Nilesh chose me as in the role of a gladiator, but that's an all-time favorite. I've seen that movie 5 times in the theatre, and most of the dialogues are still by heart. So like Maximus would say, what we do in life echoes in eternity. In Banker's surgery, what we do in the glenoid echoes in stability. There's just a humorous take on that. So what's the battlefield over here? It's firstly understanding the Bankart lesion, which I think everyone must have understood by now. So the glenoid labrum forms the shoulder's rim of stability. So imagine having a shield, and if that shield is broken, so that's the glenoid. The labrum forms the rim of the glenoid. The Bankart defect is basically a tear of that rim, and what we're trying to do is, to refix that. So restoring that anatomical shield around the glenoid. So why does the preparation matter? So inadequate preparation leads to poor healing. So you may have done the best Bankart repair, good anchors placed, nice, good bumper, but if there's no healing bed, chances of failure are high. So what are our goals? First is to mobilize the labrum, and the second is to create a bleeding bone surface for labral healing. So freeing up the labrum, so we have 2 designs of the tissue liberator. So one is the upward and the other is the downwards. So you can use either. Typically on the neck I would use the upward, and then when I go around 6 o'clock I use the downward. So we need to liberate the labrum completely from the neck, and like again Ayyappan said, 6 o'clock to 6:30. Sometimes if you find that as you slide your liberator down to 6, you may be able to even go up to 6:30 or 7, which is very helpful where it comes to the capsular shift. And at the end of your liberation, you should be able to hold that tissue and see that it is coming back onto the face of the glenoid. So here I am in viewing portal is the antero-superior one, the working is the antero-inferior one. Here I am using the downward because I am now at around the 6 o'clock position. You may ask your assistant, so sometimes when you are releasing it, you may find that there is a stop, a hard stop. That's where the labrum may be adhered to the glenoid, and you may just ask your assistant to lightly tap on the mallet to release it. So when do you know that you've done a good release is you see that the labrum has started floating, it actually obstructs the field, and once you hold it with your suture retriever or grasper, you're able to easily pull it to the edge of the glenoid. The next is the glenoid preparation. So removing the fibrous tissue, removing any of the cartilage remnants from the edge of the glenoid, because you want the anchors on the face. You should be, so if you stop your water flow, you should be able to see some punctate bleeding from the neck. And not to be too overzealous in trying to remove the bone from the glenoid. So don't create a defect over there. So after after we've liberated the labrum, I usually start off with either a rasp or the shaver. So use the shaver in reverse mode, and suction should be off intermittently as you start seeing these snowflakes, or that's the fibrous tissue or cartilage remnants. You can just turn on the suction and then put it off again. So once you're happy, you start seeing some bone on the anterior glenoid. What I also do then is to use a ring curette like so. The ring curette is very effective because sometimes the shaver doesn't get off all the tissues, and especially when it comes to taking the cartilage just off the edge like I'm doing here. The ring curette seems to be more effective. I don't use an RF for Bankart surgery. So what are you aiming for over here is one, the face, which should be completely bare. You should see some punctate bleeding. And just at the edge, you should have taken off the excess cartilage, not too much, not too onto the face. So that is where your anchors would be put in, and that's where your that's providing the healing surface for our labrum. So finally, just clearing out the remaining cartilage and the fibrous tissue. So at the end of it, this is what you should see. So a good bony surface, and you can see the fibers of the subscapularis. If you can see that, that's an ideal preparation of the labrum as well as the glenoid that you've done. So to conclude, I mean, just preparation defines victory in battles and in surgery. So surgeries are something like a battle, and if you're prepared in the mind, and then once you're in the field, especially in Bankart repair, preparing the bed is essential in getting a fantastic result in your Bankart repair. Thanks.
Thank you, Dr. Aditya. Dr. Ayappan. Sorry. So, just before we break for tea, Dr. Ayappan is going to talk on ankle pullouts, poor tissue, and medialization in Bankart repair, in case if you have. No worries. Let's plan a bit differently. Let's do it after our tea break. And before we break for tea, let's have a very small lamp lighting ceremony here, out here. And I'll advise a couple of dignitaries as well. So. May I invite Dr. Ayappan as well here, Dr. Prashant Meshram, Dr. Naved, please. Dr. Rahul Kadam and Dr. Kiran Mari, please wait. And last but not the least, Dr. Biraris. Sir, please come, sir. One of sir. It's okay, sir, please. Sir, please start. Thank you for everything, sir. Thank you so much. Mr. Nisa,
Look here, smile at me. One more.
thank you all the dignitaries. Thank you so much. Can we have the videos, Dr. Arumugam and Dr. Desai? Once we are through with this, we'll break for tea.
Any other parts of the world. I think this registry will help us understand the trends of ligament surgeries that are happening in India and help us in bettering our outcomes in the long run.
Becoming an IAS member, you can apply for these prestigious fellowships and gain unparalleled exposure and experience. Moreover, we have expanded the number of IAS. Dear colleagues, it's my pleasure to welcome. Dear colleagues, it's my pleasure to welcome you all to the IAS One program. The presidential theme of the Indian Arthroscopy Society this year is Bridging Boundaries. With this vision, IAS is committed to bringing. Dear colleagues, it's my pleasure to welcome you all to the IAS One program. The presidential theme of the Indian Arthroscopy Society this year is Bridging Boundaries. With this vision, IAS is committed to bringing arthroscopy to every corner of India, ensuring that arthroscopic surgery is accessible to all. The IAS One initiative was conceived to realize this ambitious goal. Today, I also wish to encourage our young surgeons to join the IAS family. Membership in IAS comes with multitude of benefits that are invaluable for your professional growth. As a life member, you will gain access to your own personal digital secure logbook, which is the IAS registry. Our knee registry is among the best globally, and we are soon launching the shoulder registry. Additionally, we have significantly increased the number of IAS inland and foreign fellowships. These fellowships provide an exceptional opportunity for members to enhance their skills and knowledge. By becoming an IAS member, you can apply for these prestigious fellowships and gain unparalleled exposure and experience. Moreover, we have expanded the number of IAS accredited training centers across the country. This ensures that high quality training is available to you at a location convenient for you, thereby supporting your continuous professional development. As you engage in today's program, I wish you a day filled with rich learning experiences, vibrant interactions, and of course, a bit of fun. I extend my thanks and appreciation to the organizing team for conducting this IAS One program. Long live IAS. Jai Hind.
We all know that the number of ligament surgeries being done in this country outnumber that in many other parts of the world. I think this registry will help us understand the trends of ligament surgeries that are happening in India and help us in bettering our outcomes in the long run. The Indian Ligament Registry will help Indian surgeons showcase their work on the world stage. Dr. Armugam and his team needs to be complimented for the exemplary work that they have done for the Indian Arthroscopy Society. By setting up the ligament registry, I think they have notched up the game by a couple of points. I again compliment
the IAS for setting up the Indian ligament convention.
break? Yeah? Okay. So next in line is Dr. Naved Ahmed. A real-life demonstration on Bankart and remplissage, all those knowledge that we have gained in the morning. So let us see Dr. Naved Ahmed live, real-live. Yes, yes, indeed. Umera. Yeah.
Can I have a pointer, please? And my slides, please. So, a very good morning to all of you. At the outset, I would like to thank IAS. Dr. Nilesh, Dr. Sandeep, and all the organizing committee of this IAS Connect. My name is Dr. Naved Ahmed. I am an orthopedic surgeon from Nagpur, a knee and shoulder specialist. So today I will be talking about the relive surgery on Bankart. So it's actually a revision relive now because we have seen so much of Bankart in the last 3 or 4 talks. So it's going to be a revision again. So the position is lateral decubitus for me. The arm is in 4 kg of traction, 30 degrees abduction and forward flexion. I put an axillary roll in the axilla, and I always do surface marking of the anatomy and portals. Instruments, Dr. Jahangir has told you very nicely, so we'll skip that. But the most important instrument, according to me, is the 18-gauge spinal needle. So this is a young male, left shoulder antero-inferior instability with an off-track Hill-Sachs lesion. These are the portals which you require: the posterior portal, an antero-superior portal, and an antero-inferior portal. The steps that we go through in a Bankart are a diagnostic round, assessment of the Bankart and the Hill-Sachs lesion. Then we follow through with the remplissage steps, except for the knot tying. Then we do a liberation of the capsulocerebral tissue from the glenoid neck. Then we prepare the glenoid, and then Bankart repair with anchors, and then remplissage, the knot tying of the remplissage, and then a critical assessment of your repair. So left shoulder, this is a dry arthroscopy seen from the posterior portal. So you can see that there was a Bankart lesion in the anterior part. This is the Hill-Sachs lesion over there. It's a huge Hill-Sachs. So this is the anterior superior portal. So make sure that you can go anterior and posterior to the long head of biceps. And then putting a single rod, dilate the portal, and then put in a 6 mm cannula. And then with the probe, assess the Bankart lesion. So here it's from 2 o'clock to say like 6 o'clock position. There is a Bankart lesion in this patient. Then once you've confirmed the diagnosis, this is the antero-inferior portal. Make sure with the spinal needle you're able to address the 6 o'clock position as well. Again, the same steps, the single rod dilator, and an 8 mm cannula over there. So this is how it should look. Your 2 cannulas on the face of the glenoid. Then you shift the viewing portal to the antero-superior portal, and then again put a cannula, an 8 mm cannula through the posterior portal. So this gives you a direct attack, line of attack to the Hill-Sachs. Now remove all the fibrous tissue from the Hill-Sachs lesion, create biology, create these pinpoint bleeding so that the tissue sticks onto that. And then this is the pilot hole for the anchor. This is a peak anchor going in, a double loaded anchor. Now the different thing I do is I don't use a bird beak, I use a 18-gauge spinal needle, and then through that I put in a ethylon number 1, because I believe the bird beak causes a lot of tissue damage. So this is I do it to reduce the damage to the tissues. So the 18-gauge spinal needle comes in. So I put 4 strands at 2, 5, 7 and 10 o'clock position. I pass the ethylon number 1 from the spinal needle, and then through the cannula I take a grasper, pull out that needle out of the body,
and then pull this relay suture outside and then pass one of the sutures and pull it outside. So this is how I can pass 4 sutures and with minimal tissue damage, and I have a good hold of the tissue over there. Then you shift your attention to the Bankart repair. So assess the Bankart. So you see it's like Alpsa lesion, everything is fallen down there on the anterior glenoid neck. Next step is to liberate the tissue very slowly without damaging the tissue. You have to go into the interface between the bone and the tissue. Do not go into the bone, do not go into the tissue. Go very slowly, gentle hammers if you want. Go to the inferior extent and maybe a centimeter more so that you can do a good capsular shift if required. Then you assess whether you have done a good release or not. That is, if your capsule and your labrum is coming onto the neck or not. If you haven't, you go ahead, do more. Then you start preparing the glenoid anterior wall. So that can be done with a curette, with a shaver. I use a rasp as well. And you have to see the subscap fibers as has been told before. So this is a rasp going in. And this is the most important step because you need to create biology. Otherwise, how much ever good you do the Bankart, it will fail. You need biology on your side. I don't, so you need to see some bleeding over there. I don't remove the cartilage off the glenoid face. That's my first anchor. It's at the 530. I always use all suture anchors. Your sleeve should be tapped into the cartilage so that it does not move. You drill for the anchor till the stop, and then make sure that someone is ready with the anchor so that you don't lose this position, and then you tap slowly. Make sure that you're going in the same trajectory. Sometimes the trajectory changes and the anchor fails. Now, once your inserter is out, you pull the anchor so that it forms a ball underneath the cortex and holds well. And then there are multiple ways of passing sutures through the tissue. You take one of the suture into the posterior portal, and then I believe this is the best device. It's called a spectrum device, and it allows you to take a lot of good tissue from the inferior part. Make sure you're going distal. If not, you can also come from the posterior portal for this one. And then again, the same way you relay a number 1 ethylon through that, through the posterior portal, and then pass this suture through the tissue. And then whatever knot you're comfortable with, you can pass a sliding knot and then about 4 or 5 half inches on top of that. Make sure that the knot is on the tissue side and not on the glenoid side. So you can see that bumper effect coming in. Even if you don't get it, that's fine. The bumper effect is not important. What is important that you should have a good tissue which is come to the glenoid surface. So similarly, I've done a couple of more anchors, and this is maybe a 2 o'clock or a 2:30 anchor. So this is a double loaded anchor. Again, same steps to be performed. And whilst you're pulling this, be a little careful. Sometimes these get entangled, so be very slow. I was fortunate this does not get entangled, otherwise we'll have to use a suture manipulator to unentangle the sutures. And that's a nice Bankart repair done. And once that is done, you shift your focus again to the remplissage. You have to tie that. So tie the inferior ones first. So the blue ones go first. And I usually stop the flow of saline and do it under dry arthroscopy. So you see that the tissue comes and sits into that Hill-Sachs region nicely. Then you tie the superior one. So you see that's the Hill-Sachs fill there, and all that tissue is nicely come up and sitting into the Hill-Sachs region, making it a non-engaging one. So that's that, and that's the Bankart repair. Thank you so much.
Any questions? It's an interesting technique with respect to you passing in the needle. So when you close that particular, all those sutures for the Rempli, even your portal is going to get closed if you place your needle just like on the four corners of that. So it's an interesting.
So I showed this in Raipur as well 2 weeks back, Chhattisgarh arthroscopy conference, and they also were like, we did not think of this. So it's a very neat idea, and it takes hardly 5 minutes more.
Thank you.
Thank you.
Yeah, one question.
You pass that needle through a cannula?
No, so it's outside the cannula, and once it's...
But then you are going through a deltoid. Yeah.
Once your Bankart is done, what you do is you move those sutures into the subacute space.
And then go from the top and tie.
Next, we are just clearing the backlog. Dr. Ayappan Nair will be talking on anchor pullouts, poor tissue, and medialization in case if you need in a Bankart repair.
Thank you so much, Nilesh. So, my talk is on, I covered some part of this talk in the earlier part where I mentioned about medialization. So, our anchor has to be on the glenoid surface. That's number one. Then coming to medialization, there are two takes now. It's very interesting to know that. So now, earlier, the thought process is that when we take the 2 millimeter of cartilage away from the glenoid surface, it gives a bony bed for soft tissue to heal onto and also helps in the plication. But very recent study, 2024 study has come out, that actually reduces the surface area, and maybe that's not a good thought. So there are two takes on the medialization. But still, I would take 2 millimeter of cartilage away, and I would definitely medialize. That is what I do on a regular basis. I already showed a video about management of anchor pull-out. But now mainly I'll be talking about a very important thing in our practice, which is basically soft tissue insufficiency or extreme soft tissue laxity when we're doing a Bankart. So now, the first thing is to achieve the capsular shift. So capsular shift, so we had published this technique of capsular shift with antegrade suture passer. So here, if you can see, it is on the glenoid face. Second is the complete elevation, and see where the anchor is put. The anchor is put not at 6 o'clock, it is at 5 o'clock, little more away. And see where the bite is taken. The bite is taken with the scorpion and going all the way down. That shift the capsula. And before that, elevation and release till 7 o'clock is also very important. So this is important. The placement of the anchor at 5 is important, and the deeper bite will help you in the capsular application. That is the first thing which I would like to say. Then, always a double row. We can always put a push lock and additionally put onto it. So we had this particular technique. So this is a most recent technique which we are publishing now. So we had a very interesting case. So if you can look through the video, you can see that the patient looks like a straightforward Bankart repair types. So I did a template, and then the patient, you can see that it is a proper ALPSA. The tissue has gone down all the way. So I released it, put my 6 o'clock anchor, normally how I do, and then I kept coming up. It was an ALPSA with the tissue gone down all the way. Now, see how when I'm taking a scorpion bite, in spite of that, the IGHL is not tightening up. The tissue is so lax. It's so very lax. So that's when I came out with this technique with, if we can, so I'll just go back and try to tell you what I try to do there. We call this the Nair Khan technique because okay, me and Dr. Prince Chanavaz, okay, we write the papers together and see, this is what we did. In extreme hyperlaxity, when the tissue is kind of very, very lax, so here I've done there are two limbs to the anchor. So we have, so it could be a, this is one limb of the anchor.
This is the second one. This one limb, you go around to make one pass, so the tissue rolls around. Take one more pass, it again rolls around. And you can do it till how much ever it tightens and coils up. And this again, this limb has to be passed through the,
again, it should not be coiled up, it should be passing through the soft tissue like a mattress. So I'll just repeat it. First you keep this one free, the second limb you keep coiling, pass again, pass again, pass again, out. And this again pass like this. This rolls up the entire tissue and we were able to get a very nice tight thing. I'll just show how this is done. So this is my first pass. Okay, just pass it again. First pass like that, and so you can see tissue is so lax. So this is, and how do we know it is lax? Okay, one tissue is stretched out, and the shoulder and the head continues to be subluxated. See how much of laxity is that the tissue is actually coming onto the other side of the glenoid. So you pass it, and then with the elastic again you pass it through. You pass it again, so it goes in round and round, it's like a coil. So this is the coil. As you can see, the second part of the coil now, the other thread also I've taken like that. So this actually gave a very nice plication. We're able to completely tighten this. So this. Subscap augmentation. So next is the DAS, dynamic anti-destabilization. So we know about the DAS. So this is again a very interesting patient. So patient, 35-year-old, 5 dislocations. The patient came to me. So I did a Bankart. So I'll just show how it is. So it is very interesting. So I thought I could definitely do a repair here. I was 100% sure. Because there is nothing telling me that this patient will have an issue. But here, once I started doing it, after the anchor placements, so my remplissage is done, and from this point it becomes very interesting. So I'm medializing it. You can see I'm putting the anchors in place. My 6 o'clock anchor, then I'm coming to my 5 o'clock anchor, and then I'm in trouble. The tissue is not approximating. There's nothing in this patient which tells me, because my release was good. I've done a very nice release, capsule is elevated, whatever it is, the tissue is not approximating. You can see the gap there, this is the gap. So how do I go about this? So here, I did a DAS technique, you can see the head is still subluxed. The end point of the Bankart should be, the head should be centered. So here what I did was, I did the dynamic anti-stabilization. Okay, I cut out the biceps, took a suture in the biceps, took it out to the subacromial space and made a rent in the subscap and came through the subscap and left 2 centimeters of the biceps inside the joint. I'll just show how it was done. So this is the long of the bicep being released in the subacromial space, and so coming through the subscap, a trans subscap window is made, subscap split is done, and then this is what we did. So I pulled the biceps into the joint, and it will come to the sport now. And I have another, so this is 2 marks. This is at the tip of the biceps, the another is at around 2 centimeters. So here, this particular point, okay, I put it with the swipe lock, I fix it off. The moment you do the DAS, you fix, the hand will become centered. And the tissue tension of tissue immediately reduces, so that the tissue start approximating. So the swipe lock is holding it in place. And then, and from this point you can see, that the head is already centered now. The tissue you can see that's come closer. So that's the beauty of the DAS. The moment you have the DAS sitting in, the DAS actually brings the biceps, brings the head back to the posterior, and it's centered. It's already centered. The moment you put it is centered. Then this extra biceps, what I've done is done a label reconstruction. So this has been previously described, the label reconstruction. So this is what I thought, okay. Otherwise I was not prepared for the Lataje. I could not, 100% I know that this is going to heal. So you can see we came up with a nice label reconstruction and with the DAS. This is another technique in soft tissue insufficiency. DAS can be done in different techniques. So we published a paper on trans-osseous where we did an ACL tightrope and flipped the button on the opposite side. This is one way of doing it. So shortage of time I'm not showing. Then another thing which we came up with is the dynamic anti-stabilization is so with the biceps, the other end of the biceps free. So we found out with a study, FEM study, which got published, and what we came out, we found the isometric points of the IGHL. Isometric points of the IGHL. We always have isometric point for the MCL. We know for the LC, we know from the knee, we know that's an isometric point. The question was that, why is that there's no isometric point for the shoulder which could actually be a proper restraint for us? Why can't we do an anatomical reconstruction of the IGHL? And why is that we have to do a Lataje or something? That was the thought process behind it. So we did this particular study, very interesting. We came out with the study that the glenoid, the IGHL isometric points are on the glenoid 3 o'clock, on the humerus 7:30. This is the position. If we can fix it with some structure, so we thought, what is the nearest structure which is there? The biceps. It is very interesting to see that the tissue quality or the elastic properties of the biceps is quite a bit similar to the IGHL. We took the biceps, instead of doing the DAS, we fixed it at the 7:30 position. So this is a cadaver study. We have done simulation as well, but not been done in a patient because we need more studies on it. So this is a concept. So it is, instead of the dynamic anti-stabilization, you have the static anti-stabilization with IGHL reconstruction with isometric points. So this is again, then your go-to for, in such a case, you have soft tissue insufficiency. This is a revision scenario. You can see the patient came with a primary Bankart. This 2 times failed Bankart. The tissue quality is very bad. So what is your go-to answer in a revision scenario? You should always be the Lataje. Because the Lataje gives you, so if you try to do a revision Bankart, the failure rate is 50%. And so the gold standard is always a Lataje. So here I did a arthroscopic Lataje, and this is because I was well prepared in this scenario, and did a Lataje and the pin came out well. Arthroscopic Lataje. You can see the soft tissue quality. So Lataje is an answer. So subscap release and the coracoid fixation. And lastly, the last bony block procedure, especially in hyperlax cases, is the trilad procedure. If you look at the original paper of Pascal Boileau with the recommendation of the IAS scoring system, the trilad. What is the trilad? You don't split the subscap. You cut the coracoid and put it exactly here in this position. That is a go-to procedure for in hyperlaxity. So in summary, we have a lot of procedures, soft tissue as well as bony procedures. You choose on all these cases, revision scenarios, soft tissue laxity. There are multiple ways of doing it, and as a surgeon, we can take a call on what is the best available towards that particular one. Thank you so much.
Can you elaborate on the subscapularis tendon augmentation?
Yeah.
How much and in what position that you want to do it for that particular?
I don't regularly do it. So why? Because I'm actually rather against it. Why? Because once I feel that definitely there could be an interrotation weakness could be there in this patient. This patient could be having a long-term externalization deficit. But when you looked at papers, biomechanical papers, oddly, there's not much of externalization deficit. Possibly the subscap is very, very forgiving. But I would definitely fix in a neutral position. And just like how we do a replacement, I would do in a neutral position. But I have not done it. So because I don't believe in it. And second is, whenever we are constraining the joint more, there is a more chance of arthritis and developing in the future. So that's why I don't want to disturb the mechanics. So I don't do it. But ideally it is described in neutral and like this.
And that 7:30 position on the humerus.
Is it?
So it's at the back. So you are putting it from the
No,
back.
so if the head of humerus is like this is the anterior position. So you can see 6, 7, 7:30.
So you go reverse on the humerus.
So yeah, reverse on the humerus, basically from knee to up. So 7:30. We found that even that particular position, patient did not have the cadaver. We did a cadaver also. There was no external deficit, and it was holding. The idea is we use the biceps for the routing, and the simulation was also done in the biceps. So beyond that, if you put at 8 o'clock, biceps will break. There will be movement restriction. If you put at 6:30, it will not be sufficient. So ideal position was 7:30.
And that took into account the dynamic translation of the
Yes. And so the shoulder was the most stable without rotation deficits, and that's what it was.
Hi, sir. Excellent ideas. Thank you so much. One thing is, I'm trying to get convinced that DAS is one of the procedures we should do, and I'm trying to incorporate in my practice. One thing is that what you said, that you have additional anchor which you put in your static stabilization model, in which you put it on the humeral surface.
Yeah.
So I know you have done only cadaveric studies for that.
And the simulations.
Thinking about it, if you do your external rotation or internal rotation, does not that restrict it? Because, and we can say it stretches out, but if you want to stretch that out, won't that pull off your glenoid anchor and put a stress on that? So what do you think about that?
Because that's what the idea of the study was. We did in the cadaver, we didn't find out any pull out at all. So when we did this paper, it was like we saw a lot to go to failure, or how much it is. So the biceps acts almost like the IGHL because the elasticity values are the same. So if the IGHL doesn't fail, it should technically hold how much of an IGHL does. That is the idea.
Because IGHL is a ligament.
Right.
And biceps is a tendon. So I think.
But the properties of that is almost same. If you look at we looked at biomechanics studies. So I'll share this paper with you. So it shows that elasticity is almost same as the IGHL. That is the idea of taking the biceps instead of taking an IGHL instead of taking a facial at etc.
Yeah, it's interesting. Like when you do it, and we'll look forward to when you publish the results. The second thing is the coiling thing. I think that's interesting. But why not to just do a mattress?
I did the mattress. The first anchor at 5 o'clock was a mattress. It didn't come. I didn't have a choice. So I'm a mattress guy. So I always do the mattress. Especially my 5 o'clock anchor, the first pass is always the tape and the mattress. So that should have held it. Or I would have taken the mattress and double load also. That's also not working. So you saw that I have not seen a case like this. I was really stuck because the soft tissue was when I'm taking a bite or taking a lasso, it is going from anterior to completely posterior. You saw how it got stretched out. So here I didn't have any choice other than what else I should either do or DAS. The patient was 18 years. I didn't, and he's a cricketer, so I didn't want to touch his bowling action, anything like that. So I was thinking, what other option do we have? How else do we tighten it? So this is what I figured out.
Finally, this thing is that what I've realized when you put the inferior anchor and you tie it up before, and then you put your second bite.
Yeah.
Sometimes when you're taking a bite, that first anchor, that it puts undue stress on that particular fixation which you have done. So what I like to do is, I like to put 2 anchors, pass all my sutures, and then start tying from inferior to superior instead of tying and then taking a bite. That's the one thing which I do differently. Otherwise, excellent.
When people do that, you see, you can always, for example, tie up maybe like 4 o'clock first, and then achieve the shift. Here, the way I do it is, I always put the 5 first. Take at least 2 centimeter deep bite, which gives me an adequate pull. I don't like doing the 3 o'clock or 4 o'clock.
Yeah. So the idea was to pass all the sutures and then tie them at the end of it. So I tie the inferior most first, but passing the sutures, I think.
Once you start tying the inferior first, you are stuck there. It doesn't move. Whichever you tie first, it remains in that spot. So,
I think only one question. Since this is a biceps scalar, and
DAS
is a biceps scalar, just like the biceps rerouting or the biceps CF. Do you find any difference in the elbow
power and no, actually I could actually show you.
Do you immobilize the elbow inflection?
Sorry?
Do you immobilize the elbow?
No immobilization. We allow passive, and that is rather passive or active assisted forward flexion. That means flexion of the elbow. We start from day 1. We don't go all the way straight. We hold it like this much, and this I allow a complete stretch only after 2 minutes.
Because one of the biceps rerouting that I performed, I found significant issues in elbow stretching out. I don't know how many others have found this.
So And the rerouting, I don't do rerouting as such. I always do I do an SAR and then do a T-notice or a T-not-me. In this particular case, I felt that the length is not changing too much. Because you're shifting top of the glenoid to the front of the glenoid. You're not shifting too much of tension is not there like on the rerouting.
Also depends on how much of biceps you pull in triangle.
Right. And here we are fixing on the front, so we're not pushing. Only in this particular case I have to do it. Otherwise, normally we fix in the trade block position. And then we do it gradually. We should allow the stretcher out. Like we should take 3 weeks to gradually stretch it out and allow him to completely do that. Even then, for first 6 weeks, I don't allow an active flexion. I always allow this. But then, these patients, DAS patients, take little more time in the rehab. Instead of 3 months, they will take like 4 months. If there's a time in like 2.5 months time where we find that the shoulder is still not actively lifting properly, but it will correct in some time. Around 3.5 4 months, you should have good results.
So, nice talk. You said that your Latarjet is the go-to surgery if you have a failure of the backyard and a bad tissue.
Yes.
So why not DAS over there?
But DAS is not good, sir.
And
yes.
Latter one is doing it in primary backyard
Yes.
as well. So and what if there is no bone loss?
Exactly. So all we know, we can do DAS, but there is no long-term results of DAS. We don't know. We don't know if this biceps is going to fail in some time. How much load it will take. That is number one. So now, the only thing which we can safely say as a gold standard is because you look at the outcomes. The outcomes of revision Vanguards are very bad. So 50% failure rate. At the same time, if you do a Latarjet, the failure rate is only 3%. That is my idea of the risk. So recommendation always a Latarjet, and DAS is, you can do the DAS, but I don't think that is enough, personally. So I don't want to take a risk with my patient. Primarily, I would do it in a soft tissue insufficiency. In a revision surgery, I would always do a Latarjet. Because why? It is proven. That is the idea. Statistically proven. We have a lot of papers on it. So that's the idea behind it.
And if there is no bone loss, it's still.
Still.
So would you create a bone loss?
No need. So we just put a Latarjet. Regular Latarjet is enough. Like for example, so Latarjet is a primary surgery for contact athletes. If you have a rugby player, then you do a Vanguard's failure chances are very, very high. So in a primary contact athlete, I always do a Latarjet. We don't have to just put a regular Latarjet and leave.
So won't the Wolves law apply there and the graft will resolve eventually?
It will resolve, and the non-shielding areas, that is non-shielding areas, non-loading areas, upper portion will resolve. Remaining will be fine. But sir, it is very interesting how the Latarjet helps over a period of time. When we look at the biomechanics, is also the conjoint tendon. Conjoint tendon has a great role. For example, you must have seen the graft completely getting resolved in some scenarios. The non-union of grafts. We have maybe when you're doing certain implants, encircle, complete cutout of it. But still the conjoint tendon, the patient don't dislocate. Patients are very stable. So the idea is the conjoint tendon is the main thing rather than the bone.
That's right, but you have the naked screws over there which are...
Now we have the other, nowadays I don't use the screw, I always do the cortical button Latarjet, Smith & Nephew system. Thank you.
Thank you so much, Dr. Ayappan. I would like to invite okay. So I would like to invite the Secretary of NMOA, Dr. Alpen Vieira, sir, to please come on the dais. He'll be chairing this particular session as well, and Dr. Kiran Mari, the Vice President of NMOA, again. Can we have a couple of more hats? This chap is expert in panawing totally. Okay. So after a lot of discussion about the Wolff's law, then DAS and all other stuff, probably as Dr. Ayappan also mentioned lastly that screws are not the right thing to go, probably getting through the... Okay.
Going. ChatGPT has not done this correctly. I don't look like this. Upper half of the face also. Okay, let's get. So that's BBC. Definitely not the big black, but the bone block circlage. So the thought process is definitely that this block should be seen as one, should act like one, and think like one, so that the Wolff's law doesn't apply on this particular thing. So before the another victim, which is the coracoid, falls in this particular battle, BBC is the way to go. So why and when to collect? Since morning we have spoken about we have heard about a lot of stuff with respect to percentage, the elbow, and all this. So anyway, if the bone loss is between 13.5 to 20%, right, and about 20%, there is no doubt lethargy is the way to go. But that this particular area, wherein 13.5 to 20%, we have something that can be done so that the coracoid doesn't fall back. We have another indications wherein there are arthroscopic stabilizations which have failed. Again, the glenoidal bone loss is less than 20%. In such situations, we can go ahead with this. And then the off-track Hill-Sachs lesions, wherein the remplissage can be combined to have a good result. We as surgeons are definitely spoiled for choices for this particular BBC. We have the iliac crest bank with us, the scapular spine, the distal clavicular graft that we have, and also the allograft, which is the distal tibial allograft, which can actually fit quite nicely with the glenoid. The harvesting is something that we have to look at, but when it comes to size, if we need a smaller size block, we can fall upon the distal clavicle. A little more bigger is the scapular spine, but then iliac crest is like a bank. You can take as much as you want to. But then if the patients are not very problematic, then you can still offer them the distal tibial allograft, although it comes from a cadaver. The preparation is really important. You have to take out time, make that particular surface really good enough so that it coapts to the glenoid. The measurements will depend upon the kind of block that you want to use with respect to the loss that you have anticipated based on your MRI and CT scan findings. There are special zigs that are available so that they'll help you to prepare this particular graft, mark them properly, drill the holes. You can use the zigs which you are going to use in the final as well to make the holes in the graft. Prep them properly with respect to different circlage systems that are available. We have two companies with us. One is the, let me not name it right now. And then, as Dr. Ayappan also told, that this system which has got cortical buttons, they really give a very good amount of strength whenever you're using them or utilizing them. The portals are regular, the anterosuprolateral portals, the posterior portal, as well as the biceps portal, which aims directly to, it can go to the cuff as well. There are certain parameters that are really important. You have to have the zig with a very sturdy hand. You have to see to it that they are parallel and the trajectory is good. You are not far down into the glenoid or you are not far up onto the glenoid from the posterior part of it. You make your steps through, drilling the tunnels, visualizing them. You can see that there's a thread holding the labrum. So in situations wherein you don't have that space there, you can pull the labrum with the sutures. These sutures can be incorporated during your labral repair at the end. There are systems which actually utilize, you can prepare the graft on the table, or when you're doing this BBC, you can do it intraoperatively during your portals and all, so that you pass the sutures through the shoulder joint, take it out, loop through the graft, and then take it back in. So these are the two systems that are available with this. This is when you pass through the shoulder joint, loop through the graft, and then pull the graft inside. You can depend upon the cannulae, or you can go without the cannulae as well. If the graft size is significantly big, you can definitely enlarge the rotator interval and do it without the cannulae. Graft passage is difficult. It can rotate, it can give rise to a lot of issues, but then there are systems of big graspers that are there that can help you to avoid that rotation issues with the graft. You can see that there's a vesicular rod that is like holding the graft and in level with the glenoid so that it doesn't overhangs or undersets. Right, so that's the picture wherein you have before the compression, and then with gradual compression of the circular systems, you can see that the graft is sitting quite nicely onto the glenoid. There are these tensioners that are available. it's important to do them properly and not give a pull on one particular strand. There are other knots that you need to tie on the top of this particular tensioner systems. And in the last, you can actually add up, get all the bankart, regular bankart done, get your capsular shift, and you have a dual advantage onto it. The cherry on the ice is definitely the remdesivir, which you can add after your procedure is through. You can see the results even at the end of 3 months. The CT shows that there is good amount of fusion that is developed between the graft and the glenoid. Although if the Wolff's law comes into action, the patient will retain only that much of glenoid that is needed and the rest will get absorbed. That's the end of 1 year. You have the function of the patient. There is some restriction, but perfectly fine. Right? It's not easy peasy. We have already seen in the morning lectures, the anchor pullouts are there because you are drilling 2 holes in the dual tunnel technique. And if the hold of those particular glenoid subchondral bone is not good, you can have an anchor pullout. That's pretty common. And the graft rotation is also pretty common if you are not angling trajectory from the postero-inferior glenoid to the antero-superior glenoid takes place. So that's where you can go wrong with your graft positioning as well. So in the end, it's critical to verify the graft position. Biology always is important. Progressive alternating tensioning is the way to go. 3 successive cycles is what the company recommends. You can add definitely beyond that. Last line I have taken from internet. I have not written that. It's important to avoid the twist-based malcompressions. Otherwise, later on you will see that the graft has become loose in spite of taking those knots. Earning on this slide, medialization is okay, but overhang is not accepted. Some inferiorization will help and prevent the subscap impingement. So we summarize this as this augmentation is not merely the bony volume addition, but an inherent architectural concavity that we are providing over a period of time. Surclass fixation will avoid those rigid screw-related complications that one can get in such kind of situations. Thank you, guys. I hope no questions.
You drill your anchors prior to the...
Yeah. So couple of cases I've drilled it prior, but then at the end what happens is the suture management, So when we mark those particular tunnels, we know that later on when we are going to put those anchors, we are going to avoid those tunnels. So that is probably that we can do. But then if you drill the anchors, you put the anchors, a lot of sutures that you will have to manage in between as well. So I believe.
You can just drill and then the anchor.
But you lose that side, you have to mark that thing. And then when you are drilling it and you are putting the anchor, if the angulation is slightly on that, so problematic.
It's past the bone into the joint.
Yes. So if your index finger goes into it, that's one way. Thorough rotator interval release is something that you have to look at. If your finger is going in, your graft will go in. You can use a 20 cc syringe or you can use the cannula that we have just seen here. So all those things are important. The crux is before you pass on the graft, see to it that it's not rotated. If it is rotated in your hand itself, you pass a loop grasper, pull your inferior and superior sutures, trace it right up to the top, and if it is coming to the top and the bottom where you want it, so it is not rotated. So that is why you ensure that you are not rotated to start with. Thank you. We are running late, I believe. So managing failed bankarts, Dr. Prashant Mishra will be delivering this particular talk.
Thank you so much, sir and Sandeep sir, for having us here. It's an excellent meeting, very good concept. I've seen these kind of meetings with this concept to keep it spicy in US. I'm very happy that we have this innovative things which we are doing. So my name is Prashant. I work in Apollo Hospital in Hyderabad as an exclusive shoulder surgeon. So I'll be talking about a back problem which is failed bank cuts. And a little bit about myself. I was trained, and I would encourage any of this young guys who are here that you need to have proper training to do a shoulder surgery if you want to be a dedicated shoulder surgeon. I don't have any financial disclosures in terms of academic affiliations. I have attachment with various journals on the editorial board, also international member for ASCS. So this is how the patient comes. We have done a surgery, either you or someone else, but they're always pissed if surgery fails. Either they have a dislocation or they cannot go back to their sports. And this is a difficult problem to face in your clinical practice. So we need to understand why the bankguard is failing and what treatment options do we have. So defining failure is very important after instability surgery. After a cuff repair, if the hand is going up, pretty much the patient is okay. But instability is one of the most common failed surgery which I see in my practice as a shoulder surgeon. So redislocation is definitely a failure. We see it in 15-25%, and that is not a good number. 1/4 of your patients redislocate or fail. That's a bad, I think, result. And more dislocations happen within 1 year, which is again horrible. But we need to redefine failure. Patients, if they are not dislocating, they still have apprehension and they are unable to go back to their original sports, I think that's something also a failure according to patient's perspective. And this is seen in about 14 to about 30% of patients in literature. So we need to understand why the bankguard is failing. There's of course patient factors, young age, contact athlete, generalized laxity. There's surgical techniques, failure to address all the pathology, number of ankles and position of the ankles, and the pattern of the injury, which sometimes is missed, which the special case will see one by one. So when we are evaluating a patient who has failed the bankguard surgery, we need to understand if there is a history of re-trauma. If that is there, then probably his his quality of the labrum is going to be better, especially in young patients. So you may think of doing a revision bankguard or a remplissage in very few select patients. But if the patient never got better, they said after surgery, I've never felt stable, then maybe some pathology was actually missed in the primary surgery, and you could think and evaluate them in a thorough physical examination as well as getting MRI and CT scan. Now CT scans I like to do on both the sides. Also psychological expectations is something which we need to face because more and more people are being active. Whatever we saw in a residency 10, 15, 20 years back is not the patient population coming to us now. Everyone is active, everyone is participating in paddle and God knows what not, in tennis, or they just want to be active. So patients do have high expectations and we need to manage their psychology once it is failed. So always measure glenoid bone loss. I think we talked about it. I'll touch on this very concept very briefly. Landmark study by De Beer and Burkhardt, when there was no bone loss, 6.5%, with bone loss, 67%. I think all of us should be doing CT scans for the patient. Do not just operate only on the MRI. This is one key message of this talk. When you're doing a CT scan, order from both the sides. Do have a 3D reconstruction, talk to the technician, see the amphitheater view, draw your circle, and do this yourself. Do not trust your radiologist to do it. Critical bone loss, this keeps on changing, but if it's more than 20% in my practice, patient is getting a lethargy or getting some kind of bony procedure, otherwise they're going to fail. If you do a bankguard in this patient, he's going to bound to fail. It's a day one failure. New definition of critical bone loss, and we keep pushing this envelope, and most of these studies are coming from Europe or US. Even in Indian scenario, someone who's a contact athlete, 15-16% bone loss, gets a bony procedure. Subcritical bone loss, again we keep pushing the envelope on what it is, but 13.5 to 20%, only bankguard repair is bound to fail. On-track, off-track lesion, we talked about this, but I will like to briefly understand and explain on how we do this in clinical practice. This was given to us by Giacomo and Ejito. So basically you see the width of your glenoid, and 83% of the width of the glenoid minus your glenoid bone loss is your glenoid tract. That's step number one. Step number two is you calculate this. You can do it on the CT scan, you can do it on your patients intraoperatively when you're doing a diagnostic scope. You calculate the Hill-Sachs interval, which is basically the width of the Hill-Sachs lesion plus the width of your intact bone between the cuff attachment and the lateral margin of your Hill-Sachs lesion. So if your Hill-Sachs interval is smaller, which means your Hill-Sachs size is small, then as compared to your glenoid tract, it's an on-track lesion. And when your Hill-Sachs interval is larger, which means your Hill-Sachs size is big, then it's an off-track lesion, more likely to dislocate if you do only bankguard. So not just the size of Hill-Sachs which is an issue, it is also the location of the Hill-Sachs. Even if it's a small Hill-Sachs lesion, it can still be an off-track. If you have this kind of near-track Hill-Sachs lesion, it is more medial towards the cartilage. This is more likely to fail if you do only bankguard. A peripheral region, if you see the zone 4 in this particular picture, if your Hill-Sachs is more medial like that, it is going to dislocate. Inferior position of the Hill-Sachs, again, last year's paper, it says that if your Hill-Sachs is located inferior, it's very rare, but these are the points why your Bankards is failing. And do not miss hidden lesions like the stretched IGHL, and we had excellent talks about that. And alpha lesion, which I think is a big problem because we usually just take the capsule, but your labrum is all the way down there because of these sleeve lesions. Haggle lesion is something which I've recently realized in the last 3 years to kind of find them and fix them. Humeral avulsion or glenohumeral ligament, if you do not fix them, then these are the guys who fail. Adequate number of anchors, you can, more than 4 anchors is what it is, but at least I put 3 anchors in each of my patients. Post-operative sleep for 3 weeks, do not mobilize them very early. This is known to have a failure after doing only a Bankart. And also, of course, go inferiorly all the way down. Do not just do an anterior shift, you have to do anterior to inferior shift, which is very important. Athletes are another ballgame. Dr. Ayyappan mentioned about this, that if you do Bankart repair alone, the failure rate is really high. 1/4 of them fail. So these are the patients in which Bankart alone kind of fails. So what treatment options do we have and actually fail when you have done all this evaluation of doing MRI, CT scan, knowing the patient physiology and everything? A revision Bankart repair is a very tiny, I would say, it has very small set of patients who would get a revision Bankart, only because the recurrent instability is really high, it's 26%, and more importantly, return to pre-injury level is only half of the patients, which I believe is very bad result in athletes. Only people who get a revision Bankart, in my scenario, would be like 1 patient in a year. If someone had a trauma again, which is very recent, it's not like patient had a Bankart, fell down, coming to me after 1 year, that's bad because that labor is going to be not of good quality. So I don't think there is much of indication for a revision Bankart. When it comes to minimal glenoid bone loss and on-track lesion, a degenerated labrum, and you're not prepared to do a Latarjet, I think everyone should understand the procedure which Dr. Ayyappan just said about direct anterior lateral stabilization, and you repair whatever cuff it is available. The advantage of this procedure is you can also add a remplissage in the same procedure. Free bone block surgeons talked about it, and you can use multiple of them. For me, in a revision scenario, if it's an off-track lesion, the bone loss is more than 13.5%, and an athlete free bone block is one of the options. But this is what I love in revision surgery for a Bankart. This is my go-to, which is a Latarjet. It does have a better outcome as compared to revision. A very recent meta-analysis kind of says that Latarjet actually has lower recurrent instability, higher return to sports, and better function as compared to doing a revision Bankart. But in a revision scenario, Latarjet still has poor outcomes as compared to primary Latarjet. So, when you were growing up and, in residency, people used to say, it's an instability. First surgery should not be Latarjet. First surgery, you do a Bankart. If that fails, go for Latarjet. I don't think that applies anymore. You got to do a CT scan. You got to understand that if patient is having more than 15-20% bone loss, the primary surgery should be a Latarjet, and don't even attempt to have a Bankart in that particular patient. But when you do, because you do it as a revision procedure, Latarjet, it does have higher redislocation rate, complication rate, higher revision rate, and lower return to play. So even if you're doing a Latarjet, your results are not going to be same as primary Latarjet. One of my patients, he had 4 failed surgeries. First Bankart, then revision Bankart, then a Latarjet, and then he had an anterior capsular plication. So if you see why probably it failed is because the position of that graft was way too inferior. So these are, I think, very complex kind of scenarios in which we need to, I used an iliac crest graft for this one, and I put a remplissage along with that. And this is he is a police officer in Dubai, and 2 years post-op, he is not dislocated. Every time I see him, or at least when I was there and I talk to him now, he calls me. I'm always worried if he dislocated again. But these are complex problems and require expertise as well as evaluation of your time. So my algorithm for treatment of failed Bankart in 2025 is if you have a glenoid bone loss which is less than 13.5%, on-track Hill-Sachs, good quality labral tissue, and traumatic etiology. These are the only patients, and these are very few. Then yes, we may think of doing a revision Bankart and plus adding a remplissage. At any point of time in the surgery, if I think the labral quality, tissue quality is not good, you definitely want to add a dynamic anterior stabilization with a remplissage. Off-track lesion, athlete, ligamentous instability, more than 13.5 glenoid bone loss in the revision scenario, they get a Latarjet. And this is probably, I would say, most of my revision, which I see in my practice, do get. So in summary of failed Latarjet, you want your dinosaur to be sleeping. You don't want the Jurassic Park in which the dinosaur is running behind you. So when it fails, you want to make sure you tame that dinosaur. And the way to do it is have proper patient selection. You can do an absolutely perfect, beautiful Bankart remplissage Latarjet. It can still fail if it is done in the wrong patient. So patient selection is the key for orthopedic, because most of us, they learn how to do things. We just don't know when to do it, and most importantly, when not to do it. So patient selection is the key. Measure glenoid bone loss in all your patients. Know the tracking concept if you're doing these surgeries. Minimal glenoid bone loss, good tissue quality. Think of a revision Bankart. Otherwise, go for letargic. Thank you.
That was crisp. It was nice. Any questions? Okay, so let's move on with our next talk. Dr. Pradeep Nemade will be talking on congruent arc lethargia. Pirates or the cowboy?
Cowboy.
Cowboy.
Okay, so a lot has been spoken since morning about the rationale and why we need to do a lethargic procedure. I would be speaking more onto the technical aspect of it. Thank you, Sandeep, Mitali, and so on for helping me in this. So a bit of story, and the history is pretty interesting. Noeske in Germany actually did this procedure, which Dr. Trillat adapted in 1924. What he used to do, and I often spoke about it, he used to take a lower wedge of the coracoid and kind of wedge that down gradually, pushing the subscap down and fix it with a screw, kind of creating an orthoedesis procedure, kind of creating a block for the humeral head to go down. And that was the procedure which was there for the recurrent dislocation and the habitual dislocation, the voluntary dislocation at that time. Lethargic was just, hospital was just road across Trillat. One day, Lethargic said, I want to come and visit you. And he went there and visited his surgeries. Saw few surgeries and then attempted one. During the first surgery, Lethargic couldn't take the wedge and accidentally fractured the coracoid. When he fractured the coracoid, what to do now? So he just took that coracoid and fixed it with the glenoid. And fortunately, the patient did well. And then that's how it was done. It was fractured, and then he went on and published that procedure. And that actually Trillat was not very happy, and that it is said to be that this procedure started rivalry between Trillat and Lethargic for procedure. But anyway, for us it worked very well. So later on, Lethargic published few variants of this technique where he wanted to put through the subscap, like sometimes with the putty plat, sometimes he fixed very high and medial, but and again Bristol later on fixed it lively end on. So there are a lot of variations of this, and we know of an on-track lesion, and we have seen it since in the morning. What are the indications of this procedure? That whenever the glenoid bone loss is so much so that your Bankart repair will fail, in that case we need to do a lethargic procedure. So indications are glenoid bone loss, a pear-shaped glenoid, presence of humeral bone loss also in combination with that, failed Bankart repair, which is one of the very important indications, and poor capsulolateral tissue. And IAS more than 6, I spoke about that. Contraindications when you have subscap tear or an articular fracture more than 30%, where one would like to do a bone block procedure, a non-engaging Hill sacks, maybe a voluntary dislocation, multidirectional, and epilepsy disorders where it is uncontrolled and it can put a load on the graft where it is not unite. And elderly people where it is kind of a contraindicated. Surgical technique, rationale is that it creates 3 effects: the sling effect, the capsulolateral repair, and the boning effect, which when it extends the articular surface of the humerus. So there are 2 techniques: the lethargic, where it is just put face on, and then the Jody Beer and those guys kind of modified it in a way that it can be tilted and kind of fixed like that. So I'll be speaking on the congruent arc. This thing. Yeah. So the procedure is like that, where we take the coracoid osteotomy, put it through the subscap, turn it 90 degrees, and fix it in congruence with the head of the humerus. So that is how the incision is taken. That is how the coracoid is exposed. Then they osteotomize the coracoid. Few people want to keep the coracoacromial ligament intact so as to can be sutured with the capsule later on.
Then that's how coracoid has been taken. Then that's the coracoid surface. Then we split the subscap and expose the glenoid and kind of put it either in a classic way or in a congruent arc where we turn it to 90 degrees and fix it. And then they are fixed with this kind of offset sleeve wherein we kind of fix it with either with the screw or with this plate, and then we can alternatively do a capsulolebular repair as well, and then close the capsular collagen subscapularis. My technique, I generally do it freehand. I do not use this kind of technique, so I will try to focus on that. We take, this was a 27-year-old male, redislocation after 1 year of doing Bankart procedure. So we are doing a congruent arc latarjet for this patient. It's a, this is the head end, this is the foot end. We take a deltopectoral approach, and that is the coracoid. We mark the coracoid. We expose the coracoid nicely. That's the coracoacromial arch. So we are cutting the coracoacromial arch. You can keep some sleeve if you want to repair the capsule there. I do not repair it there, that's why I am cutting it. And we release from medial side pectoralis minor also, and try to clear it from underneath so that to get a good space for the brachial plexus and the vessels down there. Then you can osteotomize either using the saw, but I use the osteotome which is much more controlled for me, and I do it from infromedial to superior lateral direction for the safety reason. And then we mobilize the coracoid. We make sure that we do not mobilize too much so as to put tension on the muscular cutaneous nerve. And once that has been done, we see the coracoid, we see to it that we have got a good length. In this case, it was 2.3 millimeter, which is okay for us. And then we park the glenoid, park that coracoid down into the inferior aspect of the wound and focus on the subscapularis. Then we externally rotate the arm and expose the subscapularis very nicely and split it in between. There are again variations where we want to split it either in the lower half or the lower 1/3 or the upper 1/3 on the middle. I split it in the middle. Then we put this Fukuda retractor to retract the humerus, and we elevate the capsulolebular complex from the anterior surface, and then we expose the glenoid from the top portion to inferior portion, and then we can even put a self-retaining retractor there. Then we prepare the glenoid using the burr or the nibbler or some sharp instrument to kind of swipe it off. And that's how it has been cleared off. We try to create a good bleeding surface. And now this is the most important thing. Here we need to, once we have put a surface, we want to fire the coracoid there so as to create that congruent arc, because we don't want to put the coracoid in inverted position where it is finding away. So in the same way we prepare the undersurface so that once it sits, it really forms that congruent arc. Then I drill by freehand 2.5 meter K wire. So this is my first K wire. We see to it that it just comes underneath, and then we cut it short so that the other long wire can be passed. So I keep 2 length wire. So this is the first 2.5 wire which has been cut, and then we use the second wire parallel to that, and that is all freehand. We don't need to do any kind of instruments for this. So this is the second wire which goes parallel to that, and then I pass a very small thin K wire in oblique direction. Now I have got a very good 3-dimensional control over this coracoid, and I can place this coracoid right onto the surface, just 1 millimeter medial to the congruent to the congruency of the glenoid. And then at that position, when I am here, I can even palpate with the hemostat and try to ensure that it is congruous. And then we transfix all these 3 wires, take away 2.5 wire and replace them with screw. The middle wire, which is a thin wire, remains there as a stabilizing procedure. Then we can reshape the superior aspect of the glenoid coracoid, which sometimes can come in the way anteriorly. And then put one anchor where we have taken the incision of the capsulolebular complex, and then we repair the capsulolebular complex to the glenoid. What this does, it pushes the graft, it keeps the graft extra articularly, because we are repairing the capsulolebular complex in between the graft and the humeral head. So once you do that, the graft remains extra articular, and then we repair the capsule with the vicryl and close the subscap. And that is at the end of the procedure, when the subscap is closed, that forms the sling of the lethargic, where it passes in through the subscap. And afterwards, we just close the delta vector approach in the same way how we do it. And that's the post-op where we make sure that it is placed much more inferiorly rather than in between. So then we have the emergence of arthroscopic lethargic, arthroscopic bristow, and the bone block procedure as well. Bone block procedure works only on the extension of the articular surface, not on the sling. So few cases, this was one case again which we did, the same case again, second case, and we can see that if you see the post-op X-ray, we can see that the articular surface extended, and that jump distance for the humeral head to go anteriorly, that clearly get extended after this. The lethargic later on got various modifications. There are many things on which people are working and publishing a lot of literature, creating some kind of differences. Of course, it is a technically challenging procedure. Learning curve is not that long, however. There are many variations. We can go through this article to look about what are the complications. The notable most dreaded complication, however, is the musculocutaneous nerve palsy. So take-home messages, whenever there is a bone loss that is significant, you can think of lethargic procedure. Proper position of coracoid and fixation is most important, not just putting the coracoid anywhere. Sling effect does work. Where the congruent arc leads to less arthritis in long term, that is the question that needs to be answered. Thank you very much.
One question.
Yeah.
So Indian coracoids are very thin. I had told myself doing the congruent arc. That's why I gave it up. So how many cases like you are always able to do a congruent arc?
Yeah. So as you have rightly pointed out, the distance of the coracoid, what is described in the literature is 2.5 centimeter. If we take just anterior to the CC ligament, many a times we'll get 2.2 or 2.3 only.
It's not the length, the thickness of the coracoid.
Thickness, yeah.
Very
So we have 3.5 screws also. In case you are, it's very thin, so that you mean that I have a part of 4 mm screw, it will split up.
Yeah.
Then you can use a 3.5 screws.
We put the pec minor surface on the glenoid.
Yeah.
Other surface is very narrow sometimes to put that screw properly.
You need to shave off that surface to make it flat. If you see that the under surface, we cannot keep it because the coracoid in cross section is ellipsoid.
Yes.
We need to make it one surface flat.
Yeah.
If you keep it ellipsoid, it will fail
It
because
has
it
to be
will
the
cover.
pec minor surface, which is the broadest one.
Yeah.
The lateral surface of the coracoid is a narrow. So
Yeah.
what happens when you put the screw from the lateral to medial side?
Yeah. We can even, to increase the surface, we can even countersink a bit, doesn't matter.
One comment. I think you have stayed true to the theme of Hollywood style presentation very well. It was very nice.
Thank you.
Lisa should give some award for that.
Thank you.
Thank you, Dr. Pradeep Namade. Unfortunately, we don't have Dr. Gautam Tavri with us, but okay. So let's call upon our next speaker, Dr. Sanjay Singh. He'll be talking on slab lesions.
Good afternoon, everyone.
In the outset, I would like to thank IAS and Dr. Nilesh for having me here. So, because it's a Hollywood theme and I was given John Wick, so the most important line in the movie was that Vigor says to his son that why did the movie start? It's not what you did, son, it's who you did it to. So basically, he killed the dog of the main character and then he started the vengeance chain. So, most of the presentation is from this very nice article where it gives a straightforward treatment algorithm for all our slabs. So in the morning also we had a talk where we had this, first we should know what is a slab and what is not a slab. We keep on seeing MRIs reporting slab, type 2 tear, type 3 tear. Most of them are inconsequential. We need to go inside and check what exactly the slab tear is. So this is the normal sublabral hole which is seen. The before campus was explained in the morning. This is how you see nice rolled up margin which is normal. It is not a tear at all. So you should leave it as it is. If you repair this, then the patient will become very tight external rotation. So Snyder classified this in 1990 paper and it was a retrospective classification. They went through all their previous surgeries, saw that these lesions were there and we missed them and then they classified it. So type 1 is a frayed degenerated superior labrum. There is no detachment of the biceps at all. You just see some frayed margin. So when you go inside the joint, you put a probe or a Wessinger rod from front. You are seeing from the posterior portal, you put it from the front and then you can see, try to lift up the labrum from the glenoid. So there is a normal bare area there also. You should not classify it as a slab tear. That is very important. There is a small hole below the labrum and beyond a certain point you see the raw area. If there is a roughened raw area, that is a slab tear. Type 2 is a detachment of the superior labrum and biceps tendon from the glenoid ring. Type 3 is a bucket handle tear of the superior labrum and the remaining labral tissue is attached. So it's just like a meniscus bucket handle in the white zone coming down, but the entire attachment is intact. Type 4 is an extension of the displaced bucket handle into the biceps tendon itself. Then Maffei in 1995 again added 3 more types to it. Type 5 is an anterior-inferior Bankart which goes right up till the base of the biceps into the slab. Type 6 is an unstable flap of the labrum which is present in addition to the biceps separation. And type 7 becomes a superior labrum biceps tendon separation which exits into the MGHL anteriorly. These 3 types are added. Now, this is the most important slide where we should know what to operate and what to leave as it is. It is a mechanism of injury. Classical mechanism of injury for a slab tear would be fall on the elbow. That leads to posterior dislocation of the shoulder up and that leads to eversion of the biceps tendon from the glenoid. If any patient is there with this injury, only those patients need slab repair kind of a surgery. Rest all other patients do not need any intervention. The second category is a chronic injury, repeated abduction, external rotation. A classical thrower, it could be a cricketer, bowler, it could be a golfer, it could be a badminton player. These patients, if you repair a slab, you will repent for your life because the patient will be behind you because the pain will never go away. And third category which we most commonly see in a regular practice is an associate pathology which we see on the MRI. There is a rotator cuff tear patient, type 2, type 3 slab scenes. You go inside, the bicep is completely degenerated and there is some labral tear present. So if you categorize them into these 3, only the top one needs a repair, rest other 2, they do some other additional procedures which will come to later on. How do we examine them? So biceps is a very confounding structure in the shoulder. Many times we see the pain, where it is coming from, we don't know where it is coming from. So multiple tests have been described. So there are few tests. The speed test is basically a simple, you just elevate the arm against resistance, patient has pain, it is positive. Yargasans is where you supinate the forearm against resistance, pain in the biceps is positive. Uppercut maneuver, I'll come back to later. O'Brien's test is you do a adduction internal rotation against resistance, painful, it is positive. You remove the internal rotation and it goes away, that means it's positive. And then there is a Mayo shear test which again I'll come to later on. So this is the modified DLS or the Mayo shear test. Very important test to diagnose isolated slab tears which are of significance. So you take the patient's arm into abduction external rotation, bring the elbow into extension and bring it down. A patient with a pathological slab tear will have a sudden click or pain. That means the posterior labrum is getting impinged between the head and the glenoid. This is a positive test. That means that patient most likely would have a significant slab tear. This is the uppercut maneuver where a boxer's uppercut is asked by the patient to be done. If the patient has pain, that means there is a significant pathology in the biceps. So this test eliminates all the cuff pathology mostly because you are not interrotating. The moment you interrotate the arm or external the arm, the cuff also gets impinged. There is some component of pain there because of the cuff. This maneuver is a simple maneuver where you push the uppercut and then the cuff is not involved, only the biceps is involved. Then this comes into picture. So if there is a bicep, so slap has two components. One is inside the joint, one is outside the joint. That is a biceps tendon itself in the sheet. If it is involved, then the uppercut would be positive and the speed test would be positive. If it's inside the joint, that means that the attachment at the 12 o'clock position, then it's usually the O'Brien's and the modified DLS would be positive. How do we manage them? So type 1, fraying, we just divide it. Type 2 is the most difficult one to decide and it is the most common one. Either you repair it or you do a biceps tenotomy or you do a biceps tenodesis. I'll come to that later. Type 3 is the resection, because the rest of the labrum is normal, you just resect the bucket and then forget it. Type 4 again has a slap repair plus resection because less than, if the biceps is affected, less than 50%. If it's more, then you have to do some bicep procedure. Type 5, Bancard's, because it's extending into the slab. You do a Bancard's repair and then you decide about what to repair the slab or not. Type 4 again is a bucket handle, so you resect it. Type 6 is the fixation of the end. So it's different from a Buford complex. Then you have to fix that labrum there and decide on the biceps later on. Now this is the simplest algorithm. So if the patient's age is less than 40, then only you consider a slap repair. I would go down to the level of less than 20 years old. You should not repair a slap more than 20 years old patient because it will be troublesome. And that episode is a non-thrower, traumatic episode. Patient fell down on the elbow, had a sudden jerk, has edema, pain and all those things. Then you go ahead and repair the slap, otherwise you are not repairing the slap. If the patient is a repeated overhead thrower, Boliu had a very good paper where he said patients with slap repair, almost there was less than 60% chance of going back to sports. They did tenodesis and those patients did very well. So a thrower, a professional athlete always do a biceps tenodesis, do not repair the slap at all. Patient more than 40, heavy worker, knee cosmesis, biceps tenodesis. Patient, if you are doing a cuff, you see a slap, just cut the biceps, you will be happy. The patient would be happy. So basic positioning, I have no video because I seldomly repair slabs. So normal abduction position. So this posterolateral Wilmington portal is very important. If you are going for a repair, this is the anchor portal where you put your anchor into the glenoid. Because apart from this, no other position gives you that posterior superior anchor approach. You can use the normal posterior portal for visualization, and your work and visualization will be through the anterosuperior portal and the anterosuperior working portal. So that would be it. Thank you.
Thank you, Dr. Sanjay. Thank you, sir. But there was a disclaimer, Dr. Sanjay doesn't repair slaps. Maybe it's,
I don't want any all coming here.
okay. So next is yours. So we have a posterior labral tear talk, which will be given by Dr. Ayappan Nair again. Any questions on slap? None.
Not too afraid, sir.
Huh?
Not too afraid, so no questions.
Not too afraid. But initially, recognizing a slap is also something which is not very easy.
Thanks again, Nilesh. And you can see this compared to, I've been to quite a bit meetings, but nobody's made me talk so much. Like 4 meetings. So our team had to prepare for a week to get everything in set. Yeah, the screen, please. Screen.
So when I came to know that you have a team, in fact that was a push that yes, we need to give it more.
So I'll be speaking on be speaking on the posterior labral tears. So the prevalence of posterior labral tears and posterior instability is always there. So when we look at isolated posterior labral tears around 16.3%, it is more found in athletic population and military population. So now if you look at the biomechanics behind it, it is posterior loading force. If you are into, for example, military push-ups and those kind of things, there are higher chance of these kind of posterior labral tears. And in association with anterior labral tears also, it is around 18.5%. That means whenever you have an anterior labral tear, always keep checking for a posterior labral tear. Posterior labral tear could be a very obvious tear, or it could be something like a Kim's lesion or something which could be very subtle. So the most important thing is when you have a posterior labral tear, you know that there is a posterior instability. It is very important to do a bone loss calculation there also. There is a critical value similar to what we have 13.5% in an anterior bone loss. Here the cutoff is 10%. So more than 10%, there is a very high recurrence chances. So if you look at the biomechanical papers, you definitely find that more than 10% you require a posterior bone block. So now there is something called as the gamma angle also, which is very important. Gamma angle is basically you draw a circle like how you do in the head of humerus, and when there is a posterior instability, there is a reverse hill sash. So anterior margin of the hill sash to the bicipital groove is a gamma angle. So that also is important in determining what else do you add on. It's very important. So this is a particular case we had. So so what we do is, so I always visualize through an anterosuperior trans cuff port because it gives me access to both sides. Sometimes you can see a very proper, separation in the labrum. Sometimes you can see something like this, and you really have to probe through to find out the extent of it. It's possibly a Kim's lesion kind of thing could be there. So a proper elevation. And elevation, you should be very careful with the elevation here because there's not much of tissues on this particular side. The elevation has to be just on the outer border of the glenoid, like that. So you go in all the way down. And same, however you do anterior pancart has to take a very small margin of cartilage away. And then I sometimes do use a cannula for an anchor insertion. But the most important thing is a vertical angle for the anchor to come. So my anchor insertion will not come through the cannula at times. It will come through a direct posterolateral port, posterior port, which is in this direction. So the anchor is here and on the face of the glenoid. And another important thing is how much of soft tissue to take. You should be really careful in the scenarios of multidirectional instability because you have to balance. It is very important to balance the anterior and posterior capsular application. If you always check for MDI, see if the shoulder is dislocating anterior as well. Then you go all the way, not only posterior but anterior. But the plication has to be decided how much ever you want. For example, if it's going too much anterior, you plicate more anteriorly. Otherwise, you plicate posteriorly more. So the plication is not normally too much required in this area. So you can see there are different ways of passing. Normally you use a bird beak for passing through the capsule, and you can see the passage through the capsule is quite less. This is the PIGHL, and the bird beak and suturing. This is what we do. It's not very complicated. It's pretty easy to do a posterior labral this thing. But the only thing is, I would like to emphasize is that you need to balance. You see if there is an anti-instability also. If there is an anti-instability, if you tie too much posteriorly, it will still become unstable. So here, there are different ways to sort of think. Here you can use simple suture passes, you can do matters, but normally matters in this area is not required to be. They might compress it too much. You can use a push lock. Different ways of doing it, or even a matters. So looking at the outcomes of it. So outcomes are pretty good. This is a particular study. You can see we've got a definitely improvement in the scores. Recurrent instability chance are very less, and 78 points. So the most important question a patient going to ask you is what are my chances of going back to sport? So you can see that 91% return to sport, and the pre-injury levels are 78.7. 91%, 91.5% is very good. So return back, 78% is also extremely good. So this again, the outcome papers, which again shows that high return to sport. In summary, posterior labral tear is not very difficult to do, it's pretty easy. The tissue plication is not as much required as the anterior. Balancing the anterior and posterior in case of multidirectional stability is very important, and it gives good outcomes. And a critical bone loss is 10% come to 13.5% anteriorly. More than 10% you need to substitute with bone. Thank you so much.
So your criteria for balancing is the head remains central.
In the center. In the center.
So
and before starting of the surgery also we have to really rotate and see which way is it going more. If you are sure that anterior is not going more, because in MDI we will not get a tear. Labral tears will not be there. How we find MDI is that we can see that the glenoid would be like this, and the tissues kind of flatten out. That is MDI. You might not have a proper tear at all. So if we see that we should not go always in the mindset that this is a posterior labral tear. We should always think that there is an anterior instability also. So definitely before starting the surgery, rotate anterior and see, external rotate and see if it is going anteriorly. Then you have to do a labral elevation all the way anterior. Plicate both sides. Your plication, then we decide if suppose it is anterior more than posterior, plicate more anteriorly than posterior. Otherwise what will happen is, we will go and do only a posterior, look at a tear, posterior labral tear. We plicate posteriorly, definitely this patient is going to come with anterior dislocation.
What is your patient selection criteria for posterior labral tear? Because I think that is very important. These guys are a little, I would say, nuts. Yeah. Heavy weightlifters and players. So not all of them will slow tear, and a lot of times we don't know. Yeah. Sometimes they say the pain is in the back, pain is in the front. We don't know. Yeah. So I tend not to operate them initially. Yeah. But what is your patient selection criteria? These are the posterior labral tears which we operate, and we will do it.
I have a posterior labral tear. So my thing is, what I would, we have to rehab for 6 months. Rehab for 6 months. Unless until it's a gross instability which is happening with a reverse hill sash which is there, then we should not operate a posterior labral tear. We should rehab at least for 6 months, see for stabilization. The patient is still symptomatic, only then we operate. What is noticeable in this patient, as you rightly said, was these patients will have pain for some time. When there is an acute injury or something, they will definitely have pain. After some time, the pain definitely comes down. Even overhead actions are possible. Even throwing is possible. So I'm a classic example of a posterior labral tear. So one day I happened to do extremely strenuous rotations, and I started having significant pain posteriorly. I waited for some time. Then we did an MRI. I happened to have a posterior labral tear extending from posterior 9 o'clock to around 9 to possibly 2 more down. So what I did was I underwent rehab. I also had a parallel cyst. So but then I waited for some time, did proper rehab. Now I'm good, fine. And the shoulder is quite stable. I can do anything. So I think we should not operate unless until the patient is responding at least for 6 months to rehab. This is my take.
Yeah. So I just wanted to ask you, since we're talking about MDI, what is the threshold to operate these patients? What are your results / failures? And what do you consider to these patients?
Multidimensional instability is definitely atraumatic instability to be treated by rehab primarily. So 6 months, definitely rehab. So looking at everyday rehab, the patient continues to be unstable means if there is, the patient can have gross instability, not able to athletic activities, even after 6 months, only then we have to operate. That is the take. Your next point is?
Yeah, so what do you counsel? I mean, you know at the back of the mind that this patient can re-dislocate or he may have to have persistent instability. Or are you confident enough to give?
Yeah, so till now, I didn't have, somebody said that I didn't have any failures with MDI touchwood. So because I do rehab for 6 months, no response, then my plication would be like, I would take from anterior, 360 degree plication I would do, except for superior. I would do anterior and posterior balance. Well, till now I have not had it, but there is always a chance of stretch out because in MDI there is always hyperlaxity, soft tissue, even if you plicate it can stretch out over a period of time, is definitely there. But till now I have not had it. But definitely, as you said, it is important to counsel and tell them that there is a chance of, because your MDI, hyperlaxity, tissue insufficiency, it is definitely, it's a possibility is there.
So just for the benefits of the delegate, I want to add a point here. This talk was majorly regarding MDI, but in the normal scenario, if you see a recurrent dislocation patient, long standing, they will have a posterior labral tear, almost 20% of the time. So there is a test called as Porcellini test. Adapt the arm, interrotate and ask the patient to push against resistance. Patient will not be able to do that. Then you push the humeral head with the thumb and again redo the test. The power will come back. That patient has a posterior labral tear, and then while doing the Bancards, you just go and repair the labrum behind. So in our scenario where we see a non-athletic population, that is a posterior labral repair which we are not supposed to miss. Otherwise the patient's dislocation will go away, pain will not go away, and that patient will continue for life. So posterior labral instability in a normal person is pain. It is not dislocation. Very seldomly you have patient doing adduction and it dislocates. I have a couple of patients. The moment I did adduction interrogation, it dislocated posteriorly. Those are gross instabilities, but the smaller ones, as Dr. Ayappan pointed out, they will only complain of pain.
Thank you, Dr. Ayappan. Next we have Dr. Vaibhav Kohli, who will be talking on relevant anatomy of the rotator cuff. We are moving from the instability to the cuff now, and before we break for lunch, probably a couple of more talks and then we can.
So good afternoon to all. I would like to thank IAS, Dr. Sandeep Barade sir, Dr. Nilesh Vishwamara sir, I'll have the cover hat, for giving me this opportunity to present. I hope I'm looking good for the camera. Yeah, so I'd like to thank all the prestige members of the IAS for giving this opportunity. Today my talk is on rotator cuff tendons. It is the most favorite thing we like to repair. So I'll just like to brush up on the things which we all know. So as we know, so the rotator cuff is made up of 4 muscles: supraspinatus, infraspinatus, teres, subscap. So we begin with the supra. It originates from the supraspinatus fossa, inserts at the greater tuberosity. It has got 2 fibers, superficial, deep. The superficial are the longitudinal fibers and have large blood vessels. And the deeper fibers run obliquely and create a non-linear pattern that hold the sutures more effectively. The anterior portion of the supraspinatus is more powerful and its muscle belly is much larger. It is active in any motion involving elevation, and its maximal effort is at 30 degrees of elevation. So in this picture you can see that the fibers, it's not working. The fibers are cross section at red block area. The infra originates from the infraspinatus fossa, inserts at the greater tuberosity. It is one of the 2 main external rotators, and it accounts for as much as 60% of the external rotation force. It acts as a depressor of the humeral head and an important stabilizer against posterior dislocation. The teres, it originates from the middle portion of the lateral border of the scapula and the infraspinatus fascia, and it inserts into the lower portion of the greater tuberosity. It provides up to 45% of the external rotation force and is important in controlling stability in anterior direction. It also participates in a short rotator force couple in abduction along with inferior portion of the subscap. The subscap, as we know, is the largest muscle of the rotator cuff. It originates from the subcutaneous fossa. The upper 60% of subscapularis muscle inserts through a collagen-rich tendon, and lower 40 has a fleshy insertion in the humerus below the LT, cupping the head and the neck. It functions as an interrotator and passive stabilizer to prevent anterior subluxation, and especially lower fiber serves to depress the humeral head. It resists the shear force of the deltoid to help with elevation and helps in compressing the glenohumeral joint. The microscopic picture, Clark and Herman described the microscopic picture of the rotator cuff in 5 distinct layers. The superficial layer is the coracohumeral ligament fibers, which are obliquely oriented to the axis of the muscle and span between the subscap and the supraspinatus. The second layer is composed of tendon fiber groups grouped into large bundles that extend from the supraspinatus tendon and form a layer of biceps. The third layer contains the tendon fascicles. The fourth is composed of loose connective tissue. These tissue merges with the coracohumeral ligament. And the fifth is a continuous sheet of collagen fibers that composes the joint capsule. Next important structure is the coracohumeral ligament. It starts from the lateral part of the coracoid process and blends anteriorly with subscapularis. It has 2 layers, superficial, deep. The superficial layer blends with the tendons of supra and infra, and the deep layer is attached to the fibrous capsule of the shoulder joint. The very important structure comes as the rotator cable. It is a curved extension of the coracohumeral ligament which stretches between lesser tuberosity and the junction of middle and inferior facet of the greater tuberosity. The cable runs from anterior to posterior direction underneath to the supra and infraspinatus tendons. The thickened fibers of the rotator cuff cable are perpendicular to tendinous fibers of supraspinatus. You can see this picture, the rotator cable and the rotator crescent. This is how it looks on a MR. So what is the importance? Its primary function is to distribute the forces across the rotator cuff complex. It helps the rotator cuff to remain functional in the event of partial or full thickness tears. It forms a suspension bridge between the tendons of the subscapularis and the infraspinatus, and its mean thickness and width are 12 and 4 mm respectively. Next one is the rotator crescent. This is a thin crescent-shaped sheet of rotator cuff which consists of the lateralmost end of the supraspinatus and infraspinatus tendons. It is a relatively avascular zone of the rotator cuff which tears easily. An inadequate vascular supply of rotator cuff tendons has made it associated with cuff tendinopathy pathogenesis. This critical zone of decreased vascularity described by Codman resides approximately 1 centimeter from the cuff insertion to the greater tuberosity and is most common site for cuff tendon injury. Its dimensions are, as described by Burkhardt, are 41 mm and to 14 mm, mean thickness being 1.8 mm. So the cuff is categorized in 2 types, basically. They are cable dominant and crescent dominant. The rotator cuff is thick, the rotator cable is thick, and rotator crescent is thin in old individuals, but it is dominant in younger age groups because of thick crescent. The strength of the superior rotator cuff is more dependent on rotator cable integrity in older patients. Next is the rotator interval. It is a relatively semi-functional and empty area in the rotator cuff. The anterior, it is divided in 2 parts, anterior and posterior. The anterior is a triangular space in the superior anterior portion of the shoulder joint, and its borders being the supra, subscap and the base of coracoid. The posterior rotator interval is located between the supraspinatus, infraspinatus. It consists of glenohumeral capsule fused with supraspinatus tendon medially and infraspinatus tendons laterally. Microscopically, it has 4 layers. First being the superficial fiber of CHL. Second is the amalgamation of this coracohumeral ligament and the rotator cuff tendons. Third includes deep fibers of the CHL. And the fourth is a combined sheet of SGHL and capsule. So this is the MR picture of the rotator interval. So what are the functions of the rotator interval? It acts as a shackle to prevent extreme flexion, extension, adduction and external rotation. It stabilizes the humeral head against inferior translation during extreme adduction. It steadies the humeral head against posterior translation during extreme flexion or external rotation of abducted shoulder. We come to the biomechanics. The rotator cuff is, if the rotator cuff is intact, the humeral head is located in the center and completely congruent during movement. The rotator cable keeps humeral head centered because of force coupled between subscapularis and the infraspinatus. The supra, infra and subscap are active stabilizers. They prevent depression of the humeral head in overhead abduction and superior migration towards the coracohumeral arch in initial abduction. Both these tendons provide force coupled to depress the humeral head and restrict it from migrating upward during early abduction. The deltoid and the supra act as a force couple in the coronal plane, compressing the humeral head to the glenoid in abduction, whereas the subscap and infra provide a compressive joint reaction force in the axial plane. The presence of rotator cuff tear leads to the failure of this mechanism and causes upward displacement of humeral head. The suspension bridge. Burkhardt demonstrated that the uppermost suspension cable of a bridge transfers the force to the towers that are located at the ends, in this case the LT and the GT. Here the rotator cable stretches between the lesser tubercle and the greater tubercle below the middle facet. The rotator cuff distributes the stress forces created by the supraspinatus tendon, and this mechanism prevents tear of the rotator cuff crescent. If the above mechanism is explained by the stress shielding effect of rotator cuff to the thinner tissue of the rotator crescent. So it's important to know that this stress shielding effect is more effective in old individuals and young athletic because of thin rotator crescent, where the crescent is dominant rotator cuff. So violent contraction of supraspinous tendon may lead to tear of the rotator cuff, causing painful arc syndrome. The rotator crescent is much thinner in shoulders of old subjects and is damaged even in trivial trauma. These are the cable dominant rotator cuff. The cable is better able to shield the cuff from loads than a crescent. This mechanism explains asymptomatic and minor symptomatic clinical presentations and why rotator cuff tears are biomechanically more debilitating than rotator crescent tears. Thank you.
Thank you, Vaibhav. Next, Dr. Sandeep Birari. Okay, so let's wait until we see Dr. Sandeep Birari on dais. Let's have Dr. Parth Agarwal, who will be talking on the lateral decubitus versus the beach chair. The positioning has got a lot of significance with respect to the surgical techniques. So, sir, you prefer lateral or instability specific positions?
Basically it's our training which actually helps you over a period of time. So I think over a period of time we should be well versed to do either position, switch every time. But overall, all rotator cuffs and Pancards are done always do it lateral position. And for the beach chair, arthroscopic letage, AC joints, shoulder replacements in beach chair. But I feel that we should be, there are certain conditions. For example, we want to do an anterior dissection. For example, subscap is very much attractive. Those kind of scenarios, I think we should be trained for both. Keep switching to period of time.
Thank you, sir. I would like to thank IAS Society and Dr. Sandeep Birari sir and Nilesh Karma sir for inviting me for the topic. So all of us have been talking about rotator cuff, slab, bankard. We need to know about the position. Every one of us majority of us are doing in lateral positions. There are a few of us who have been trained in beach chair. But yes, we have shifted back to the lateral position. So here I would say that there are only two positions, that is lateral decubitus and a beach chair position. Lateral decubitus is the most commonly used one. So these are the two positions. One is the lateral position in which the arm is hanging, and the other one is a beach chair in which we sit like a chair on the beach. So these are the two traction tables which we can see. The one which is on the right side is the spider, which is generally used for a beach chair position and a good one and a comfortable one. We even use it for a lateral position. And the commonly used one is the lateral position one, which we all have an Indian made one. So lateral decubitus position, how should be the position? The patient is placed in a lateral decubitus with the affected shoulder exposed and is supported by a beanbag and a kidney rest. Kidney rest is a side support which is being used so that the scapula stabilizes. All pressure points should be covered, they should be padded with a pillow. Acromion should be ASRS, below knee, lateral malleolus, and pillows between the knee and ankle should also be done. Now, how do we position it in a lateral position? We should have a 20 to 30 degrees posterior tilting so that the glenoid will be parallel to the floor. The advantages of this lateral is that it gives a less amount of traction, it decreases the risk of neuropraxia and brachial plexus. It also has an accentuation of the labrum, glenoid labrum, as it is pulled away from their beds, and improved arthroscopic access to the inferior third of the glenoid labrum and capsule. Vertical and longitudinal traction with the most traction applied vertically to distract the glenohumeral joint without subluxating it inferiorly. Generally, we apply around 4 to 5 kgs of traction in a 30 to 60 degrees of abduction with 20 to 30 degrees of forward flexion. There are 23 to 30% chances of neuropraxia if there is an excessive arm traction. So we should be very careful about applying the weights. Now this is generally, there are two types of lateral traction. One is the one which I would not like to name the company, but they definitely have an abduction traction, whereas the other one which we generally use is a simple pulley one. So now this is a beach chair position. As you can clearly see here in the beach chair position, the arm is rested, and here we generally use a spider so that the arm is freely mobile and we can give a good amount of traction and an opening in the joint which helps us out. So beach chair, the benefits are you can give an intestine walk, faster and easier positioning, reduced risk of neuropraxia. It is less distortion of the intra-articular capsular anatomy. It eases in orientation. Surgical manipulation in the subacromial space is easy, and easy conversion to the open surgical procedure. Complications are definitely there. Difficulty in working from posterior portal. There can be due to hypertension, there can be a stroke, and there can be a death due to hypertensive episodes. So the major challenge which all of us face in a beach chair position is this guy. So majority of us don't have this head support, which is usually should be there. So if you don't have a head support, definitely you should not go ahead and do a beach chair position. I feel that it becomes difficult to stabilize the head without a headrest. So yeah, these are the advantages of the lateral decubitus in a beach chair position. As you can clearly see that the traction increases space in the joint and subacromial space. Traction accentuates the labral tear, and cautery bubbles move laterally out of the view, and there is no risk of bradycardia or hypertension because there is a better cerebral perfusion in a lateral position. Whereas in a beach chair, you have an upright anatomic position, you have an ease of examination under anesthesia. There is no need to reposition or redrape to convert into an open procedure. Can use a regional anesthesia, and mobility of the operative arm is always there. Now the disadvantages of the lateral decubitus position are that it is a non-anatomic one. You must reach around the arm for an anterior portal. Patients do not tolerate the regional anesthesia in the lateral decubitus position. Traction causes a neurovascular injury, and there is an increased risk to the axillary nerve or musculocutaneous nerve when we do an anterior-inferior portal. Whereas the disadvantages of the beach chair position are potential mechanical blocks to the scope in the posterior and the superior portals, increased risk of hypertension and bradycardia. Cautery bubbles definitely are there in a subacromial space. They don't move out. There is a fluid, can fog the camera. And expensive equipment if beach chair attachment with or without a mechanical arm holder, that is a spider. So this is generally the position in which we do a lateral. So the surgeon, assistant surgeon, scrub nurse, a Mayo trolley, and an arthroscopic stack is there, and the anesthesia is on the head end. Thank you.
Thank you, Dr. Pal. So next we have Dr. Sandeep Biraris, who is going to talk on the clinical examination. That will be a quick lecture, but it's an important thing that you should all be knowing.
Yeah, thank you very much.
Thank you.
So I'm sorry for coming in late because as the name suggested, clinical drowning. So somehow my whole presentation got lost and I was not able to present it.
I thank the
So I just prepared it.
So I thank the Vice President and the Secretary of NMOA for gracing this occasion. So please, thank you so much. So for us, at times the anesthesia guys decide that whether you want to go ahead with a beach chair or you will not do beach chair because the blood pressure of the patient is shooting over the roof. So you go with a lateral decubitus. Exactly. And if the epilepticus happens to be a female, then you don't have any say in that. Okay? Otherwise, you will be.
Yeah. Thank you very much. So, just bring it on the screen, please. Earlier it was coming, no? Presenter view. इसमें आइए दिखाइए presenter view दिखाइए. Thank you. Sorry for the glitch. So quickly we'll go through the clinical examination of the shoulder. Because nobody is wearing, and I'll complete my presentation with the same. So when we are examining the shoulder patient, so what we should know the history in detail, mechanism of injury is important because we would like to know how the patient has fallen and there are any associated issues like if involvement of other structures around the shoulder, means like a cervical spine or something. You always begin your presentation with the inspection. You inspect thoroughly from front, on sideway and from the back, and check for patients any asymmetry of the shoulder as well as cervical spine. Next thing is range of motion. Check thorough range of, get the patient's complete range of motion. Always compare it on the opposite side. Abduction, if patient is able to abduct fully, then able to bring it down. Complete adduction on both the sides. External rotation. Then stand behind the patient and ask him to check the extension, and again complete internal rotation. Try and see for where he is able to reach with the internal rotation at what level, and note it down. And always carefully examine supra and infraspinatus for any swelling or tenderness. Next one is an important part of the rotator cuff examination is a check for impingement, like takes patient's arm, press it passively, again in the repeated way, check it if patient can load the shoulder joint with the internal rotation and adduction, and check if patient is getting pain. So this impingement sign is very important. The next one comes the rotator cuff. So three important tests like full can test, empty can test and drop arm test. So ask patient to abduct, then bring it around 30 degrees of flexion with both the thumbs pointing upwards, and ask patient to lift it up. You always check the integrity on opposite side. Similar fashion, patient abducts around 20 to 30 degrees and then rotates internally and checks the, so it tests supra as well as infraspinatus tear. Another test is like a drop arm test. Passively abduct patient's shoulder and ask the patient to break it down, and you can see patient is wincing or finding it very difficult. At some arc of motion, there is an increased pain. Then the next comes the subscapularis. The important test for the subscapularis: internal rotation lag sign, Gerber's lift off, bear hug and belly press. So belly, I'm directly going to the lift off. Completely internally rotate, ask patient to rotate, and then ask patient to lift it off from the patient's back and check the integrity or strength on either side. So that's the lift off test. Next one is the internal rotation lag sign. Ask patient to internal rotation completely, pull it, and again check for the lag. If it is again falling off or it is not staying in the same position. Now that's a normal subject, so we cannot elicit very clearly there. Then next important is like infraspinal and teres minor. So this is a particular article by Alexander Lederman. So he has classified the various tear patterns like upper subscap, supra, upper lower subscap, supra in that same fashion. Then supra, infra and teres minor. So what he says, so there are tests for the teres minor. So that's external rotation lag sign. Patient is seated, can be done in a sitting position or standing. Patient is seated, elbow is around 90 degrees flexed and shoulder is in 20 degrees of flexion in a scapular plane. Ask patient, he is able to doing the external rotation, and then is complete external rotation, reduce it 5 degrees and leave it. If patient is able to maintain, then that's normal. But again it is falling off. That means if there is a recoil, that is there is a lag of external rotation. So that's very much pathognomic of teres minor tear. So I feel that sitting up test gives very much result, better result, and this standing test. Then another important test for the external rotation for the teres minor is the drop sign. Keep elbow at 90 degrees. Shoulder has around 90 degrees of flexion in a scapular plane. Do the complete external rotation and leave the hand. If the hand stays or maintained in the same position, that's normal. But if it falls anteriorly, then that means there is a tear in the external, that's the teres minor. In a similar fashion, patient is able to maintain here. Actually, the elbow should be supported. Next one is called as Patte's test. So where it is similar fashion, support patient's elbow and then ask patient to try and touch your palm. So is patient able to reach there? That means its teres minor is normal. Thank you very much. Sorry for the glitch.
Thank you, Sandeep sir. Thank you so much. Now there's only one man between you guys and lunch. And a good friend, Dr. Sajid Usman, who is going to take a talk just before lunch session.
Rambo is supposed to have a hat or
give him gun.
Cowboy? Yeah, gun.
Gun. So I'm sorry to come out of turn, and this presentation is a very short presentation on the double row rotator cuff repair. I'm not a huge proponent of any double row for all, but I'm just reviewing literature and what I do if I think or consider doing a double row rotator cuff is what I'm going to present in this. Okay. So I would like to disclose that I've used AI and I've sourced some of the videos from online, and this is for educational purposes only. And I have no other disclaimers or any industry disclaimers to give. But the concept of a double row rotator cuff is not new. Joe De Beer and Burkhardt in as early as 2002 have published techniques of double row rotator cuff repair, and this is pertaining to the anatomy of the cuff insertion. So the anatomy was highlighted much later by Curtis et al. In his article, where he clearly showed that the footprint is way more than 2 centimeter, and in the AP view direction it is more than 4 to 5 centimeter. It is a wide footprint attachment. So we are talking about not attaching the cuff back in one line, but to recreate the footprint anatomy in itself. And the same thing you can observe on your MRIs as well, where you can see that this at the average insertional distance of the footprint is ranging between around 1.2 to 2 centimeters in width, based on the kind of individual that you are analyzing. So if you would like to recreate this footprint anatomy, theoretically you can do this only with a double row rotator cuff repair. Because the first and the foremost advantage that you can explain to a patient with a double row cuff repair is it increases the contact area of the rotator cuff on the footprint, thereby improving the biology. And the pressure of the rotator cuff back onto the footprint is much better with a double row configuration. Although functionally, if they ask you how better is the double row in comparison to single row, imaging has proven that partial retears do occur with a single row, but functionally there is no difference in majority of the meta-analysis comparing a single row and a double row. But I would reserve this kind of repair for only the massive rotator cuff repairs. So how does one perform a double row cuff repair? You can do it either by just taking a suture and fixing it laterally, but then it becomes like a pasta lesion because the articular surface of the rotator cuff doesn't come into contact. So the ideal way is to put a medial row anchor and a lateral row anchor and connect both of them to one another. Historically, there are different methods of fixation that they have come across, the suture bridge being the most acceptable one, where the medial row anchor and one suture is crisscrossed towards the lateral row anchor. So if you talk about how many anchors, they have compared biomechanically 2 anchors medial, 2 lateral, to just two anchor medial and one lateral, which is my preferred configuration. Biomechanically, there is very marginal difference between two anchor medial, two anchor lateral, and the two anchor medial and single anchor lateral. So how do you go about it? You are not inclined towards a double row cuff repair when you do the surgery. So once you start analyzing the cuff tear, if it is a cuff tear which is having a very high tension repair, I would not even think about a double row cuff repair. I would just medialize the cuff and do the repair in a single row. So if you would like to place and decide on a double row, you should place the anchor on the medial border of the footprint and take sutures which are mattress configuration. Now when you are taking these mattress configuration, one should ensure that you do not take very deep sutures like a single row suturing where you should take in the muscle tendon junction. You should take it slightly away because then you are giving a very high tension repair if you are taking deep sutures, because these medial knots that you have placed is going through a knotless push lock like anchor which you place on the lateral row. And this anchor can be placed, like I discussed, it can be two anchors, both medial and lateral, to give equal compression on both sides. But in our setup, because of the financial situation, especially in Indian setup, we go ahead with just a single anchor. Now I have burned my hands in all possible ways in these kind of repairs where I have pulled out all anchors, bio, peak, that's what I was just discussing with Sanjay. So this is not as smooth or clean like the video that we see here. Most often the Indian bones are porotic, and once you're putting the lateral suture, the lateral anchor, you find that at the end of the procedure that the lateral anchor is in the gutter. So medial sutures are essential because most often that's the only one that's holding at the end of the surgery. So placing a medial suture and knots on the medial row and compressing towards the lateral row can complete a double row repair, so ensuring that you won't fail, but they do fail. So all kinds of single row or double row have a equal chance of failure. There is a major meta-analysis which was conducted, and both types of failures, which is at the tendon junction and at the footprint, these both kind of tears are found equally in the single row and double row kind of repair patterns. The additional concern that I have with a double row kind of repair strategy is the number of sutures. We are putting so many tapes, materials and sutures in the subacromial space. What essentially happens to them? Do they get synovalized? Does the body reject them? Does the anchor back out later? There are so many reported articles of anchor back out at a later stage where people have redone scopy and seen the anchor just lying in the gutter. So we are talking about a procedure which can give reasonable results biomechanically, but practically it does apply in your clinical practice. But I reserve it to the kind of 3 centimeter plus easily reducible rotator cuff tears. And if I am sure that there is not high tension repair, then only then I go ahead with a lateral row, adding it on the table, or you can take a decision on table to go ahead with this kind of repair. Thank you.
Sir, you said that you have burnt your fingers with all kind of anchor pull-out. So if your anchor pulls out on the lateral side, you wanted to do a lateral row, and the anchor pulls out, or the hold is not good, what is your go-to thing that you do?
So in the last case, I just snipped the sutures and accepted it as a single row. But the kind of, in the case that I had a pull out of the lateral row anchor, it was actually an anchor with wings. This is one of the best anchor, apparently, which gives the maximum lateral hold. I'm not saying which company. But I had a struggle pulling out the anchor. At the end of it, I saw the cuff was still not reduced because it was mattress sutures which the knots had cut through the muscle tendon junction. So I inserted additional lateral metal anchor and just took some more sutures. Ultimately, I think the goal of a cuff repair, even if you can restore the anterior supra and the infra back into its position, the concept can work and they do work.
Can I answer this question? So if it pulls out, instead of putting another anchor which is 20,000-30,000 more, you can just put a cement and reinsert the same anchor.
So I do have a published paper on this surgical technique in which you just take, the cement is available, it is cheap. In all the operation theatres in the world, we have cement. Just take it in the 50cc syringe with long nozzle, put it wherever the bone defect is, push it, shove it inside. As soon as it becomes dummy, only then you remove it. Otherwise, the cement goes all over in the subacromial space. Once that is done, you insert your anchor and you wait until it curates. I have 12 patients of mine, and then one of the senior surgeons has more. It works really well, and it does not bother.
We have seen that video. It's a very good video, very good technique. But
in Indian scenario, we have multiple this thing. Bone cyst is there, the osteoporosis.
So since
is there,
we are discussing about pull-out, if we ask the faculties each other, which kind of industry, which kind of anchors do you use for your lateral?
I don't want to answer that. I'll tell you because it's conflicting with the hospital.
Okay.
Thank you. Thank you.
Nitin sir.
check, hey, hey.
हाँ अभी देखिए बस क्या है check 1 2 3 7 8 ये देखिए इतना ऊपर थोड़ी जाएगा आना चाहिए ना अभी इसका भी फिल्टर बंद कर माइक का भी बंद कर सब बंद कर दे सब बंद कर सब म्यूट कर
Hey. Check, hey, check.
Yeah, bro.
Check, alright? Check, hey, check, hey, check. Clear? कुछ है? Check, hey, check.
तो चाचा अभी आएगा तुम्हारा
Check, hey, check, hey.
एक मिनट देखो
Check.
वही ईपी डाला हूँ देख लिया ना देख लिया ना मेरे वो आपका सरोवर से प्रॉब्लम अब मेरा ईपी वही डाला वही आ रहा है तो मेरा एक दूसरे नहीं आता कैसे आएगा
check. Okay guys, जा रहे क्या आवाज वहां तक? ओके आ रहे हैं, नहीं आता ना? ओह okay guys, I believe the lunch should be over by 2 o'clock. There's one small request to all the faculties as well as the delegates. Please do visit the registration counter and write down your MNC codes. That's important for the accreditation. So in next 2 minutes we are going to start with our post-lunch.
अरे वो नतीले तो आगे को पीछे सर आगे वीडियो है सर हाँ
ऐसा पहनना है पड़ता है रे, हम सब उल्टा पहना रहे हैं। Now it is correct. Jack Sparrow. So I believe this is the right way to wear it. So guys, please hurry up. Sir, चालू कर लो. यहाँ पे सर इधर आइए. सर बैकग्राउंड ये चाहिए. So next, we are starting with this session. Please here guys, someone try to finish up with your lunch. Next in line is Dr. Samir Pilankar. He's a senior surgeon out here, arthroscopy, specialization and sports medicine. There's a lot of work in and around the suburbs as well. He'll be talking on knotted versus knotless versus trans-osseous equivalent repairs in the calf. Dr. Pilankar sir.
you, Nilesh. And by the way, fantastic organization and a great idea to put this as a topic for the conference.
Sir.
The theme is fantastic, and I being a super nerd, I'm into all this nerd culture. I really okay. Not so much into pirates, but into MCU. So today I'll be speaking on something which is, we use it day in and day out, the anchors. And specifically on knotted, knotless and the transosseous equivalent construct. So I remember during our childhood days we had only Doordarshan and there was no confusion. We had just one channel. And afterwards we had, now presently we have a plethora of channels and we are always confused what to watch. So that is same problem, the decision paralysis. When you are faced with so many options, sometimes you have a decision paralysis because of the cognitive overload. So I'll try to dispel some of the confusion in the decision making regarding which anchor to choose and in which particular tear, which particular bone. So that is very important. Abraham Lincoln had famously said that there is more than one way to skin a cat. But more recently, Dr. Strange has said in the multiverse of madness, in the multiverse of options, like the anchors, there is never just one good anchor. There is no one good way. So that is so very true in anchor selection. So the ideal anchor should be someone like Superman, which is the ideal superhero. It should be easy to insert. It should have excellent security, good pull-out strength, either whether it is knotted or without knot. It should hold the repair very strongly, and also it should be cost effective. Unfortunately, we don't have such an anchor, but maybe in the near future we'll have this ideal anchor. At the moment we have to make do with whatever best anchors we are having, which are also not too bad. So there are three main contenders for the top spot. We have the knotted anchors, which we have been using for so many years. The knotless anchor, which is the new kid on the block, which is also good. And the transosseous equivalent construct. It is not actually an anchor, it is a group of anchors, so I would call it a construct rather than an anchor. And so these are the three main contenders for the top spot. Let's start with the knotted anchors. It has been there since many years. All of us have started using when we did shoulder arthroscopy with the knotted anchors. All of us know that it has excellent stability. Also, you can precisely control the tension. It depends on how much you push it, you can control the tension. But it suffers from these problems. Sometimes it is technically demanding in your early learning age, because the knot tying sometimes can get cumbersome. You can get knot entanglement, thread entanglement, and if the knots are not properly tied, you can have loosening and repair can fail. Also, if you land up having bulky knots on the glenoidal side, they can cause glenoid articular abrasion, which is a common thing seen. And on the subacromial rotator cuff side, you can have impingement. So these are the problems with knotted anchors. Also, they take a little bit more time than the knotless. So the next innovation was the knotless anchors. So everybody has used this. It is very simple. There is a guiding thread which pulls the actual anchor fiber wire into the repaired tissue. So it simplifies the technique. There is no need to tie a knot. It saves time, and also more importantly, it avoids bulky knots, which is very important. All the knot related problems which you used to face with the knotted anchors are no longer with this. So the knots are not there. There is no risk of glenoid abrasion,
no risk of impingement. But always anything good comes with a caveat. So even with the knotless anchor, there is a small caveat. It relies, when you tighten the thread, it relies on good bone strength. If the bone strength is not good, it can just pull out. Also, sometimes it is less secure than the knotted. And over the years, months, weeks, because of micro motion, if the healing is not proper, the construct can loosen up. Thirdly, what I personally feel is the feel. When we tighten a knotted anchor, we get the feel of the tightness. That is missing. So that kick which you get while tightening, that is missing. But you can get used to it. So the third thing which is there, which is the trans-osseous equivalent construct. It is a construct, not an anchor. It is a group of anchors put in a proper way. So we had this trans-osseous technique, which was a bit cumbersome when we do it arthroscopically. Because getting the tunnels, getting the threads into the tunnel, all that is a bit cumbersome compared to putting in just an anchor. So they have come up with this trans-osseous equivalent, which is the double row repair, in which we put a medial row and a lateral row, and it works just like the trans-osseous. You get better stability. Also, more importantly, as Sajir has already explained to you previous talk, it recreates a natural tendon footprint. So tendon footprint is about a centimeter long, and it gets the entire tendon there, and it helps in healing better. Since the load distribution is better, there is better strength. Also, many studies have shown that it has less re-tear rate. Okay. But again, anything good has a bad side. So there is a bit longer surgical time initially, because you need to put in one more anchor on the outer side. Cost is a deterrent, almost 20,000-30,000 more, depending on amount of anchors you put. Slight more expertise, learning curve is required. Also, if the tendon quality is poor, Gottlieb 3, 4, then the repair is not that strong. You can compromise the repair. So each of these has some pros and cons. So they have done some comparative studies comparing each of these, knotted versus knotless, and single row versus double row. So I'll just mention two studies for the sake of brevity, which compare the knotted with the knotless. One is Zio, who did a big, there's a big conspiracy here. So there's a big meta-analysis he did a big meta-analysis of 10 rotator cuff repairs, randomized controlled trials, more than 1,000 patients. And Sahin, in 2021, he published a study of 800 patients. And there are a few more other studies. All of them have come to the same conclusion. So there is no significant difference functionally or otherwise in the re-tear rate, pain and movement if you compare knotted versus knotless. The time is definitely lesser in knotless. But the anchor selection is basically guided by the surgeon preference. Like, I want to wear jeans, you want to wear bell bottoms. There is no scientific evidence backing a particular
knotted versus knotless. So you can use either if you are using just one anchor. So there have been studies comparing the double row repair versus single row, that is the knotted knotless. And again, multiple studies. I'll just mention two again for the sake of brevity. Guardsman in 2013, in a prospective trial, over almost a year, compared 90 patients
with ultrasound and MRI and studied the healing. And Yakamoto also did a prospective randomized controlled trial in medium tests. First was with the large test, second was with the medium test. And over a year they followed up these patients,
and this is what they came to conclusion. There was a lower re-tear rate. Understand? In a large tear, when there is a large tear, there is a lower re-tear rate. So the double row repair scores over single row repair in a large tear. And functional outcomes, but in medium tear, they are the same. So large tears, if you have, go for double row repair. If it is a medium or a small tear, you can get away with a single row tear. Single row tear still remains effective, especially if the bone quality is poor or the tendon quality is poor. In this case, they would prefer going in for a single row tear, single row repair. So this is a take-home message which I want you to take home when you start your surgery. There is no universal winner, and the technique which you decide depends on the tear pattern, whether it is small, medium, large, the tendon quality, the bone density, and your own expertise. And ideally you should master all the three techniques, because you never know which you might require in which patient. So you should be adept in all the three versions of technique if you have a rotator cuff tear. My choice, if I get a rotator cuff tear, then I would first analyze the tear. If it is small, medium, I go for either knotted, knotless, single row construct. But if it is osteoporotic, I would be biased towards using a knotted anchor, because there the pull-out rate is less. If it is a large tear, then I would definitely go in for a double row repair, because all the studies favor double row repair in a large tear. But again, if the tendon is friable, cochlear grade 2 or more, then I would go in for a single row repair and protect it. Always, when you get a patient, you think over it and analyze the patient's muscle tear and the bone quality, because for you it is just one surgery, for the patient it is that one surgery. Okay, so with as someone great has already said, with great power comes great responsibility. You have to take each patient with a lot of responsibility and give them the best. Thank you. By the way, this is from Stanley.
Any questions? Thank you. That was crisp and clear. Thank you so much. To talk more on the transosteosequal, we have Dr. Abhijit Savadekar out here. How about anything? If you look at it, it's basically also company-driven, market-driven, to move from knotted to knotless and something of that sort.
More than because finally the patient is going to not meet the market numbers.
Agreed.
Every good patient will get to 10 more patients.
So, but you are happy with the knotted ones, you want to try new, and then you don't have similar results as this thing, but still you will not continue for that for sure.
Yeah, of course.
So now, initially it was knotless. To start with, there were Mytech anchors which were knotless. Now it is like again getting back to the knotless ones, and in between it was knotted. So things have been changing. There are cycles and all the stuff.
Just like fashion comes and goes. This will come and go, but some universal principles will remain the same. The universal principle is get good tendon to bone approximation. How you get it is your problem, either with knotted or knotless. If there is a osteoporotic bone, I would definitely put a knotted angle, because there you are not so much relying on the bone to hold the.
मिस्टर क्या बोल रहे हैं इधर ऊपर रखो
This is getting पैर गिर जाता है जंप पुश
There's one. I think Dr. Naved is around. Yeah. So there's this one problem that is going on. So I believe if we can start with your lecture, and then Dr. Savadekar can come back again on the dais. So we have Dr. Naved Ahmed who is going to talk on, I think at one particular point of time, everybody's favorite, biceps SCR. Sir, one in the front.
Hello. So good afternoon once again. Thank you for the invite. So this talk is about biceps SCR and it is titled Biceps of Steel. So I believe actually the biceps is now being used more than it usually was. So the long head of the biceps, it was considered a pain generator, and there are multiple studies during the 90s and the early 2000s when people used to cut the biceps, do a tenotomy, and they could get pain relief. But then over the last few years, people have now been started using biceps as an augment, as a local biologic augment for rotator cuff repairs, and also for glenohumeral joint as well now. In fact, there is an editorial commentary in 2023 in the Journal of Arthroscopy from Alex Laderman, where he states that the long head of biceps tendon is useful for shoulder reconstruction, including glenohumeral stabilization. So now from biceps killers, we are now biceps users. So how do we address the long head of biceps and rotator cuff tears? We can either leave it intact, you can debride it, you can do a tenotomy, you can do a tenodesis, you can do a superior capsular reconstruction with it, and you can also now do a biceps rerouting. So in this talk, I will be talking about these two things. So superior capsular reconstruction was proposed in 2007 by Professor Mehta. He used the tensor fascia lata as a static stabilizer of the glenohumeral joint, fixing it on the glenoid and on the greater tuberosity so that it depresses the humeral head and the center of rotation is maintained and the shoulder works well. There are multiple papers for studying the outcomes of conventional SCR, and we have proved that it improves the scores, it reverses the pseudoparalysis, the return to sport and demanding work is good, it restores the acromiohumeral distance, it prevents cuff tear arthropathy, and it has excellent graft survival rate of about 90% at 10 years. And this is the article in this year from Mehta as well. So the graft choice which he used was tensor fascia lata, which had quite a bit of morbidity. So people started using dermal allografts and the long head of biceps as well now. So the biceps SCR The first study which came on it was from Professor Shil Chen in 2017, and he described it the Chinese way of doing it. So they started doing it because it was locally available, a cheaper option. It had already an anchorage on the glenoid, so no anchors on that side. It was less morbid because you don't need the TFL for that, and it was a faster procedure. Now after that, there are many techniques which have come in. So if on the lower bottom left side, if you see, there's a snake technique by Dr. Kim. Now on the right side, there's a box technique, the Chilemi techniques, so lots of techniques. But which is the best biceps SCR technique? So there's this article by Berthold in 2021. There are not many which compare the techniques, and these they studied the box shape, the single strand, and the V shape. But they found that all were equally competent. So there is lack of high quality evidence to determine which is the most effective technique. The outcomes of SCR, again, multiple studies which show that the biceps SCR improves the VAS, improves the AHD, it reduces the re-tear rate, and the graft failure rate is 5.6% at 1 year. But these are all short-term studies. We don't have long-term studies on these, and so we don't know whether they are as effective as the conventional SCR. So then what is biceps rerouting? So biceps rerouting was introduced by Dr. Kim in 2018. It is a concept similar to the SCR, but the long head of biceps is put a little posterior into a groove created on the humerus, which is followed by the rotator cuff repair. So the surgical steps are basically you release the transverse humeral ligament, take the long head of biceps posteriorly, create a bone groove in which the biceps tendon would sit, then fix it with 2 anchors, one medial and one lateral into the groove, and then complete your rotator cuff repair over it. So what are the good parts about it? It's a simple technique, it reduces the operative time, there is no donor site morbidity, there is a higher pull-out strength compared to anchor-fixed graft tissues. You don't have to put any anchors on the glenoid side, and it depresses the humeral head, thus it acts as an internal splint, and there is a biceps stenodesis effect. So if you compare biceps SCR versus biceps rerouting, the rerouting does depress the head, the biceps SCR does not. It also does not act as an internal splint, and therefore it does not give any biceps stenodesis effect. So there are some concerns while using the biceps in these surgeries as to what if there is associated biceps lesion? What if the biceps will generate pain? What is the graft thickness that you are getting from the biceps? What is the surface coverage when you are doing a biceps SCR, and does it really reverse the pseudoparalysis? So let's take them one by one. So if you have associated biceps lesion, say a slap tear, or the biceps is degenerate, or there is synovitis. So you know that in 88% of large to massive rotator cuff tears, you will have some kind of biceps lesion, be it a slap tear, a partial tear, a poly lesion. But this article by Kim, where they compared the clinical outcomes to subpectoral biceps stenodesis, they said that the biceps rerouting had similar re-tear rates, or even better. So that means even if you have a associated biceps lesion, the biceps rerouting would work well. What is the graft thickness of the biceps SCR? Is it good enough? So Mihata has said that when he used the TFL, he wanted a thickness of 6 to 8 mm. And in this study by Patrick Dennard in 2012, where they studied the anatomy of the biceps tendon, if you see here, at the origin, the diameter which they got in their population was 6.6, so that is in the range. So even if we might be a little lesser because we are Asians, the diameter should be good enough to go for the biceps SCR. Surface coverage, Mihata said that he wanted a width of 3 centimeters and a length of 6 centimeters. Now we know that we won't get a width of 3 centimeters, but there is this study from Han which states that effects of biceps rerouting technique to restore glenohumeral joint stability for large irreversible rotator cuff tears, a cadaveric biomechanical study where they approximated the cuff to the rerouted biceps, and that gave the coverage which was needed. And both these things, they significantly reduce the superior translation and subacromial contact pressure, but obviously we can state that the surface coverage is not as good as the conventional SCR. And does this really have an effect on the pseudoparalysis? So there are no articles which have studied the effect of biceps SCR or rerouting on pseudoparalysis. So we don't have any evidence for pseudoparalysis reversal on both biceps SCR or biceps rerouting. So we can surely say that if you have an associated biceps lesion, you could still use the biceps. The biceps does not generate pain. The graft thickness is good enough. But when it comes to surface coverage and pseudoparalysis reversal, we are still not very sure about the biceps SCR or the rerouting. So if you have a pseudoparalysis patient, the suggestion is to go for a conventional SCR. If you have a partially repairable rotator cuff and you want to augment it, then the biceps rerouting is a much better technique than the simple biceps SCR. If you want a 100% guaranteed result, go for the conventional SCR. If you want no donor morbidity, donor site morbidity, if the patient is very serious about the thigh being involved, so then you can have the biceps procedures. And out of the two biceps procedures that we are discussing, the biceps rerouting is a better biomechanical technique. We have short-term clinical outcomes for that, and it's a very easy surgery to do. So the take-home message is that we are now from biceps killer to we are now biceps users. Both biceps SCR and rerouting have the similar concept, excellent short-term outcomes, no evidence for pseudoparalysis reversal yet. Biceps rerouting has a reliable tenodesis and an internal splint effect, and the biceps SCR, there are a variety of techniques, there is no gold standard yet. Thank you so much. I would take this opportunity to invite all of you to this conference which we are having in March 6th and 7th. It's called the Young Arthritic Knee. It's a 2-day event wherein all these masters of knee are coming, and we are having a complete plethora of topics wherein we will be covering osteotomy, we will be covering conservative measures, biologics, uni knees, and total knee replacement as well. So everything about the knee will be covered in this. So please make sure you're there. Thank you so much.
Thank you. Any questions? Now, sir, what is your ideal point of fixation of the rerouted biceps?
So it's about a centimeter or 1.5 centimeter posterior to the bicipital groove. I might go 3 or 4 millimeters anterior or posterior depending on which part of the rotator cuff is amenable to repair. So if the anterior cable is good enough, so I'll go a little more posterior.
And you will always fix it with 2 anchors once you reroute.
Always 2 anchors.
So Dr. Abhijit Savadekar will be talking on transosseous cuff repairs.
Good afternoon, everyone. Thank you organizers for giving me this opportunity. It's a wonderful event, wonderful attendance and lovely talks. Dr. Samir Pirankar just talked about the anchors that we use in rotator cuff. He gave the details about single row, double row, transosseous equivalent techniques. I am going to talk about transosseous cuff repair. As Dr. Pirankar correctly said, transosseous rotator cuff repair is little tedious to perform, at least initially. Technically, it is, I would not say demanding, but there is a lot of suture management that we don't like to do. So generally, we don't prefer to do the transosseous repair. But I'll try to convince you to shift from anchors to anchorless surgery. Let's try. We have been doing open transosseous repair
for years together. Actually, rotator cuff, it all started with open transosseous repair. So what is transosseous repair? Basically, we put the needle through the bone and then through the tendon, and then that same suture is used to tie the knot. So that gives a kind of double row configuration. It gives very well compression of the tendon on the footprint. This technique we have been using for years. A lot of surgeons still use it because of the ease of doing it and the excellent results. But then came arthroscopy, and as we all were introduced to arthroscopy, industry started putting in anchors. So we started with single row repairs, where we just put the anchors on the medial side. That was probably not giving sufficient result when compared to the transosseous open repair. We shifted to double row repair, where we put the anchor on the medial side and we put the anchor on the lateral side. We tied knots on both medially and laterally, which gave us point fixation, but still it was not good enough. So we started doing transosseous equivalent repair, where we put the anchor on the medial side and then taking that same suture, we fixed it on the lateral side with the knotless anchor. Fair enough, but that has increased the cost of the surgery tremendously, using knotless anchor, knotted anchor. So why not go for transosseous repair? I'm not saying open, but arthroscopic. So what we do in transosseous repair, we actually make two tunnels, one vertical tunnel and one horizontal tunnel, and connect both the tunnels so that we can pass the sutures through that tunnel and tie the knots. This is why it is called transosseous equivalent, where the two anchors are put, the lateral row anchors are knotless. It looks similar. Transosseous equivalent technique and transosseous technique, when we compare both of them biomechanically, the failure load of transosseous equivalent technique is higher as compared to the transosseous, but it is not very high. Transosseous repair without anchor also gives fairly good failure load. Mode of failure in case of anchored transosseous equivalent technique is type 2 failure, where if the repair fails, the tear is at the musculo-tendinous junction, and that can be a problem while doing a revision surgery. Whereas when the transosseous repair fails, the failure is usually type 1 failure, where the tendon gives way from the bone. So that's the advantage when you go for revision surgery. Also, especially when we take the knots on the medial anchor, the perfusion of the tendon is lowered. So that is another problem. When we see the patient outcome, there are a lot of studies that show there is equal outcome on both the procedures. So how arthroscopic transosseous technique evolved? It all started by using a simple ACL jig, TBL jig, where the wires were passed and the sutures were passed through those wires, and the repair was done. Gradually there were a lot of development, there are a lot of equipment that were developed. A lot of surgeons are working today. At least 20 different designs are available in the market. Some of them use the drills, some of them use the nitinol needle, sturdy needle to make the tunnel. What I prefer to use is this arthrotunneler that was developed by Suman Krishnan way back in 2002. So this is a surgical video that I'll just present quickly. So this is the usual preparation of the footprint. That's the good bleeding bone. That's the reducibility of the tendon. So this is the vertical tunnel that I made. From a superior portal. Then here comes the jig that goes into this vertical tunnel. And other end of the jig is sitting on the lateral cortex. Through this lateral cortex comes another drill that makes the horizontal tunnel, and there is a grasping nitinol wire with which you can grasp the suture that you pass from the lateral side. This is how the sutures are passed. You retrieve this leading suture, and for this case, the interval closure was done with the one stage, which is seen here. And this is the transosseous leading suture, which is used to shuttle the fiber wires. Then the bites are taken in the usual fashion in the rotator cuff, and and the knots are tied on the lateral side to prevent the cutting of the bone. So that's the final repair. Here I use the single tunnel, but many times you need to use 2 or maybe sometimes 3 tunnels as well. This is the pre-op MRI of one of my patients. There was a full thickness tear. This is how it looks at 6 months, at the end of 6 months. You can see the tunnel there, transosseous tunnel. This is another pic. And this is 6-year follow-up of the same patient. The tunnels are completely filled up with the bone, with the excellent cover of the tunnel. What are the drawbacks? Drawbacks is learning curve, as we discussed, yes. Then the other problem is the suture cutout. When we tie the knots, there is high chance of suture cutout. How can we tackle that? Learning curve, basically the problem we face is with the suture management. What I have been doing now is I've been using different portals to park my sutures. These are 4 strands which are coming from 2 tunnels, which I park into 4 different portals, so that there is no confusion. Also, I use different color fiber wires for each and every bite. Suture cutout is another problem that is very common. Here, this we can avoid by using the tape instead of fiber wire. And knots can be put on the lower side of the lateral leg of the GT, so that the bone quality is better. Also, always put the knots on the lateral side rather than putting the knots on the tendon. There are some augments available which can be put on the lateral tunnel that avoids the cutout. So where can we use this technique? We can use in almost all the rotator cuff tears, supraspinatus, infraspinatus. Subscapularis, I have not been using it, especially because of the bicipital groove. Osteoporotic bone, yes, wherever you dare to put anchors, we can definitely use the transosseous technique. Some patients that get huge cyst on the GT with the cuff tear, this is the best technique to use. Again, revision cases, we can use it. And of course, this is financially very rewarding. I mean, not for the surgeons, but patients. Take home message, arthroscopic transosseous technique can be used for almost all the rotator cuff tears, and it gives best of both the worlds. It gives the advantage of arthroscopy as well as transosseous repair. Thank you.
Any questions?
Fantastic talk, by the way. This particular device which you use to make the tunnel, who provides it? Which company?
So this one have been using it from Tornier. I got it from abroad. The set comes, the set I bought, and there are disposable switcher passers that you get, which are not available, and until now they were not available in India. But recently, one of the local companies have started making it. They had patent issue, but the patent is over now. So this jig is available locally also.
That makes a little bit.
Yes.
At least we can start.
Yes, of course.
So Senthil Velan from Tamil Nadu has this developed arthro cuff. The advantages is, number one, is way cheaper as compared to the Tornier one. The second advantage is that it's reusable. So you autoclave it, and I have people who have been using it for at least 3 years now. Works wonderfully well. So it is more cost effective for us, and also if something goes like it's broken or something like this, it's easier to just get it from Tamil Nadu, and that's a good option. Arthro cuff.
It's the same as this?
Its principle is the same. It's just that it does not have any disposable. So basically, that instrument you can reuse it. You can autoclave it and reuse it. You don't need any extra cost except for the this.
Any vendors?
Any vendor? Yeah, that's what I was
You directly contact Senthil, and Senthil will get it.
I recently purchased it and sent you the contact.
Was it?
I recently purchased it and sent you the contact.
What is the cost?
75.80.
I tried it very hard during my initial days. Arthro tunneler had just come, but the company refused to give it to any of the consultants, even in the US. It used to only give it to the institutions, so I couldn't get hand. I'm sure you've done some big chore in getting it.
So let's hear subscapularis stairs by Dr. Fayaz again.
So again, thank you very much. Am I able to see? So I'm Dr. Fayaz Memon from Mumbai. I've been given this topic, arthroscopic subscapularis repair. These are my credentials. So why is subscapularis very important? Unlike what we used to see earlier when we learnt rotator cuff, subscapularis happens to be the most powerful of the rotator cuff tendon. It's the key stabilizer, forming anterior force couple and giving good amount of humeral head depression. If you miss the diagnosis of subscapularis tear, it can result in poor cuff repair outcomes. So you need to always suspect a subscapularis tear where there is a biceps pathology. Anatomically, it is the largest of the rotator cuff muscles. It covers the full anterior surface of the scapula. So it is Sari Khudai ek taraf, Joru ka bhai ek taraf, something of that kind. So it's subscapularis on one side and 3 tendons on the other sides. 50% of the rotator cuff strength is formed by subscapularis, and the attachment is in 2 parts. The superior 2/3 is the tendon and the inferior 1/3 is the muscle. When you see the subscapularis arthroscopically from your posterior portal, it is just the superior 1/3 of the tendon. The remaining 2/3 of the attachment is basically covered by the capsule. So there's a large portion which you cannot see from the posterior portal. So this is the subscapularis viewed from the posterior portal. This is dry scopy. The footprint, yes, it is, as we all know, on the lesser tuberosity, 3 centimeters into 2 centimeters. The anterior border, of course, it's bicipital groove, and it provides stability to the biceps. Extra-articular portion, the superior 1/3 is behind the coracoid. The muscle is crossed by brachial plexus and axillary artery, and inferior 2/3 it is crossed by axillary nerve. This is all important when you are doing a subscapularis repair.
Innervation is different from what we see in the supraspinatus and the infraspinatus. There are twigs coming out from the brachial plexus which supply the subscapularis muscle. Here is the video of Laurent Laplace, who has shown the nerve supply to the subscapularis through the lateral portal, the D portal. So the tear could be degenerative or traumatic. It could be vertical, partial superior 1/3 with retraction extending up to the inferior 2/3. In anteroposterior plane, it could be just deep layer only, or it could be complete tear, and the mechanism could be from up to down or down to up, from deep to superficial, or the other way. So what can subscapularis cause? Subscapularis tear would cause anterior superior migration of the humeral head and the coracoid, subsequent coracoid impingement. There could be muscle atrophy if it is left alone, which could be irreversible. It could be associated with biceps tendon, either subluxation, dislocation, or a tear, and of course a supraspinatus and an infraspinatus tear along with it, whether it is separate or attached to it with a comma sign there. Most important classification is for subscapularis tear has been given by Lafosse. Type 1 is just abnormal attachment, need not do much about it. Type 2 is just superior 1/3 of the tear. These all types are important. What is required for what kind of a tear and what kind of surgery is to be planned. Type 3 is a tendon tear, but the muscular part is attached. Type 4 is completely torn tendon with retraction, and type 5 is complete tear with anterior subluxation of the humeral head. These are the tests for clinical evaluation. When you see from the posterior portal, what seems to be just a benign fraying of the muscle could turn out to be a big tendon tear when you push the humeral head posteriorly. And you can see A is just simple looking tear, which actually is a bigger tear when you push the humeral head posteriorly. If you use a 70-degree scope, it could be much more than that, what you thought, even by pushing the humeral head posteriorly. Here you can see when the humeral head is pushed posteriorly, a sort of fraying, it looks like simple looking fraying could be a bigger tear. So for visualization of these bigger tears, you might require, from posterior aspect, you might be seeing just the superior 1/3. For the bigger tears, you might require to use the C portal, which is along the line of the superior border of the subscapularis, where you can see the superior 2/3 of the tendon and the muscle. If it is completely retracted, then you might have to use a D portal, which is nothing but our deltopectoral approach portal basically, and it gives access to the whole muscle tendon complex along with the brachial plexus if you actually go on to look for that. So while releasing these larger tears, posteriorly you need to release the deeper layer of that is glenohumeral ligaments. Superiorly it should be coracoid tear. Anteriorly the plexus and the axillary nerve. You need to actually go in and release those. Otherwise, as you pull them, if it is long standing, you might land up damaging the musculocutaneous nerve or the axillary nerve. The portals used for anterior superior and the portals used are basically anterior superior, anterior inferior, depending upon what trajectory is required for the fixation of the anchors. For the superior 1/3, it has to be close to glenohumeral and coracohumeral ligaments. Deeper layers, of course, inferior anchor is supposed to be used first. If it's a massive tear, you might require 2 anchors to make the footprint fixation. So this is a simple looking type 2 tear, which is seen from the posterior portal. You just clean the lesser tuberosity, take in the bite, see whether the tendon comes back, take in a good nice bite, 1 or 2 of them through the tendon, and then you can just fix it to the bone by means of an anchor. You can do it the other way, you can put in the anchor first and then you can take the bites, etc. So once you fixed it, you're done. If it's type 3, then you might have to take the C portal along the line of the superior margin of the subscapularis and see the retractability of the tear. Once you are convinced that it is retractable, you can put in your anchor into the lesser tuberosity, and then in whatever way you are comfortable, either the antegrade or a retrograde suture passing device, you can take the bites through the subscapularis and then fix it. For the type 4 tear, you need to use the D portal, where you need to clear out all the mess that is around the subscapularis and then use 2 anchors and do a footprint fixation. I'm just cutting short. For type 5, you can use an open repair. If you are not able to do it, then you can do a pec minor or a lat dorsal transfer. Pec minor is not the best transfer to do because it comes from the anterior aspect of the chest. Actually, the line of the shoulder is not this way. It has to come from posteriorly. So lat dorsal transfer is a better transfer. You can take a catch hold of your plastic surgeon friend for doing that. You have to treat the associated issues like coracoidplasty, long head of biceps stenodesis, and if there is a supraspinatus and infraspinatus tear, you need to repair them, not before repairing the subscapularis tear. You can come across extensive problems like more bleeding, neck and chest swelling, brachial plexus injuries, etc. So you need to be really careful. If it is an isolated tear, just fraying type 1, you can just keep it internal rotation and that does the trick. If it's a massive posterior and superior anterior tear, small abduction pillow needs to be used. Remember one thing, immobilization should be for 6 weeks. Do not worry about stiffness. It's easier to treat stiffness than getting the tendon avulsed, and no passive or external rotation or active internal rotation for full 3 months. This is the recommendation by Laurent Lafosse. So in a nutshell, keep high index of suspicion. You might be surprised that 40 to 50% of the cases might have this pathology. Type 1 we can conserve with a sling. Type 2 and 3 give good results with arthroscopy, arthroscopic procedure. 2 usually you can do inside the box technique, that is through the posterior portal. And type 4, yes, you get good result in terms of pain and functionality, but the strength may not be there. Type 5 you can do and wait for results and pray to Almighty or invest in Bible. Thank you very much for your kind attention.
So you would directly go for an open in case of chronic retracted tears, or you would give it a try arthroscopy?
If it is it's a massive muscle, so it's not going to come. More so anteriorly, the release and everything, at least at my hands, I would not take that chance. I would straight away go and keep a backup of a tendon transfer, because usually type 5 don't come even with open. That's my experience, whatever little experience that I have.
So there are at times, there's just significant tendinosis, there are laminations along the tendon of the subscap. So if you see them arthroscopically, do you do anything to them or just leave it the way it is?
Leave it the way it is.
Leave it the way it is.
Yeah, if it is not torn.
There's extreme
tendinosis,
but there's laminations across the tendon length itself, right from the insertion to the...
Yeah, but if it is if the insertion is intact, I would not do anything, because even if the insertion is frayed, that's type 1. I still have, it's the recommendation by nobody else but Laurent Lafosse, you can call father of subscapular modern, he has said just sling in internal rotation. I would conserve it with long time of this thing so that it heals. If it is not avulsed from its attachment distally, then I would not.
So what percentage of arthroscopy repair is there
subscap tear.
If it is, you don't know. Yes, sir.
Which is not detectable clinically or not detected radiologically, like a surprise finding of subscap tear during arthroscopy of a supraspinatus chip.
Yeah. So I've got two radiologists. One is Bhavin Saab, and there's one more guy who do. And usually, unless it is coming from somewhere else, and clinically I find I get it repeated. So that's one thing. Usually my colleagues, I mean those whom I have faith in, usually they don't err. But still, I would not completely believe on them. I would believe in my clinical finding, one, and two is go in and see arthroscopically. You're there, देखने में क्या जाता है?
That's what I'm saying.
So percentage, if you see with my radiologist, about 1 or 2% they falter, I would say.
So clinically, a patient had no weakness of subscap, and arthroscopically you find there's a tear in the superior fibers. Would you go and repair that?
So if it is type 1, no repair. If it is type 2, yes, must repair. One I showed here, one actually I couldn't get time to edit it. That was fantastic case. It was complete superior fibers gone, and it was little different. Of course, inside the box technically I can show you their editing. So inside the box technique from anterior itself we did. So if it is a tear type 2, yes, you should go and fix it, because it is one of the strongest muscles. If you don't treat it now, it is going to tear furthermore.
The reason I asked about that significant tendinosis with delaminations is that there's a technique where you take a slit, circumferential slit.
We can do it, but again for that you have to take those anterior things. You need to clean it anteriorly. You cannot just go and do it like that.
But is it like people do?
So I have not done.
It's a valid treatment protocol, right?
Like there is a longitudinal, we were talking about longitudinal laminations. So I also believe that it is, what you said is very right, sir. So I believe that if you leave it like this, the chance of some kind of progression in the future. So always I'll take one suture around it. If I see it, I'll put one stitch on it. So the suture will be like a mattress with a niche, and then you can just suture it. So it's hold it in place.
Nilesh, similar, I did a recent case like you that similar like meeting a box stitch in a horizontal cleavage tear for a meniscus. Not fixing it to the porosity, just take a couple of bites, tie the knot there, so that tendon integrity is maintained and it doesn't. And as most of the times when you are in the joint, you are clearing the rotator interval, so you are there, so you can just put a stitch in 5 minutes and get out. And for massive subscap case, once people who are new, many times the tendon is not seen at all. So you have to pull that comma tissue and bring it up and see the tendon in view and release the injection, and then you will see the tendon.
Yeah, but those massive, those massive tears, usually the comma tissue is not intact. If it's a massive tear, if it's a superior 1/3 or maybe up to 2/3 of the tendon, still it is there. But if it's a massive tear like complete retraction, the comma tissue might not be.
How to pick it up on MRI? Anteriorly in front of glenoid, you will not see any muscle. Those tears are not repairable. You have to directly go in for a tendon transfer.
Right.
Do you use C portal and D portal you mentioned? So for all subscap repair you do C portal, D portal?
No. If it is type 1, nothing is to be done anyhow. If it is type 2, my inside the box technique works. If it is type 3 or more, where I am not able to get it back there, then yes, I need to, because I need to see everything to get them back. So I am seeing from here and using my other portal for my working portal. So this sort of, both the things are parallel. So it's just anterior and it's not a very big deal basically.
It's risky to do a D portal?
D portal, yes, it is risky. So you need to precisely know where you need to go. You need to pass in the dentopectoral basically.
So do you do double row repairs for subscap?
If it is completely retracted type 4, yes, we have to do it, because then otherwise you can just bring it and those may not. It's a strong muscle basically.
Payas, one last question. How do you always address the biceps in these tests? Do you always address it, or have you sometimes left it intact after the repair?
Honestly speaking, if the biceps is subluxated and the patient is old or something, I just do tenotomy, that's it. And then come from anteriorly, subscap repair karo, suprascap karo and go back. So that's what. I still believe biceps is a pain generator. Unless I've got no option, as Navid said that If the rotator cuff is not coming or something, then I might do something with the biceps and that.
No. Do you believe that leaving the biceps intact will stress your subscapularis repair?
Yes, I do believe. So I usually do it anatomy.
You almost always, or?
Usually, if it is more of frayed or something, it's subluxated or something. Because if it is subluxated, I bring it back, which means now the ligament holding the biceps in place is not working. If I do leave it like that, it is going to keep on pushing my repair there. So it's better to tenotomize there and go in and finish that.
Exactly. So if it is sublux or if it has a pathology, then the answer is easy. But you often have these type 1, type 2 subscap tears where the pulley actually is not necessarily disrupted.
So if pulley is not disrupted, why should I go in and do anything for the biceps? I just go and do my work and just leave it here.
Many times it comes in way of your repair.
If it comes in my way of repair, if it is, so that is okay. I mean, I can always retract it by putting one. Thank you very much.
Thank you. So, let me invite Dr. Kaustubh Durve. He will be talking on suprascapular nerve release, like a prison break.
Yeah, good afternoon everybody. I hope after lunch most of you are still awake. I thank all the organizers for this kind invitation. And this is going to be a little bit of an unusual topic, so I hope I'm able to do justice to this. By the way, the picture of mine was very nice. It looked like me from a much younger day. So, suprascapular nerve, we all are very acutely aware of the axillary nerve when it comes to a shoulder. We always know, we know where it goes, we know how we should not go near it, we know how we should protect it. But suprascapular is another very important nerve of the shoulder because most of the sensory innervation of the shoulder comes from the suprascapular nerve, and it innervates two of the most important rotator cuff muscles, the supraspinatus and the infraspinatus. So, little bit of the anatomy to begin with, because that's what this is all about. It is a branch of the upper trunk of the brachial plexus with contribution from C5 and C6. Sometimes from C4, but C5, C6 is what it is. It crosses the posterior triangle of the neck. If you remember from Chaurasia a long time ago, there is a triangle, posterior triangle. It crosses the posterior triangle below the omohyoid and passes under the trapezius directly towards the scapula. After reaching the scapula, it passes through the suprascapular notch, which is just medial to the base of the coracoid and approximately 2 cm from the glenoid rim. As it passes through the notch, it gives out the sensory fibers to the glenohumeral joint, and simultaneously as it passes under the undersurface of the supraspinatus, it innervates the supraspinatus. Then it reaches the spinoglenoid notch. Spinoglenoid notch is the notch between the glenoid and the spine of scapula. Okay, somewhere there. I don't know if you can see the point of it. Yeah. So this is the spinoglenoid notch, and that's a very, very important landmark again. After crossing the spinoglenoid notch, when it crosses the spinoglenoid notch, it may pass under something called as a spinoglenoid ligament. It's basically just a thickening of the tissue, variable. It may or may not be there. And after passing this notch, then it gives the supply to the infraspinatus. So this is the life story of the suprascapular nerve. Now, in suprascapular neuropathy, two types of neuropathy. One is traction neuropathy, often because of an injury, or compression neuropathy, which may be because of various reasons, but the compression neuropathy is the one which may need surgical intervention. Traction neuropathy, not so much. For traction neuropathy, you can just give rest, give a sling, observe the patient. But for compression neuropathy, you may need to operate. So, which are the sites of compression? These are two main sites of compression. One is the suprascapular notch, when it passes under the transverse scapular ligament. The transverse scapular ligament, which converts the suprascapular notch into a hole. In this case, you will have pain because it involves the sensory fibers, and also weakness with atrophy of the supra as well as the infra. The second important side of compression is the spinoglynoid notch, and here it is compressed because most of the time because of a spinoglynoid notch cyst. Now, spinoglynoid notch cyst is basically a paralabral cyst similar to your parameniscal cyst. Just like a meniscus tear causes leakage and cyst, similarly a labral tear causes leakage and cyst. Most of the time this labral tear is something like a slab tear, it's posterior superior, or maybe even a posterior tear which causes leakage of fluid, and a cyst which eventually extends into the spinoglynoid notch and compresses the nerve. In this case, you will not have pain because the pain fibers are already gone, and only thing you will have is a little bit of weakness and atrophy of the infraspinatus, but it's very nicely picked up on the EMG, because in the EMG they can test the infraspinatus with the needle and it shows denervation pattern. And of course you can see the cyst on the MRI. Now, arthroscopic decompression of course is preferred because you get access to the nerve without disrupting the musculature. Theoretically, there's a decreased risk of neurovascular injury because you can see it well on the arthroscope. But you need to have an excellent knowledge of the anatomy of the neurovascular structures and the landmarks so that you don't accidentally damage anything. The three main approaches you need to know to decompress the suprascapular nerve. One is the transarticular spinoglynoid notch decompression. The other is the subacromial spinoglynoid notch decompression. And the third is the subacromial suprascapular notch decompression, of which the first and third are the ones which are actually used commonly, and those are the two which I'm going to discuss. Transarticular spinoglynoid notch decompression is something I'm sure all of us have done sometime or the other. You use a simple anterior, posterior and the anterolateral portal. Like similar to the Bankards, you have two anterior portals, one posterior portal. Try to get the anterolateral portal as superior as possible so that you can reach across to the posterior superior labrum. It is important to identify the clock face of the cyst. So look at the MRI scan and see in which o'clock position is the cyst closest to your labrum or to your glenoid face, because that's where you decompress. The reason is because although often it is secondary to a tear, but many times the labrum tear is actually so tiny or so overlapped that you will not be able to find the labrum tear many times on the arthroscopy. And it has often occurred with me that I have to actually open the cyst knowing where it is closest to the labrum rather than actually following the tear into the cyst. But it is important to open the cyst because you want to decompress it. So if you know which clock face the cyst is, there you can open it. Otherwise, you can just do a capsulotomy starting from the superior just behind the biceps anchor and go to the posterior direction. You can do it through the anterolateral portal using an arthroscopic scissor or a curved tissue liberator, or you can do it from the posterior portal also using an upward tissue liberator. Once you enter the cyst, you will have an egress of cloudy fluid, typically like how you have when you open any ganglion cyst. Then open the mouth well with either a blunt trocar or a blunt switching stick and use the shaver to debride the cyst wall as much as possible. Okay? You can alternate the arthroscope and the working instruments like your trocar or your probe or your shaver between the posterior portal and the anterolateral portal. The anterior portal usually not very useful to reach here, but the anterolateral portal and the posterior portal can both give you access into the cyst, and it allows you to debride the cyst wall as much as possible. But always remember that the suprascapular nerve lies approximately 1.5 centimeter medial to glenoid rim, so you cannot do a blind debridement into the cyst for a very long distance. So don't shove your shaver in too much. Debride more along the mouth only, so that most of the cyst wall comes out and there's enough bleeding for the mouth to close. So this is what you will commonly do because these are relatively common cases. This second surgery is really uncommon. This is a subacromial suprascapular notch decompression, but I will go through the steps with you. Use the usual posterior viewing portal. This is a subacromial surgery, so use the usual posterior viewing portal to go subacromial and the lateral portal to clear the bursa. Now work on clearing the coracoacromial ligament first. So anteriorly the entire coracoacromial ligament should become visible. Then you can switch the scope to the lateral portal because now you got space. Now follow the coracoacromial ligament to the base of the coracoid. There you get the base of the coracoid. Dissect anteromedially along the anterior border of the supraspinatus to expose the base of the coracoid till you reach the coracoclavicular ligaments, that is the conoid and trapezoid ligaments. Once you reach the coracoclavicular ligaments, you know that the suprascapular notch lies just medial to the conoid ligament attachment on the coracoid base. You will also see the suprascapular vasculature, that is suprascapular artery and vein running just over the transverse ligament, superior to transverse ligament, and the suprascapular nerve runs just under the TSF. Next, you create an accessory Nevaser portal, which is 2 cm medial to the classical Nevaser portal. Insert a blunt switching stick for dissection. Retract the, you can use that to retract the suprascapular nerve, to retract the vessels, to probe the ligament, transverse scapular ligament, to make sure that it's not ossified. And once you're sure that you know where you are, then you create the standard Nevaser portal, which is the working portal. That gives you the access to actually cut the transverse scapular ligament by using a biter. So before doing that, using the accessory portal, you retract the suprascapular nerve with a probe, blunt probe, and then transect the transverse scapular ligament under direct vision. If the ligament is ossified, you may have to use a osteotome. In summary, suprascapular neuropathy is a relatively uncommon condition. Some studies show it's only about 4% or so of tertiary referral shoulder referrals. You need a high index of suspicion for diagnosis, thorough knowledge of anatomy before undertaking any surgery, but excellent results have been reported with arthroscopic decompression. Thank you very much for your attention. Any questions?
What position would you prefer, a beach chair or what patient position would you prefer, a beach chair or a
Yeah, so Dr. Fayaz is asking which position. So when I'm doing a spinoglenoid notch cyst decompression, which is basically a slab repair, I always do it in a lateral position because I like to approach the labrum always in the lateral position. But if you're going to do a subacromial decompression of suprascapular nerve, a beach chair position is definitely preferable.
So how do you decide preoperatively what you are going to do?
Yeah, so that depends on where the compression is. There are two different diseases entirely. Compression in the spinoglenoid notch is secondary to a spinoglenoid notch cyst, in which case your MRI will show big spinoglenoid notch cyst. The EMG will show good innervation of the supraspinatus. So supraspinatus is normal, but the infraspinatus shows spontaneous waves and innervation, denervation pattern. So you know that the compression in the spinoglenoid notch, and you know you're going to decompress the cyst. So lateral position. Either if you find the slab tear, open the slab tear and make it wider. Many times the slab tear is too tiny, and that's the reason the cyst has formed, because the fluid is leaking out and not coming back. So then if you don't find the tear, that's fine. Just see which part of the cyst is closest. So if the cyst is closest to the labrum at say 1 o'clock or 2 o'clock, then near about that clock face you just make an opening by a tissue liberator and decompress the cyst. Decompress the cyst and widen the mouth there. After that, you just close it with 1 or 2 anchors. And if you find that your EMG is showing you, first of all, there's pain. If the compression is in the suprascapular notch, there's going to be pain. Also, EMG is going to show denervation of the supraspinatus as well as the infraspinatus. So you know you want to transect the transverse scapular ligament, and that's a completely different surgery. Then in the beach chair, follow it anteriorly, base of the coracoid, go just medial to the base of the coracoid to find the notch and transect the ligament.
Thank you.
Thank you very much.
Thank you so much. Okay, so we all know future is biologics. So let's hear from Dr. Ayyappan Nair about the role of biologics in our cuff and how it can make it heal faster.
Good afternoon to you all. I think the hat actually made me wake up a little, because I was also very sleepy. So I'll try to finish fast. So the biologics in the shoulder, in the rotator cuff, should be based on two things. One is the injectables which you have, and second is the patches and the augmentation which you have. So I thought I will go through some literature and whatever results we have on this kind of scenario. So coming to the biologics, we'll start with the injections. The question is there any role of any kind of injections in the cuff healing? So when you look at literature is always biased. You can have literature that way or this way. There's no proper literature which says that it supports PRP in the usage. Then coming to PRP is just not just PRP. We have Lucozade rich, Lucozade poor, Lucozade very poor, different types of PRPs which are available. So when you look at what is the ideal PRP which might work, so the principle should be to induce inflammation. Only then you have more healing. So then you are looking at the Lucozade rich PRP. So when you look at the different companies, so we did a study on different companies looking at what each has. So it looks like a double spin which we normally get from Arthrex normally has Lucozade rich PRP, and that is what we normally use. So now you can see this, this is on a systematic review on these are the different types of PRP and the different uses. So we prefer the Lucozade rich. Then as I was saying earlier, there's no proper data which actually says for or against. But definitely there is definitely some, if you look at this is a 2025 paper, systematic review meta-analysis. So musculoskeletal surgery, pretty good results. So they are saying that retear rates are lesser if you use, along with the rotator cuff repair, if you are using PRP, it is supposed to be better, it seems. Then at the same time, when you look at a 3-arm control, so you find that there is no particular difference in the different rates overall. So that's it coming to, so we decided to do our own study on the PRP and how it works. So when there is, so when we look at literature, we find that we can divide a test into 2 categories. First is degenerative and traumatic. So degeneration basically means there is some other pathology behind it. It is degenerated. So we didn't want to select those patients. So we took traumatic tests. In traumatic tests, further we classify into high grade and low grade depending upon the size of the tear. So high grade tear, higher chance of progression, so we operated. In low grade tears, less than 50% thickness, we started to give the PRP injection. So we had 2 arms here. One is the PRP and the physiotherapy arm. The other is only the patient who opted for the physiotherapy. So you can see that there is quite a bit of difference. So in the outcomes. So we see that. So you can see the green is basically the PRP. So this is So this is the PRP pre-injection and post-injection. This is the physiotherapy before and after. So then you look at it, you can actually find a difference. There's quite a bit of difference in the different scores, constant scores, ACS scores, quick dash scores, and the VAS scores also. There's a reverse of it because these scores are the reverse. These are positive scores. These are negative scores. So quite a bit of difference we did have. So in these traumatic patients, when you look at the return to sport, again it is quite different. In the physiotherapy arm, it is 20%. And here it is 50% return to sport. So in our patients, we followed this, and we don't have any evidence on the remaining. We don't know about degenerative tests. We don't know about high-grade tests. But definitely, it looks like in low-grade traumatic rotator cuff tears, we did have good results. Now coming to BMAC. BMAC, again, all of us know, okay, we definitely use the BMAC for cartilage repairs and all that. So there is some evidence on the BMAC saying that it could affect, it could have a positive outcome on the rotator cuff healing according to some studies like this. We don't have any experience on that. Coming to MSCs, so mesenchymal stem cells. So we worked on the MSCs quite a bit. We tried to find out some data on it. When you looked at MSCs, how it works in rat models, definitely MSC, that is stem cells, when injected, different types of stem cells. You can have adipose derived stem cells. You have allogenic stem cells where you it becomes, you can isolate it and it is not patient specific. So these stem cells definitely seem to have a positive effect. If you look at it, see, the MSCs remained in the muscle tissue for 7 days. These are mouse models. It had a positive effect and increased the muscle growth and muscle protein growth. So when we look at certain studies, there is only very few studies with the MSCs. So these studies, one study showed positive outcome, the other study said not much of outcomes. Then the most happening in rotator cuff repair in the molecular level is the BMPs. So there is a very, very interesting Chinese study which was presented in the Korean Shoulder Society. So they did a study on BMP. So they used, you can see a electrospun device, the PGLA, and on one side, which is on the bone side,
So the endocyst has two sides, the muscle side and the bone side. So on the bone side, they put BMP2, and on the muscle side, to promote tendon healing and tendon formation, BMP12, because these are specific molecules which attack and which help in healing. They seem to have good outcomes in mice level because this is quite a bit of molecular activation happens and good results. So that is about the molecules which I could search whatever I had information on. Coming to the patches, there are different types of patches. So there are complete collagen patches, which are, for example, your Smith & Nephew Regeneratin is a collagen patch. So here the BioBrace is a woven patch. It is a mix of the PLLA and bovine collagen. It is woven. So it is a technology which we have in India also. So that's how the BioBrace developed it. So the advantage of the BioBrace is that it gives you immediate mechanical stability, and gradually the PLA gets absorbed, and the collagen helps in the integration, and there's a complete absorption. So immediate strength is given by the BioBrace. So this is the BioBrace. We had one particular case. So I don't use patches in my practice at all. So very rarely, for example, this was a re-tear scenario. The patient after the primary repair had a traumatic fall. So then I had to re-repair it. So this is a particular case which we had. So what I did was, I didn't want to disturb the healing, the already existing healing. So this was primarily how it was sitting. You can see I had to very delicately handle that tissue there. And you can see the pull off where the tendon is, the suture is actually pulled off, and you can see the re-tear there. You can see some amount of tissue over here. I had to debride it. I did a trans tendon repair, and in the trans tendon, I used two sutures basically for fixing the BioBrace. Because shortage of this, the BioBrace actually sitting on top of it. So the patient went on to heal very well. So I stimulated the healing down. I did the BioBrace on top of it. It came out pretty good. We took MRIs later, 6 months later, patient had excellent results. Very good results according to, there's a bias. Whenever a company is giving you a outcome, there is a bias. But there are different, some papers saying that it got good outcomes. So Regeneratin exactly, again Smith & Nephew, it is bovine Achilles tendon. Again, it is basically collagen tissue. It gives you some amount of collagen on top. It does not have any mechanical properties. So when you're looking at some amount of repair, when you don't want a mechanical property, that means strength is not there, but you want biology and thickening of the tendon and more collagen, then Regeneratin is a good choice. Again, I had Regeneratin in a particular case where re-tear, muscular tendon junction tear. The patient came with a type 2 re-tear, and I had to put a Regeneratin on top. So again, what are the other options available? So other options available are dermal allografts. Even artists come with a dermal allograft. Again, it's a good option. It's much cheaper than the other two options which I mentioned right now. And then dermal allografts, they have more long-term results are there because Arthoflex kind of patches have come some time. Then something which is very inexpensive is your biceps smash. So you have take some amount of biceps, and in the long head of the biceps, you can smash it and put on top. So this is a smasher. So again, I use this kind of things only in kind of re-tear scenarios. So here again the patient had a re-tear. I took the biceps, and you can actually compress it. There's a compression device, you can put it on top. So this is patient's autograft, that's the biceps which is coming in. So biceps, and coming to biceps SCR. So biceps SCR is where you use the biceps from the attachment of the bicep, the root is intact, and you cut a long head little more down. So we had followed up we had 100 patients. We reviewed 100 patients and we had excellent results of biceps SCR. This is our own study. You can see the number of patients and follow-up. Biceps SCR these are the outcomes. You can see the outcomes, pre-op and post-op outcomes. Excellent scores. So this is a biceps SCR. You can see the rotator cuff like that. The biceps being isolated, and bicep being integrated into the repair. I don't have much of time, so I'm not explaining it. So our study, when you're looking at our outcomes, you can see our study as well as the McLaughlin et al. Study. So we have comparable results, pretty good. Next is the facial data SCR, we use the IT band. So this is the facial data SCR. What is the facial data SCR? It is invented by Mahabhihata. So basically the anterior posterior force couple should be intact. So what we do is, we modified this technique. We added the biceps also along with the facial data, like this. The yellow color thing which you see here is the biceps. On top of that, the facial data is there. So you must see this. You can see the thing on the right. Okay, you can see here is the biceps, long head of biceps. You are basically stitching it down. Then you're finding out what is the remaining cuff defect, and you take the facial data. You double it or triple it, make it to 8 mm thickness, and with the sutures in this particular pattern, you have to guide it like this into the shoulder. And then you have to do most important thing, to have a side-to-side suture. So it's very important because only when the force couples act. So this is the facial data SCR. These are the outcomes of this particular technique. Facial data plus biceps, the techniques, outcomes are pretty good. So these are the different options which we have. And so we have options. Okay, so PRP, there is no guideline. All these injectables don't have any guidelines now. But I think with the future, okay, we'll have more of things. Thank you so much.
No questions?
Is it? I think I'll take this one.
We all face at times, like patients with irreparable cuff tears. So let's hear from Dr. Prashant Mishram about what are the options, non-arthroplasty options that he can tell us.
So thank you, Nilesh, again. And I think Dr. Naved and Dr. Ayyappan has made my job a little bit easier. So I'll go through this very quickly. Massive cuff tears is a problem. We repair them, 50% of times they don't heal. And no matter what you say, they never get the power back if they don't heal. But you have this irreparable cuff tear. Look at this old lady, she's 75-year-old. Now, you may be able to repair this, but the quality of cuff is so bad that your repair will not be good. She's as equal as irreparable, but she does not have much of a problem. Her pain is gone with physio, then for 2 weeks. I left her alone. So you have to understand that there are some people, you don't have to operate everyone. Irreparable cuff tear does not mean you need to do something. You can just leave them alone. The problem happens when they come a little bit younger. They come with pseudoparesis or paralysis. And the footprint, if you see here on your left side, that you're not able to reduce it all the way down to the humerus, the tendon quality is poor, and the progression of arthritis in these cases is high, and also these cases are the ones which may be a candidate for reverse. So if these people are old, and if you see an X-ray like this in which the humeral head is migrating all the way up, these are the guys you want to do a reverse for. I don't think anything else gives them a better, especially with pseudoparalysis. But what if you have, as the theme which Sir has given me, which is the James Bond theme, your patients are young, 40s, 50s, and they are still kicking. I think these are the patients for non-arthroplasty options, and it is, fortunately, these patients are less, at least in my practice, but this is a challenging, I think, patient population. And when you tell them, we are not going to do a reverse for you, you're going to die, or you're going to have that another day. So what are the options do we have? This is IT employee, which I have fairly active, chronic smoker, 2 packs every day, chronic diabetic. He fell down 6 months back, and then since then he's having 120 degrees of flexion, and the main problem is not able to open the doors. So his external rotation by side, this was the main issue which he was facing. His scans, you see his humeral head has already gone up, and this is a big problem. You have to bring it down. And the second thing is, in my hands, this supraspinatus, I don't think I'll be able to repair it. Infra, maybe I will repair it, but if it looks very hazy, it does not look very good quality of infraspinatus as well. So options we have is leave it alone, not an option for this guy. Partial cuff repair or some kind of augmentation, I don't know if it will work. Some kind of patch, as Sir said, but then it is still controversial if they work or not. Then tendon transfers or fascia lata superior capsular reconstruction. In tendon transfer, I'm not sure if biceps rerouting can be called as tendon transfer or not, but we are changing the route, and I think that's really important that for me it is a tendon transfer. You have latissimus dorsi and lower trapezius. So this whole superior capsule reconstruction business started 2018 when Mihata said that we put something on in between the acromion and the humerus of 8 mm and bring the head down. It really worked well for his patient population, 95%, and then the results have been up and down. But we put something on the top to create a depressor effect. It usually works. Patients do get better. They may not have the same power, but it does work. And except for xenografts, everything else seems to be working really well with a sustained kind of result. But if you see, balloons are the ones in which after 2 years they go down. So balloons have not sustained it. Everything else, if you put something, then it will work. So why not biceps rerouting? It's a little bit overlap of what Dr. Naved has said. But one thing which I want to contest is that pseudoparalysis is not a contraindication for not doing biceps rerouting, and I will show a case. So Yanshu Kim has described. So advantages is it's free. Number one advantage in India. It's a depressor. It's a natural depressor of the humeral head. It's mechanically strong, 900 newtons. I don't think it's not a, and also it's thick to depress the humeral head down dynamically as well as statically. It's an autograft, no morbidity from, you don't have to harvest it from somewhere else. And it's a naturally gained out anchor, so that's one less anchor to use. And this is the same paper which Dr. Naved quoted, and the numbers are, if you do an SCR, which means you cut the distal end of the biceps, it doesn't really work same as when you reroute and you keep the biceps intact. I think the key is to release it all the way down until the superior part of the pec major. So that is the key, not to have biceps pain. My patient population, I don't have biceps pain after this surgery. I don't think that is, and the literature also supports it. So I think rerouting is better as compared to SCR for sure. Pseudoparalysis in this particular female, 65-year-old female obese, above 50 female patients, if you are not able to repair the cuff very well, biceps rerouting is an excellent option. Not for heavy laborers. Heavy laborers, probably you want to do fascial attack SCR. But if your supraspinatus is irreparable, patient's demand is not so much, biceps rerouting works even if pseudoparalysis is not there. Sorry, even if patient has pseudoparalysis. Oops. I'm sorry, can you get this back? नावेद सर आपको नजर लग गया. Yes, so for me this is an irreparable supraspinatus tear. If you see, the infraspinatus is still there, we can still repair it, and the subscap looks okay. Fatty degeneration grade 2, I don't want to do a reverse on this particular patient. So if you see, sorry about the cracked scope, but you can see the subscapularis was still reparable. The infraspinatus was coming. It was the front subscap which is not there. So subscapularis repair is a must. You have to do it very, very meticulously. Biceps rerouting, bring it down, and repair as much supra and infra if you can. And if you do this, this is after 4 months, the patient is having reversal of pseudoparalysis, and it works fantastically well. This has been my practice. If supra is not there, patient's demand is not so heavy, I do like to have biceps rerouting. The second option which we have, when supra and infra both are irreparable. Now this is again a very challenging, I think, scenario. We can do something called as latissimus dorsi transfer, but if you see, just by the look of it, it looks like a complex procedure. You make an incision in the axilla, you harvest your latissimus dorsi, then you make another posterior portal, or you, not portal but an incision, or you can do it arthroscopically. You shuttle it in between the triceps and the teres major and bring it back up and put it on top of the greater tuberosity footprint. But this was introduced in 1980s, and this procedure never really became very famous for a few reasons. Number one, the outcomes are really unpredictable, especially external rotation is not so good with latissimus dorsi. The second thing is the complication rate is 13%, but when they get complication, it is neurologic and it is very, very serious. If you have a deltoid injury in this particular problem, then even the reverse is not going to salvage it. And also it's technically demanding. So what I like for posterior superior cuff test is to have a biceps rerouting, plus on top of that, to help you with external rotation, is to use a lower trapezius transfer. If you see lower trap, the line of pull is same as the infraspinatus as compared to latissimus dorsi, which is a little bit different. And biomechanical studies have proved that you get better flexion as well as external rotation with lower trapezius as compared to a latissimus dorsi. The only caveat or only one hurdle is that lower trapezius tendon is very small, so you need some kind of graft to connect that tendon with the greater tuberosity. You can use multiple things for this. You can use a peroneus longus, and I use an allograft. So Dr. C.H. Baek, I think from South Korea, is excellent study comparing latissimus lower trapezius against superior capsular reconstruction, and he used allograft for both of them. Better range of motion, less progression to arthritis, less graft retear with the lower trapezius group. So it works better than the SCR, but he did not do the Mihata SCR, he did the allograft SCR. Why I use the tendo Achilles allograft to connect the lower trapezius transfer to the greater tuberosity instead of using a peroneus longus or semi-T as you would use. It has excellent strength. The thickness is very good. It gives me a depressor effect, so it helps also if the supraspinatus is not there. The graft morbidity is, there is no graft morbidity, and it's 1/3 of the price of the patches. And it's not just me, it is a track record of 10 years. It is not something which came yesterday. 10 out of 15 studies have used tendo Achilles allograft. In this meta-analysis, the pain and function is improved across the studies, and if you get an external rotation of 20 to 30 degrees, which means patient is functional, and also if the patient is going 90 degrees, you are giving them a flexion of 30 to 50 degrees more, which means you are practically reversing the pseudoparalysis. So the only issue is superficial infection, which can be debrided in 13% of the patients, and the conversion to reverse would be 20%. So I'm giving you a patient population which is very tough. Young guys, heavy, probably they're looking for more activities to do, pseudoparalysis and stuff. There's a survivorship of 80%, which I think in this patient population is fantastic. So coming back to the patient which I showed earlier, having problems with external rotation as well as flexion, superior migration of humeral head. What I did for him is lower trapezius transfer with biceps rerouting. This is how I do the lower trapezius harvesting. On the back, you make an incision just 2 centimeters below the spine of the scapula. And we go all the way down to the tendon, and there is a fat pad. You remove the fat pad, the shiny tendon is right in front of you, lying on top of infraspinatus. You cannot miss it. So when you go and you identify the tendon, at the periphery or at the lateral, it can be a little bit thin. So you have to go a little careful. But I don't think there is any concerns of graft breakage or the tendon breakage during this procedure. You release it, and then this is the tendon which is harvested. You make a hole through which your allograft or your autograft will pass. So this is the intra-articular procedure of how we do it. This is the harvested lower trapezius tendon. This is how the tendo Achilles graft comes. It comes right from Bombay, so it's available locally for us. You would pass a whip stitch as you would do in your ACL. You see the breadth is 2.5, enough to cover whole of the tuberosity. Thickness is 8 mm, enough to depress the humeral head, and the length is enough to connect it to the GT. This is how the intraoperative picture looks for this guy. Supraspinatus, infraspinatus, the quality is horrible. As I said, chronic smoker as well as diabetic. So you'll spend a lot of time in order to make the space between your deltoid as well as the scapula, and if you do that, your graft will pass easily. Also, it will have very good excursion, and once you do that, go a little bit ahead. So this is my biceps rerouting, and this automatically gets your head down already. Then we prepare the footprint so that your graft, when it comes in, it will have good healing to put some biology. Then you take a grasper, go into infraspinatus fossa, right outside, take a nylon or an ethylon and pull it out for shuttling of your graft. This is the graft stitches which are coming in, and if you see the thickness of the graft and the volume is so good that it covers the whole of tuberosity. The way you want to fix it, you can use a knotted anchor, you can use a knotless anchor, one in the front and one in the one posteriorly, as you would put for an infraspinatus, back as much as possible. There are multiple ways you can do a double door repair as well. For me, 2 knotless anchors is the simplest way to go. But as soon as I put the first anchor, if you see, the head is already down and it is covering whole of the footprint, and that's why I like this more than the autographs. There's the second anchor which is going in, and the position can differ depending on the problem. If you have only infraspinatus, you can put it a little bit in the back. And this is pretty much easy as compared to the latissimus dorsi transfer or anything else complex you want to do. Then the medial end of the graft, you attach it to the tendon, which is harvested lower trapezius. This is how it moves, and this is intra-articular picture of lower trapezius and your biceps rerouting, which is moving. Few more slides. So rehab, external rotation for 10 weeks, no internal rotation external rotation sling for 6 weeks, no internal rotation for 10 weeks, strengthening at 3 months, return to sports at 6 months. This is the same patient. You saw the superior migration of humeral head. This is the next day of the surgery. His humeral head is already depressed, which is about 1 centimeter. And this is 4 months post-op. It is maintained. So it is not like it is only, you lose the depression of the humeral head. It's kind of sustained. So this is full range of motion at 4 months. He's still getting his strength back, full internal rotation. And for me, this is important. You see his external rotation motion is full, as well as he's got strength back. He's saying that finally he's able to do things which he wants for his daily activities. So take home for me, irreparable rotator cuff tears, non-arthroplasty options, reparable subscapularis, and patient should not have osteoarthritis. This is if you have this, then probably you're thinking for a reverse. Irreparable supra, I still think SCR with biceps rerouting is an excellent option for us. Or if a heavy laborer, we should think of a facial autograft. Irreparable supra plus infra, I prefer to have lower trapezius transfer with the biceps rerouting. I think Achilles allograft is an excellent option, and pseudoparalysis in my practice is not a contraindication to save the joint. Thank you.
Prashant, where do you source your Sanjay?
Yeah.
Allograft from?
From Tata Memorial. They have. There's another company which gives. I'll tell you later. Which give it.
Yeah. Tata is readily, easily available.
You just tell them 2-3 days before. And they will bring it, they'll put in the freezer. You get the graft, put it in the slide for 30 minutes or so, it becomes loose and then you use it.
And your take on this versus Dr. Ashish Gupta's muscle slide in these patients?
That's completely different. So, when you're saying irreparable, it means you've tried everything in your hands and then you're not able to repair it. I think muscle slide is a different thing. It's something for a massive cuff tear which is difficult to reduce. And if you want to use that,
but he's saying that should be workable in this kind of patients also, where you feel that a tendon is not coming at all, but he says if you release from that end, it should come back to the upper.
I've done that only once and it comes, but I cannot stand here and give you for sure answer because I don't think we have enough data to know if it works or not. And just to say that we can repair everything, that's okay, but it has to be sustained in the sense that patient should be happy.
So for him, the only contradiction is that tendon length is reduced by less than around a centimeter. Then you are not supposed to do it, otherwise you can do it in all of the cases.
Yeah, I have no experience with that, so I will not comment on that, and we still need to wait and see how that works. But you are looking at a patient who's like 60, 65 or something like this, and they are not looking for...
These are for the younger ones. Like I also have a lady of 35, there is no supra, there is no infra left. So
we might potentially do a lower trapezius. I think that works really better. But if you want to do that, I think it's a fair choice, but I don't think we have enough data to kind of comment if it definitely works or not.
Do you get such kind of external rotation with LTT transfer in all your patients? Or
I get 30 degrees is what I tell them. You're able to reach here. This is difficult.
Because the patient that you showed are actually full external rotation.
So yeah, I got lucky with that. That's why I showed this patient. But I have patients, but they get 30 degrees. Like with reverse, I never tell my patients you're going to go all the way up. I tell them 120 degrees. This is what I promise them. So with this one, I promise them 30 degrees. But what we also get them is good strength. They're able to do daily activities with this. So I think 30 degrees is what they get.
What is your, first of all, you do medialization of insertion? If yes, how much is your maximum limit by which you would want to do a medialization, if at all you are doing it? Because that was another thing which was missing when you didn't speak about medialization of the cup in case they are not repaired. So first of all, whether you do it, or if yes, then how much?
Medialization of the footprint, you mean, in order to repair. So my talk was irreparable cuff tear. If I was giving a talk on massive cuff tear, which I am still repairing, partial repair, I do up to 5 mm. We can go up to 1 centimeter, but 5 mm I think is fair enough for us to medialize, and I do that very commonly, sir.
Okay,
I like
so
it.
1 centimeter is your maximum limit. Beyond that, you will, if not possible, then you will limit. They will label it as irreparable.
Yeah. So I review for a few journals, and there was a paper from China in which they medialized up to 2 centimeters. It was way too medial, and the cuff was actually sitting on the top. I think that's too much. That's too much. I rejected that paper, of course, but people have tried that, and I don't think it's a good idea to do more than 1 centimeter.
The second question which I wanted to ask is, one thing is about the irreparability, and the second thing which you mentioned about the high grade fatty infiltration of the muscle. So, in case right in the pre-operatively evaluation, we see that there is a very high grade fatty infiltration with retracted cuff tear. Is it the same as, like, practically speaking, irreparable cuff tear, and we want to go non-repair options, or would you still repair these cuffs?
I think grade 3 and grade 4 there is no point in, we should consider that it's not going to, because reversal of, once we repair it, whether the fat infiltration reverses or not, that's a controversial topic. Studies have shown that it's reversible, but your repair has to be very good. If it is fat infiltration because the patient is coming chronically to you after 1 year or so, if you repair it, probably that's a good option. But if you're not able to repair it properly and there's a fatty infiltration, so that's a recipe for, I think, failure. You have to think of something else. Tendon transfers, I think it's the ideal thing for lower trapezius. Thank you.
Thank you so much, Dr. Prashant. So let's have a second real life surgery by Dr. Ayappan Nair on the rotator cuff repair.
Thanks again, and good evening to all. I think this is going to be my last talk. So this is on the muscle advancement. So real life surgery and the muscle advancement. So muscle advancement was invented, the concept was brought about by Morihara. So in almost like 10 years back, he came out with his first paper. It was, he published pretty good results with the muscle slide. Then Ashish Gupta came out with, and he went ahead and published it more. Showed again good results. We know about the considerations of irreparable tear. We know why a tear is irreparable, the fatty infiltration. We know the Patter's classification. We know the Hamada, and we know that this is the muscle slide. Muscle slide is basically we know it is an irreparable tear. There's a retraction even up to the glenoid, so it could be involving the supraspinatus as well as infraspinatus in cases. And what we do is, we have to open the medial border of the scapula. So we can put an incision directly on the medial border, or slightly even on the more medial to the medial border of the scapula slightly. But it should, the safe zone is beyond 4 cm from the midline, from the medial border of the scapula, is your spine, let's say. Then you elevate it with cob elevators, you elevate it, open that space, elevate it, and after the elevation is done, you have to release the suprascapular nerve. So there is definite studies showing that if you don't release the nerve and try to pull the tendon, there could be nerve damage. And once the nerve is completely released, and then the muscle can be easily brought back to its position, we can get even up to around 3 to 4 centimeters of good coverage, excellent footprint coverage with this particular technique. So I was trained with Mihata for the facial atta. So I used to do a lot of facial attas, that is the SERs. But after seeing and knowing how the muscle slide is being done, so I stopped my SCR completely. So I don't require anything else other than irreparable tear other than this. If it is an isolated supraspinatus, you need to release only the supra. Otherwise, you need to release both the supra and the infra. So these are the incisions. So you do a diagnostic arthroscopy. You have to be careful when you are elevating it. So basically, you keep 3 fingers away from the lateral part of the acromion, and this is where your nerve is going to be. So you mark with the cob elevator, and your elevation should not go beyond that. That is a kind of a landmark when you release it. If you go beyond that, you can damage the nerve. These are further incisions and other things. So this is arthroscopic assisted. When you are opening up the medial border, and then it is arthroscopic assisted. Morihara 2025 has come out as techniques and outcomes of complete arthroscopy. So it is very interesting to see how it works. So we have the rhomboids, and we have the supraspinatus and the infraspinatus. Both of them converge into a fascia. A connecting fascia is there. So we have the, if you look here, from here you have the rhomboids, and here you have the supraspinatus and infraspinatus. They converge into a fascia, and it is this fascia kind of fixed onto the middle border scapula. So Morihara did an anatomical study. What he did was he released the entire thing arthroscopically. So in this 2025 paper talks about complete arthroscopic muscle slide. So there is no detachment of the rhomboids at all. So he completely releases. So which the fascia continues into the rhomboids as well. So this what we do, what I've learned from Ashish Gupta was this particular technique where it is arthroscopic assisted. So I'll come to a recent video which we did. So I did whatever possible was on earth to repair this muscle back. So here it is a irreparable tear. You can see how the condition of the tissues are inside. So there is a diagnostic artist. You can see where the muscle is sitting on top of the glenoid. You can see here again the head is exposed. You can also see the biceps is intact, but some amount of the biceps is damaged. Definitely degeneration is there in the biceps. So here the first step is, so whenever I know if that is a scenario I'm going to do a slide, I do the slide first. This is how the slide is done. Medial part of the scapula. So your incision 2 cm long is based on the spinal scapula. That is 1.5 cm above and another 1 cm below. Then you can see the trapezius fibers, the upper and the lower trapezius fibers will be actually going in parallel. So you split it open and then you're directly on the muscle and then you can elevate it. After that is done, you need to do a thorough elevation, that is 360-degree elevation clearance of the capsule. You will see that I'm lifting up the biceps and I'm doing a thorough clearance that is dissecting the capsule from posterior all the way to superior. So we know that the nerve is 1.5 centimeters away, so up to 1 centimeter can release it nicely. This release is very important, then the muscle will come. So you've done the extraarticular release, then you're doing the intraarticular release, complete, you do a complete nice release on top, go up to the coracoid process anteriorly, and you can see the muscle is retracted. You lift up the muscle like that, and then take it out, release it slow. So I don't go with the cautery all the way, RF all the way, just release the capsule, then you use the elevator. So use the elevator, so your elevator for the pancreas, just hit it and keep moving it. A few hits, it will open up completely. Then here, you can see, slow, steady, we do that. And once this is done, let me see, can you fast forward it? Yeah, you can see the elevator coming in. So once the capsule is released, you elevate it, you can quickly do it off the elevation. Yeah, so then clearance of the subacromial space nicely. You can do an acromioplasty, make enough space there. Then if the AC joint is affected, do the AC joint decompression as well. Then there is acromioplasty coming in and then the AC joint decompression. Then coming to suprascapular nerve. Suprascapular nerve, it's not very difficult to do at all. There are few tricks. The sir before me, he was talking about how to do that. But here it is very simple. So there are 2-3 tricks in it. Number one, see the you can see the supraspinatus will be here. Supraspinatus is in the supraspinatus fossa. So your idea is you should move the supraspinatus away like this, posteriorly, from anterior to posterior to move it away. So that should be like how you do a chopstick. That means you have to take one Wisinger rod from your anterior superior, your anterior port or an anterolateral port and tease, suppose I am looking like this, this is the supraspinatus, I tease it back. From the nevisor port again, then I hold it back. Then again this back. 2 times you do, you will be easily on near the CC ligament. So sir was saying that the conoid ligament is important. So immediately after the AC joint, when you go inside from lateral to medial, first thing you see is the AC joint. Immediately after the AC joint, you can see a band which is going down like that, a white band, that is your CC. The CC and the transverse scapular ligament are very much connected. So if you trace the CC like that, it will immediately come to the transverse scapula. I show you the video on it now. You can see possibly because most of these cases what happens is, because the fatty infiltration is quite significant, quite a bit of fat is that we need to clear up the fat in that area. It can bleed also, take your time to actually cauterize it. Fast forward a little more. Right. So here is where my nerve is going to come. So here, this is what I'm trying to tell you. This is the nevisor port, the Wisinger rod coming in. Can you see on the left side of the screen? Can you see that this coming in? This is your CC ligament. So you take the CC, you can see how the Wisinger rod is going to the base of it, going up to down. You sweep it like that. When you sweep it and hold it there, take the other Wisinger rod and then tease it back, push it back. Then hold again, push it back. So you can see how I'm doing it now. This is the Wisinger rod which is coming from lateral. The other Wisinger rod is coming from top. So 2 times you tease it, you can easily see to go to the base. It doesn't take much time. Okay, it's basically like the 5 minutes you can easily do it up. And So now you can see more clearly. You can see how toward the left side goes on the screen in the CC, and you can see the vessel on top of the transoscapular there, and you can see how there is your transoscapular. It is not very difficult. It's all about you going in, take little time. How you sweep the supraspinatus back is the key. How to get this there. So once you have done that, you can see it beautifully. So the place between this vesical rod and the vesical rod is different. Upar ka and aage ka. So you push back, push back, push back, push back, push back, and then you are here. And then you can release it with. This is an instrument which we have specifically made for this, and so it is quite safe because it goes like that. It's got a cut on top, one cut. So this one part of it is more smooth and rounded. It will go into the transoscapular notch, and you're getting it. So when this is done, I want a little more clearance, that's why I'm playing around there. I want to be very sure that I'm safe, and then cut, finish. That is your suprascapular release. Once the suprascapular release is done, then your entire muscle is free for you to pull out. So here, then you take your traction sutures. You have to play around and see how this anatomy and the configuration of the rotator cuff is. So you can put, you have to put multiple traction sutures in different parts of the rotator cuff and pull and see. So one pull it will not come. You are talking about a muscle which has been attached, which you have elevated. So you have to pull and see where it is coming and how much it is coming. And when you are pulling, you need to definitely give it some traction time also. Here I am additionally adding the biceps because I know that tissue quality in these cases, chronic cases, is bad. So I am adding a biceps SCR. So you can see how I am doing the biceps. One suture I pass around the biceps. Then I come again and see I am keeping the suture in front of the bicep like that, penetrating exactly where it is entering so that the length is maintained. And then I am going to take a lasso loop around it. Like that. So this, after I have done it, I don't knot it. I have caught it, I kept it ready, the suture is ready. Then I release the long head of biceps and the bicep will go a little more down. So till now it is held together. So I don't need anybody to hold the biceps for me. So I call it as a bicep snatch because I am able to snatch it in position. So when this is done, the moment I cut it there, then I tighten this. So here I get the adequate tension, biceps correctly in the place. So biceps is in place. I also have extra length of the biceps also to play around here. Then after this, the same biceps SCR sutures you pass through the cuff and start. I normally use a triple loaded tape anchor in the front, triple tape anchor posteriorly, and then muscle easily comes down. You can see beautiful, brilliant approximation. It is a beautiful surgery. Takes you maximum 10-15 minutes more to do. You don't have to take any graft from anywhere. It doesn't cost you anything. Number of anchors is less. So muscle slide is really something which you can do. So you can see a beautiful repair. And we had 21 patients, 3 lost to follow-up. Study period of 6 months. So this is our inclusion criteria. This is exclusion, and this is our functional outcomes. So you can see the scores. Results, you can see how our forward flexion, abduction, excitation has improved over a period of time. My main concern here was only one thing. So we had this particular patient, we did a complete release. Whenever, what I've noticed is whenever there is a external rotation lag is positive, and even if the infraspinatus is repairable, infraspinatus sometimes according to scan could be intact. So even if infraspinatus is intact, sometimes external lag would be positive. That is because of chronic fatty infiltration there and chronic atrophy. In those kind of scenarios, it doesn't work. That means I had a patient who had a complete, so the patient was not responding, about 90 degrees she was not lifting. So I did a repeat MRI. MRI showed a complete healing, beautiful healing of the entire cuff. Patient still not lifting. So when I look back on literature, it is the same principle. When the posterior postcoppal is not that good, excitation lag is positive, it doesn't work according to me. According to Ashish Gupta, he says that it doesn't matter in his hand the excitation lag is okay, even that is reversed. But when you look at other literature, so I dug up all the literature which is available. So definitely there is enough evidence to say that I disagree with Ashish on that. Okay, whenever that when there is excitation lag positive, posterior force couple is not acting, this might not give you brilliant results. In all the other patients, they're extremely good. Full range, power is, takes little time, like around 6 months for them to develop the full power. So you get at least 4 plus power you get in most of the patients. So this is the muscle slide. So I would really advise the muscle slide. Now this is what I was talking about. This is Mariha's 2025 paper which you should all read out. You can see how the rhombus and the supraspinatus are attached. We saw that there's a fascia in between and he releases that and they do a complete repair, and his very low retear, you can see 6.3% is a beautiful retear rate. So excellent results. So as muscle slide is something which all of us should know and is going to really help us in practice. It's not very difficult to do, it's pretty simple to do. Thank you.
What position you do in lateral only?
Yeah, absolutely.
So sometimes these short females, it's very difficult to have that medial water of scapula exposed in lateral position.
You can easily expose. Okay, so my post which I normally keep is one is on the pelvis and the other is little more up below the scapula. So you can definitely keep it.
And as you said, you don't get, if you have that extensor lag, then what is the backup procedure for getting that?
I don't do it because I went ahead because the literature support was there that even exhortation lag you can do. But from my experience, I don't think we should take any literature by the way it is given. We should have our own experience on the literature. So my experience is that in exhortation lag doesn't work. So I don't do it. I would do a lower trunk. And if the patient is above 60 years, definitely RSA is my answer. So then when you look at, so what to add on to what you were saying, Prashant was saying, so muscle transfers, so LD versus LT. LD is for lat dorsal is for excitation 2 and LT is for excitation 1. So that only they give good results. I would do a lower trunk in this kind of scenario where excitation lag is there and even younger patient.
At what point do you, in the surgery, do you decide that this patient will need a muscle slide and it will not come conventionally during the surgery? Because many times we see the cuff is...
Yeah, you're right. So you would know immediately after you do the intercapsular release, the capsular release, and you utilize it immediately. Within 10 minutes, 15 minutes you will know it. But preoperatively, chronic, see, the most important thing is the history of the patient. Chronic history with the retraction, acute dissipation is followed like 1 month. Muscle is flipped, we know we can repair it. But if it's a chronic history, 6 months, 1 year history, and MRI showing irreparability, then I would do it first. Because what happens is, if you try to do a slide later, the water flows in, saline flows in, you see the tissues a little difficult. So I do it off first time itself, the slide. And intraoperatively I will take a call after the intra-articular releases and the visualization.
So does this reverse pseudoparalysis?
Sorry?
Does this reverse pseudoparalysis?
Yes, it depends upon, see, most of my patients in this chronic tears have a forward elevation of like 16 degrees, 7 degrees. That falls into the category of pseudoparalysis. It does release, but only thing in exhortation lag doesn't release.
So indications wise, if we have to just summarize it, right? So someone with an irreparable cuff tear or a massive cuff tear which is not completely coming easily, then the fat infiltration should not be more than 3 or 4.
4 is maximum. So now, see, even 4, act done for 4. It works very well for 4. The question you would ask me, like, why does it act for 4? So it works like an SCR. You depress it and the deltoid function happens.
Also, Dr. Ashish says that what we are seeing the scans, we are not seeing medial enough.
That's okay. So we do that. We 3 centimeters.
We go 3 centimeters below, beyond, and then see.
We achieve that.
Correct. Yeah. So according to me, fatty infiltration is not a criteria. So I would say that anterior posterior force couple should be intact. Tendon length should be minimum 1.5 centimeter. There should not be any glenohumeral arthritis. Fatty infiltration is not a criteria for me. Only these 3 are there.
Also the quality of tendon, not just the length, because a lot of times you see.
So the quality of tendon also doesn't matter to me because I'm adding the biceps. And last week I had a case where I did biceps, slide, and a regenerative. Sure. Thank you. Abduction external sir. Abduction external for 6 weeks. Because the idea is like we have elevated it. Now the muscle has to heal back to this position. So if you give tension like this, the muscle will come off. So it has to heal back.
Thank you so much. We break for tea. Maybe is it? Just one last session, maybe a couple of cases for panelists, and I will wrap up with the
Peanut.
हमारी सेफ्टी जो वो बाइसेप्स लिटरली फिजिकली अगर
इसको इंफ्रा भी नहीं है आगे ना very good.
Then otherwise people faculty करायचं आहे अगोदर विषय.
Before we start with the panel, let me invite Dr. Sandeep Biraris, past president of IAS. Sir. Okay. Please, Dr. Prashant Mishram, Dr. Sandeep Biraris will be giving a memento to Dr. Prashant Mishram.
Boss, I think as this is a shoulder course, I would like to invite Dr. Ayappan Nair, also is a SEC secretary. Yes, please come here.
Dr. Ayappan Nair, Dr. Naved Ahmed as well on the dais, please. Sir.
थोड़ा ऑफ सेंटर to hand over to Dr. Naved Ahmed. Ayappan Nair.
Let's have a very short panel discussion, a couple of cases maybe.
Sir.
Okay, yeah. So, Dr. Ayappan Nair, please. Dr. Naved.
We have a
Yeah.
like 7:30.
Yours is actually you're also giving. Okay. Fair enough. No worries. Yeah. So let's have a faculty photo first. एक फोटो घेऊया आणि
everyone please join.
Faculty, delegates, everyone.
Sir, osteocare also, please come. Come, sir. सबका फोटो एक ले लेते हैं.
Banning the सब two more chairs. कैसा पहले वीडियो के लिए स्माइल एवरीवन या फोटोग्राफ ले बात में यहाँ से लेता आप यहाँ से पीछे आ जाओ
सर पीछे आ जाइए.
थोड़ा सा पीछे से ले बस वीडियो एवरीवन स्माइल सर आराम से ज़्यादा भी मारो या look yeah smile everyone yes one more yes perfect thank you
So, one last couple. Dr. Nemade on the dais, please, with the panelists. Please, Sarji.
एक देखा तो दूसरा नहीं देखा.
Okay. You can start, Aditya.
Okay. So, at the end of a long day, so the first case, it's an 18-year-old male. He's a kabaddi player. He had a shoulder dislocation 2 months ago while playing kabaddi. Self-reduced on the field. Took no treatment after that. He has had multiple episodes over the past 2 months since the index dislocation, all self-reduced. He's not taken any treatment. And clinically, he has no tenderness, he has a full range, obviously apprehension is positive and his cuff is good. These are his exam videos. He's not hyperlaxed. He has a full range. These are his x-rays. So the x-ray is showing this. I don't know how clearly this is visible. But in this view, you can see a small piece here, a bony flake. So it's in the inferior axillary pouch basically. So X-rays just gave us this view. Otherwise, everything else looked okay. So we got a CT. So this is MR, sorry. Just run through this again.
What's the take of panel on further evaluation in an 18-year boy with a first time, well, this is a case of recurrent dislocation, but first time dislocator.
First
How
time
many of you will
dislocator,
decide
18-year-old
about
kabaddi
further
player.
investigation?
So I showed the MRI because I thought this was a thing that was obviously needed. So this is what the picture is.
How old was the injury?
2 months. 2 months.
MRI both. CT and MRI definitely both.
And if he would have been 28 years old, the same,
Yeah, same.
still you will do on the first time dislocator, you will still advise with the first dislocation.
Because on the X-ray there is a bony flake.
Okay.
So that is 100% going to re-dislocate. Otherwise, if it's a non-fracture thing, I always conserve first time dislocator, never operate.
And in this particular scenario, the patient has already had multiple dislocations in a very short period of
So
time.
in a short period of time, he has had multiple dislocations.
Suggestive of aggregate.
Even if it is no bony detachment, I would like to convey the information to the patient that in the first 2 decades, if the dislocation occurs, the dislocation rate is as high as 80 to 90%. So whether you want to wait for second dislocation or whether we want to get it right away with the labral repair, especially when the labral quality is good after fall, that is the question that the patient needs to answer.
So my question was, say it's a 28-year-old, like Dr. Sandeep sir said, it's a 28-year-old first time dislocation. Do we go ahead with the MRI? In my practice, I usually go ahead because I want to know, because I am not sure on an X-ray if there's going to be a small bony flake somewhere. An X-ray is not always going to tell me. X-ray is not going to tell me if there's a glenoid rim fracture undisplaced.
Usually these patients are presenting like this only.
Yeah.
A normal dislocation would, unless the patient does again similar movements immediately, he won't re-dislocate. The trauma itself is so painful that they keep their arm in the arm pouch. But if it's a bony fracture or a bony Bernard, 100%, even if it's reduced, it will keep on dislocating within the next couple of weeks.
Okay.
In our country, MRI availability is not an issue, cost is also not an issue.
Yeah.
So I don't think so there is any harm in doing a non-invasive. Those countries who call them developed, they have some issues with the MRI, and then there the question arises. In our country, non-invasive investigation like that, I don't think so there is any problem in doing it.
I think it is better you advise the MRI, okay? Because if you don't advise, then it can be a problem in the future because you have omitted that. So yeah, I would definitely advise to do an MRI scan.
I do the same thing. MRI after first episode, the patient, MRI is a must for me.
Definitely MRI and CT is a must. The incidence of associated rotator cuff tears, even if it is in a young patient, is like around 10-12%. If you miss that, then it could be a pasta, could be a significant rotator cuff tear also important.
Yes.
And here again, kabaddi player, athlete, professional athlete. So he requires surgery 100%.
Sir, anyone would like to comment on the source of the bone fragment on this?
That anterior
glenoid.
Yeah.
Called along with the cartilage.
Along with the cartilage. It's an osteoperiostral.
Yes. So these are further sagittal and coronal images, again MR. So this is the CT finding. A radiologist friend has written on paper of 30 to 40% bone loss.
It is not actually that much because it's just a cartilage piece which has gone
It's a
down.
cartilage flap sort of a piece which has really gone away in the axillary pouch.
Whether it's a bony Bernard or just a osteochondral injury that we need to see. It might be that it is just an osteochondral injury, but the limb is staying.
Very true. And then again, depends upon what is the method of calculation the CT. When we did an evaluation different study, there are different methods. Percentage circle line method, Sugai method, Pico method. Sugai method is the most accurate So even 1 millimeter will change percentage like crazy. So that's why CT is very important.
If you see the location of this bony bankard, if you see the X-ray, is falling into the glenoid pouch like a free fallen leaf.
Yes.
So that suggests that it's a free fragment and not a bony like a labral osteolabral fragment.
Yeah. Looking at this image, sorry. If you look here, I can't see any labrum here. I can make out the posterior labrum. I don't really make out any labral attachment over here. So, based on these images, sir, what would be your plan of action? Is it, I think conservative is out. I don't think this can be conserved. I don't think anyone believes this can be conserved. So, what would be the plan? A bankard, a remplissage plus bankard, which there's no real hill sacks, frankly, a letarge or a bone block procedure, or any other treatment modality.
So basically, for me, when on doing the diagnostic round, we'll have to assess that how big that cut. First of all, we have to counsel him pre of that cartilage piece might be free, devoid of any attachments, potentially avascular, might have to just excise it, and I would advance my bankard repair to the remaining cartilage to make it extra-articular, the defect extra-articular. If at all it is fixable, there are certain videos available where, because it's a free piece, then you will have to fix it through the repair with two separate anchors, pressing knotless anchors, pressing the entire cartilage down with a tape in between, something like that. But it is not from anteroposterior, it is from superior to inferior, from 3 to 6, most likely. So seems to be a difficult thing to fix it back. Most likely I will do a formal bankard repair with advancing the labrum over the defect and excise that piece.
Almost same, just that I would not sweat too much into advancing it to the cartilaginous region and making it extra articular, because for the reason that we know that if we advance it too much medially, the stresses on the repair is too much and they are more likely to fail. That anteroinferior portion with respect to the cartilage void, I don't think so will be much of an issue.
3 to 6.
Yeah, but it is just a strip, anterior strip, will be filled with the fibrocartilage. So I would be still want to go as it is the bankard repair, like we do normally do. I will not sweat too much onto the cartilaginous lost strip.
Okay.
However, always will explain the patient that shall I find on arthroscopy that it's a pear-shaped glenoid or something like that, then maybe a letarge will be on the.
So again, I would add to the fact that you need to understand that whether that first thing is, once you enter the joint, you see and you do a diagnostic scopy, you'll understand what kind of fragment it is, how much of loss is there, and if it's a free fragment, then there's an issue with that. If it's attached to your labrum, obviously then you can do a double row kind of a repair, as you were saying. I think because of the instability, the kind of instability that you are mentioning, the labrum, I feel, has to be attached to that particular thing. And he wants to play kabaddi. Yeah, so you need to get back. If it's a huge fragment and a very thin fragment, obviously you know that you will not be able to fix it, and then you have to consider some kind of a boning procedure for that.
My take would be very different here because, as you said, the most important thing which is stressing again and again is kabaddi play. Professional contact athlete. I will do a letarge. Letarge with, I look at the cartilage, I do a BMAC along with it. So to just see if there is a cartilage defect, fill it up. This would be, if I would have changed it, for example, if it was a bony bankard, without a fallen piece, is still attached, then bony bankard has excellent results. So 100% healing rates, 0% according to Sugaya's techniques, okay, 0% failure rate. So that, here it is very different. Bone is gone, there is completely gone away, kabaddi player, contact athlete, letarge with cartilage.
But here we don't have a bone loss per se loss, it's just a cartilage loss. Okay?
Contact athletes. IC score goes above 3. So it goes like 4 or 5. So then automatically, professional athlete, contact athlete, primary bankard will fail, higher failure chances. So if he, for example, was
into non-contact, basically table tennis, I would have done maybe a repair if it is, but here definitely I would do that primarily attached.
You won't keep the options open. You will just decide pre-op and just go ahead and.
So you will put a scope in or directly open Latache?
I always do an arthroscopic Latache, so I would definitely scope in, right? And 100% do a remplissage if there is a hill-sage. I could not appreciate a
There is no
hill-sage. So then you go directly with a dressing and a capsular repair in top.
So just because the patient is young and is a player, that's the sole reason that you want to do it with the Latache?
Yes. Otherwise, if it was, for example, the table tennis player, non-contact athlete, then I would look at the bone loss and then take a call. But here is a contact athlete will change everything because it's.
So what is your percentage like? Do you have any percentage in mind or a dislocation with no bony loss, but a kabaddi player?
Primary rugby player, kabaddi player, those kind of people who are into extreme martial arts, gymnasts. If you don't do it with its failure chances, we are almost sure that it will dislocate in time.
So this was the picture once we went in.
So column 3 please.
So it's a video. The labrum is attached to the inferior aspect of the face. It's not a very clear screen. There's a raw bony time from 3 to 6 o'clock. Like what do you see? This is how it looked to reduce it for 1 month. So, does the plan change now for you, sir, especially? Latache. Sir?
Yeah, for a contact sport athlete, Latache is a better bet.
I think so. So I always kept that Latache stand by, but yes. But I want to see the labral condition though. Means I'm not able to show. Because the fragment is attached distally here.
Yeah.
It's free here. My contention, my evaluation on the MRI would be that the labrum is just there in place.
Yeah.
But pay 2 night. So do you have any video showing where the labrum is?
The labrum is attached all across the fragment.
All across the fragment?
Yes.
So the labrum can completely cut in the fragment.
A cartilage piece with a flake of bone along with the labrum has fallen in. Yeah, that is
based on a inferior hinge.
Yes.
Yeah. So and then it's very difficult to heal this labrum because this fragment is not going to heal.
Okay. So I went on a slightly different route. So I proceeded with the repair.
For bony banker.
Bony banker. So for lack of time, is it okay if I just run through? Okay. So did 3 anchors.
So you would have exercised that piece, but I.
No. Sorry.
You would have exercised that. I would have, because it will not stay. There's no way of retaining it. And if it after doing it, I'll see if the capsule is covering it. But if the capsule is not covering, I would have to attach it, then do a BMAC. You have medialized the labrum.
Yeah, I have medialized the labrum.
The labrum mean to say the bony piece because it was attached to the bony piece.
Yeah. So it was attached? Yes.
Those injuries with the labrum they do not sometimes they have the capsule.
Yes. He did not have that. Luckily, he did not have that. Probably because it was not that long post-injury. Maybe if he would have waited for longer, that would have been the case. So 3 anchor repair, went medialized the anchors onto the base of the glenoid, went around the bone piece, capsule and the labrum.
There was I felt there was a split in the posterior inferior labrum as well. So there was a capsule application which was also done.
How sturdy is your fragment? Okay, after it?
It's still there. There's one more anchor which will be going in after this. It was stable. The repair was stable at the end of it all.
I think if there is there should be osteocontrol, and if there's still some bone on the undersurface, then some healing can happen. And if you hold on to the rehab for some time, it will kind of heal. Even if slightly maldonated, it will heal. But it's important to have that. You should not be just cartilage. Some bone has to be there.
Yes, sir.
Then this is a single row repair, right?
Yes, single row.
So in the single row repair, the fragment still will be kind of as a mobility like that. Only when you want to like a typical ORIF, we want a double row repair where you top the fragment down and make it upright. This is like co-opted to the surface.
So I've asked him to get a CT. The patient lives in a village, he does not really come for follow-up. Even his follow-up video was on the phone. So we asked him for a CT. That is what will tell us what is happening inside. But he is almost 5 months post-op now. 5.5 months post-op.
It looks pretty good. It looks nice. The way of it looks very nice.
It's excellent.
The tie down is very good.
So all that was discussed basically with the patient. He has been counseled that there is a chance of failure, there is a chance of redislocation, and he has been told it is going to take some time for him to return to kabaddi. So this was, he's around 5 months, 5.5 months post-op. So this was the final repair. Post-operative X-ray, that fragment is not seen. I have not excised the fragment. The fragment is not seen. It is fallen back in place. This is clinical video. And like I said, he has not come for follow-up for the last couple of months. And management is on the phone. He has achieved his full range. Not really having any problems. It's not returned to sports as of now. Do we proceed? Do we call it a day? Nilesh sir, do we proceed? Do we call it a day?
We have a question from.
Yes.
Yeah, please.
Sir, according to your timeline, 5.5 months. So, from now, by what time you want to start the rehab for the sports-specific rehabilitation?
Sports-specific,
yeah.
Ideally should be started around this time.
Yes.
Around 5 to
with
6
this
months.
repair, and you know he wants to go back. So now, what is your timeline you want?
So another couple of months, maybe 3 months. Not before. Go slow with him. Go slow with him.
Whatever will happen, will happen. So I think if you don't mobilize him and go aggressive, he will lose his sporting life. Let if it dislocate, let it dislocate. So go in for a lateral. So the 3 months I would do a regular rehab, passive movement, active assisted for till 6 weeks, 6 weeks to 12 weeks strengthening, full range by 3 months. The 3rd month on sport specific rehab, 6 months return to sport.
Okay.
The best part of the Lancard is that it's so physiological this thing. So when it fails, he just the next set is just like news.
But the patient has to be counseled properly.
Yeah,
yes, that this is what may happen.
Yes.
It may fail. It may need a research.
Average recurrence timeline is 3 years.
Yeah. Thank you everyone. Thank you the listeners.
Thank you. Thank you Aditya, thank you for that. As we come to the end of it, I would like Dr. Ayyappan Nair to do the honors of presenting the memento to Dr. Aditya Danjotikar. Aditya, please. Dr. Vilas Salve to present a memento to Dr. Pradeep Nemade.
काफी बड़े बाकी
wait, Nitin sir. Okay, done.
Sir, just a couple of momentous. Dr. Ayappan Nair to present to Dr. Abhishek Neruttar. Dr. Rahul Dowry. Dr. Jahangir Pashtonji. Dr. Vilas Sadhu, Dr. Sanjay Singh.
Sir, excuse sir.
Dr. Vaibhav Kohli. We have come to the end of it. I deeply thank all the faculties who have taken out time on this Sunday. And please, Nimade sir, please take that hat home. I really. So let me thank everybody out here, Dr. Ayappan Nair, Dr. Naved who has just left, Dr. Prashant Mishram, Dr. Sandeep Piraris, Aditya, Vaibhav, Dr. Nemade, Abhishek, Sanjay, Vilas sir, everybody. I hope I am not missing on anybody, Dr. Jahangir, everybody. Last but not the least, I want to thank the Osteocare family, Mr. Nisarg Shah, Mr. Vishal Talwar for making this happen. Thank you so much. I will be indebted to IAS for giving me this opportunity, Sandeep Bhau as well. And I also thank the NMOA to say yes to become a part of it. It's been really very good. Thank you so much. Thank you. I hope things have gone well. Sir, and Hardik, thank you so much. I keep on forgetting your name. Maya, thank you so much for bearing with us. I didn't get your name. Thank you so much. Yeah, please, sir. The Osteocare team can come up, please. Shubham. Surya. They have been working here since yesterday, late evening itself, pushing a lot of coffee down their throats.
Sir. Yeah, look here, yes. One more. Thank you.
It's a lots of effort that Nilesh sir has put behind to execute this event, and for a small thing he has taken care. He was literally behind to make this event very much in a perfect manner. So I really appreciate the dedication, the time which is devoting. I know at at late evening he also respond to for like small correction for each and everything. So he's very meticulous and he just make this event to be in a perfect manner. I really thank Dr. Sandeep sir, who has given us opportunity 1 year back, and he allowed us to be a part of this IAS One event, IAS family, and for all the events, for all the places, we always get the immediate sanction from his side. So we really, as the Osteocare family, we really thank IAS family, especially to you, for giving us this opportunity, and for any kind of academic feast, Osteocare is always be a part, will always be available. Everyone is good.
Osteocare has been always supportive in all the events, and now immediately next week they are ready to not directly Kerala.
Thank you so much.
We will have a workshop if any wants to.
Delegates. Yeah, you can have there's a simulation machine out there, so you can try your hands on.
એમને પૂછો કાઢું હા સર કાઢું કે પૂછો એમને મશીન અરે ઓલું મશીનનું વર્કશોપ બતાવ્યું તો એ લેવું છે જાવું કે નહીં કોણે કીધું એ જ છે અહીંયાથી જ બતાવું ને પણ તારે જવું છે શું કરવા નહીં અહીંયાથી